Good morning, everyone. Good morning. People are having too much fun. We need to just stop this fun that you're having and get to the public hearing. Thank you so much. Good morning, everyone. We will call or convene our public hearing for Wednesday, March 13th, 2024 to order. And we just had a few things that we want to remind people. Please look at the exit from this room. If you don't like a testimony, you can exit for a little bit and then come back. And if you also have just we'll give 3 minutes for people to be able to speak, and after that, if there are questions, we will try to have us ask those questions. Keep your answers short. We wanted to thank everybody for being here, but also thank each and every one of the Public Health Committee members who are online and in person over here, but our team with our administrator and also our LCOs, our Office of Legislative Research, the people who have been working behind the scenes on these bills, and the people who have proposed them. We want to thank each and every one for that. And I also wanted to make a quick little announcement. There was a tentative meeting that was scheduled for Public Health Committee for Friday, March 15th. That has been canceled. We will address all the other issues. We had enough times that we had set up for some of the other committee meetings, but we wanted to inform people that we are canceling that meeting. And with that, I'm going to ask my honorable co-chair for remarks.
Thank you, Senator Anwar. Back to the squeaky mic. It's wonderful to see so many of you here today. I will remind folks that we ask folks to testify within their 3-minute limit. We have over 70 people signed up today, and we want to be able to hear from all of you. So I just remind both members and members of the public of that as well. Thank you so much, Senator.
And Representative Claire Desdieter.
Thank you, Mr. Chair. Good morning, everybody. Thank you for being here. Looking forward to some great conversation. Thank you.
I do not see Senator Summers on. She'll be here in a little bit. Just so that everybody's aware, this is probably one of the busiest days in this busiest week. We have everybody on 2 or 3 or even 4 meetings at the same time. So you'll see people come in and out, but we are listening to you, and we'll be listening to each and every one of the testimonies and reading them as well. And also we wanted to remind individuals who are online that you will get a request to be promoted to be a panelist. Please accept that, because only when you accept that, you will be able to testify. That's another reminder we had. And with that, we will see if our first speaker on the list is Representative Reyes is not here. I don't see him on the screen. And I see number 2, Murad Painter. Welcome.
Good morning, Senator Anwar, Representative McCarthy Vahey, Senator Summers, and Representative Claire Desdieter, and distinguished members of the Public Health Committee. I'm Murad Painter, the State Long-Term Care Ombudsman, and I'm happy to offer you testimony today on SB 275 and SB 273. SB 275, an act prohibiting nursing homes from rejecting a patient solely on the basis that such patient receives mental health services. I support this bill as it protects the rights and access for care for individuals with a history of receiving mental health services. Mental health is a critical component of overall health, yet individuals who receive mental health services often face unjust and discrimination, as well as barriers to seeking long-term care. This discrimination not only violates the basic rights of these individuals, but also perpetuates the stigma surrounding mental health, discouraging people from seeking the support that they need. Furthermore, the bill recognizes the importance of comprehensive care, acknowledging that individuals with a history of engaging with mental health services can, with appropriate support, thrive in long-term care environments. It encourages skilled nursing facilities to adopt a more inclusive set of policies and practices to accommodate the diverse needs of all residents, thereby improving the quality of care and quality of life for everyone in their care. SB 273, an act concerning nursing home staffing. The nexus between nursing home staffing levels and the quality of care in nursing homes is well documented and undeniable. Residents in facilities with poor staffing ratios experience a myriad of negative outcomes, including increased risk of neglect, delayed response to their needs, and overall lower quality of life. The testimony of countless residents and studies underscores the daily impact of insufficient staffing, from prolonged wait for assistance to missed medications and activities, painting a clear picture of the urgent need for reform. The bill addresses these pressing issues by establishing staffing requirements that are essential for providing quality person-centered care. We recognize that the nursing industry faces workforce challenges, but we believe these need to be taken head on. We've also seen an improvement in the ability for some facilities to hire new staff when providing a positive work environment, where care team members are paid an appropriate wage. And with the trust and respect that they are given, they then give this to their residents and return to skilled nursing facilities. Those nursing homes are not experiencing the same challenges related to staffing. It is also about direct care to residents and the care team members that are working on the units and interacting with residents related to their activities of daily living. This legislation acknowledges the complexity of the workforce concerns, but also asserts that the status quo, which compromises residents' care and safety, is unacceptable and requires immediate action. The bill addresses clinical aspects of staffing and the need to identify that the direct care doesn't count. Excuse me, the director of nursing and assistant director of nursing in buildings of certain sizes, as well as any.
Your name is Painter, but your time is up. Thank you.
Thank you.
Thank you. I did have a question. Thank you so much for your testimony and thank you for the work that you do. Tell us, in your experience prior to this bill, how have people been using the ratios or and the staffing ratios that we have put into legislation in the past and mixing it up with non-direct care individuals?
That's a challenging question because we often don't see the correct postings. It's a requirement that the staff breakdown is posted at the front of every building and accessible to any resident as well as family member and the public. And it is supposed to say how many direct care nurses and CNAs are working on each unit. However, often when we go in, it hasn't been updated. It is the proposed staffing, not the actual. Or the person has gone out, maybe there's a CNA who is out on transportation, assisting a resident, or isn't licensed yet and is shadowing, or is there and hasn't been fully educated on the needs of the residents. As well as in nursing, we see nurses who may be working in the office, the director of nursing, assistant director of nursing, or other individuals providing nursing services in the building, but not direct care related to activities of daily living.
And so do you feel that the direct care definition and clarity is going to help us move in the right or a better direction?
Absolutely. I think it'll make a big difference, not only related to the hands-on care individuals receive and the accountability that we can provide them with, but also in understanding the financial structures in the building and understanding what's being paid for under what categories.
Thank you so much. And if you wanted to complete your last sentence that you were about to complete in the testimony, you're welcome to do so.
I close it. I was just going to thank you all and say that this is an incredibly important issue that we deal with on a daily basis. These are complaints that we receive every day related to, in some buildings, the lack of accessibility to direct care.
Perfect. Thank you so much. Seeing no questions or comments, we thank you for your testimony.
Thank you very much.
The next person on our list is Jean Mills Arana, but we do not. Oh, you're welcome. You're on.
Thank you very much. My name is Jean Mills Arana, and I'm a volunteer attorney with Connecticut Legal Services, where I practiced elder law before my retirement. I served on the Governor's Nursing Home and Assisted Living Oversight Working Group and on its staffing level subcommittee. On behalf of Connecticut's legal aid programs and our low-income elderly clients, who include residents of nursing homes, I'm submitting my testimony in support of Senate Bill 273, an act concerning nursing home staffing. Connecticut's nursing home population suffered greatly during the COVID-19 pandemic. While the pandemic laid bare many deficiencies in care in nursing homes, it did not create all of them. nor has the easing of the pandemic cured such deficiencies. In 2021, the legislature raised the number of hours of direct care nursing home staff per resident per day from the 1.9 hours previously required to 3 hours per resident per day. Senate Bill 273 establishes minimum staffing level requirements for nurses and nurses' aides to make up these hours. It also adds a definition of direct care that clarifies the activities eligible to be counted towards these ratios and clarifies what staff cannot be considered. These provisions will improve quality of care and make an urgently needed positive difference in the lives of residents of nursing homes. The Department of Public Health issued regulations to implement these standards last year. After comments and a public hearing, the regulations were unfortunately withdrawn by the department. Without adequate standards for nurses as well as nurses' aides that the regulations required, the care of nursing home residents is at risk. Inadequate staffing in nursing homes is a longstanding problem. Senate Bill 273 unfortunately does not increase the total numbers of care to be provided. Importantly, however, it requires specific amounts of time by registered nurses, licensed practical nurses, and nurses' aides to make up the 3 hours of daily direct care provided. It's important that trained nurses are available as well as nurses' aides to properly care for all residents. My written testimony cites 2 studies supporting this fact. Finally, Senate Bill 273 also implements a change to the number of therapeutic recreational staff in long-term care facilities. The working group found that the ratio of residents to these staff should be lower, but unfortunately, in the drafting of Public Act 21-185, the working group's recommendation for a lower ratio of residents to recreational staff was mistakenly drafted as a lower number of recreational staff, and Senate Bill 273 corrects this error. Thank you for your concern for vulnerable nursing home residents. We urge the passage of this bill to protect and care for them.
Thank you so much, Ms. Arana, for your testimony and being within time, but also being very clear where you stand. We appreciate you, and thank you for volunteering for our community members. Thank you.
Thank you.
Seeing no questions or comments, we'll move on to the next person on our list, which is Mr. Scott Weber. Welcome.
Welcome. Thank you. My name is Scott Weber, Executive Director, Regulatory Affairs and Compliance with the American Red Cross. And thank you for the opportunity to provide testimony in support of SB 368, an act concerning source plasma donation centers with amendments. Though the Red Cross does not collect source plasma, we support an amendment to SB 368 that is important for blood collection facilities. The amendment proposes to do 2 things. 1, remove language that requires a licensed nurse to be on site during hours of operation of a blood collection facility. And 2, add language that provides for qualified, non-licensed staff to perform apheresis procedures for collection of blood intended for transfusion. The current Connecticut requirements impose a significant and unmanageable burden that creates barriers for blood collection facilities to operate within the state. Rather than expanding operations to meet the increasing demand for blood products, the current requirements are having the opposite effect due to this nationwide shortage of nurses and the ability to fill the roles required by the regulations. The Red Cross is a national organization with an ongoing commitment to donor safety. We safely collect blood and blood products throughout the United States using well-trained, highly skilled, non-licensed staff to perform whole blood and apheresis collection procedures. It's important to note that no other state requires licensed nurses to perform apheresis blood collection procedures for transfusion, nor requires a licensed nurse to be on site during hours of operation. Both requirements are more burdensome than FDA regulations and AABB's industry standards and are limiting blood collections within the state. The Red Cross remains in compliance with national as well as state regulations that ensure the safety of our donors and patients in need of blood. Ongoing oversight by FDA, AABB, and states demonstrate that we are consistently meeting this objective. We also advocate for alignment with FDA regulations to create an even playing field from state to state. For the last 2.5 years, we have been actively engaged with and supportive of the Department of Public Health in their efforts to ensuring the safety of donors as they update regulations consistent with those of FDA. We appreciate that shared interest in this objective. Support for this amendment, which is detailed in my written testimony, is consistent with that objective and allows for the collection of adequate supplies of blood in the state. And my testimony is an addition and supplemental to written testimony by Dr. Faye West, who's our medical director in Connecticut, and our labor partner and AFSCME president, Joe Tyne. It's also in addition to testimony later in the agenda by Richard Brannigan. So thank you very much.
Thank you so much for your testimony. We say that third time is a charm. We are back again at the Plasma Center bill for the third time. We hopefully will. We will thank you for your testimony, and then what we will do is we will also have my esteemed colleague, my co-chair, Nick.
Thank you very much for your testimony. Thank you, Mr. Chair. Mr. Weber, I know it was the addition of the nurse requirement from this committee last year that has caused difficulty for the Red Cross. Is that correct?
That is correct.
And I just wanted to reiterate, in your testimony, you shared that no other state requires the RN requirement as we did in last year's bill. Is that correct?
That's correct. I can qualify that. You know, the state of California did have a regulation that required nurses to be on site 2 or 3 years ago. They revised that legislation and now have gone to require either on-site or remote nurses via telehealth. Also in New Jersey, they have a requirement for an on-site nurse, but they routinely waive it. And so year after year, we submit for a waiver and receive that waiver. And it's my understanding that they're working with their legislature to try to resolve that.
Thank you. And speaking of waivers, I wanted to just be sure that the committee and others were aware you did submit for a waiver through the Department of Public Health for that requirement. Is that correct?
That is correct.
And you did not receive the waiver.
Those waivers were denied.
And as a result, what was the result of the denial of the waiver?
Well, the result is we've had to dial back operations in our blood centers. And, you know, without relief, it will likely cause us to dial back even further and even shut down certain locations and maybe operations within the state. The effect could be quite severe.
So I bring all this forward because both you and the Department of Public Health are seeking to comply with statute. And in complying with statute, you are now finding yourselves in the situation where you may not be able to collect blood for from the residents of Connecticut and for the residents of Connecticut.
That is correct.
Okay. I just wanted to make sure that we were all on the same page with that and understand the urgency of amending this language in a way that would allow us to continue blood collection at the levels that we need to do so. Thank you, Mr. Chair.
Thank you, Madam Co-Chair. We have Representative Claire Desditra, who has a question or comment.
Thank you, Mr. Chair. Thank you, Mr. Weber, for your testimony today. Do you, you had mentioned that the American Red Cross applied for the waiver through Department of Public Health and they were denied. Did they give you a reason why they denied your waiver?
They felt, given the legislative directive to require nurses on site, that they couldn't take that lightly, and felt that they would be setting a precedent that would be hard to defend going forward. So they're taking their direction from the legislature and the statutes.
Okay, that's I'm finding that odd. Why would we have a process of applying for a waiver if they're not granting waivers because the legislature said we should, but then they said they're following what we said and we shouldn't, if anybody understood what I said. So which is politics and the legislature every single day, if most of you don't understand. But why do you think that waivers aren't a good form of public policy?
Well, if it creates administrative work for the Department of Health. And if the waivers are going to be routinely requested and approved, then what's the point to begin with? I know that we were working with the department, like I said, for a couple of years, trying to align regulations with those of FDA and AABB standards. And we were quite surprised, and I believe the Department of Health is quite surprised that the language regarding on-site nurses was added, late in the game in the last legislative session.
Okay, thank you. And just to reiterate what my co-chair, Representative McCarthy Vahey said, there's no other state that has the same requirements of a registered nurse or an APRN on site.
Not that's being enforced.
Okay, thank you. Thank you for your testimony. Thank you, Madam Chair.
You're welcome.
Thank you. I have Representative D'Amico who has a question or comment.
Thank you, Mr. Chair. Thank you, Madam Chair. So, Mr. Weber, thank you for coming and providing testimony. It's probably not a surprise to my colleagues on this committee that I am confused on this issue in particular and on many issues in general. So on this issue in particular, we have gone through this, last year, and now here we are this year. I don't know if it goes back any further than that. Perhaps it does. We had testimony last year that indicated that for safety reasons, it only makes sense to have a registered nurse on site, particularly with regards to apheresis collection, as opposed to run-of-the-mill blood donations. And so I, rather than ascribe this to politics, I think we have to ascribe it to health and safety, or at least that's what I would prefer to do. So I'm just going to read you, since we're talking about testimony today, I'm going to read you a couple of lines from the testimony from the Commissioner of the Department of Public Health, Commissioner Giuttani. She says that as drafted, Senate Bill 368 would require the department to revert our proposed regulations to just the federal requirements, sacrificing key components that would guarantee quality of care for the donors. She goes on to say that it's important to note that the federal requirements represent the bare minimum standards that the facilities need to uphold, and meeting the bare minimums established by the federal government does not give DPH the necessary assurances that we are doing our jobs. So I would like you to react to that, if you could.
Yes. Well, I would say that, it's a perspective that the FDA regulations represent minimum standards. There's also AABB standards. And I can assure you that the Red Cross, who's collecting nationwide, is doing so safely. And, we have the ultimate, care in mind for our donors as well as the patients who receive the blood. We have extensive training programs for all of our staff. They are highly skilled in what they do. They are trained in CPR and how to respond to any adverse events that may occur. And, we safely, if you look at a safety profile, for adverse reactions associated with donors, we find there's no difference between when nurses are on site and when they're not on site. In fact, we had some data from New Jersey that indicated that we had fewer adverse events, when there wasn't a nurse on site than when there was. I don't quite know how to, decipher that, but I think what it tells us is that there's no difference in the safety or the outcome of the collections when we have nurses on site and when we do not.
Well, would you agree that and again, I'm certainly far from an expert on this, but I go by what I read and what I am told by the people who do know something about this. Would you agree that the apheresis is a much more complicated and tricky procedure than just ordinary blood donation?
It is a more complicated procedure. However, the apheresis devices of today are highly automated. One of the most important aspects of apheresis is, getting the phlebotomy right, making sure that you have good flow, to the device and then from the device back to the donor. The procedures are very prescribed. They're prescribed by the programs, the actually software programs that run the apheresis devices, and they do require attention by the individuals performing those phlebotomies and performing those procedures. But as I had said before, we have highly skilled individuals that perform these on a daily basis and do so safely.
Right. If I may, just one or two more questions, Mr. Chair?
One sounds better. Yes.
Okay, okay. Well, I'll combine the two then, Mr. Chair. How's that? In view of the fact that the department declined to grant a waiver last year, and in view of the fact that the commissioner seems pretty strong in her testimony that Senate Bill 368 is not a good idea because of the reasons that we just discussed, would it not make more sense to just shelve this bill for now and let the Red Cross and the Department of Public Health and whatever other entities need to be consulted to try to work this out as we go along? Would that not make the most sense?
Not in my opinion. No, it wouldn't make the most sense, and it would put the Red Cross and other blood collectors really in a position of limbo and not knowing what to do and how to manage our business. As I said before, right now we've dialed back operations, and also in the commissioner's testimony, she did indicate that if this bill passed, that it should apply to blood collection facilities as well. So I think that's an indication that they support some aspects, maybe all aspects of this with conditions. I can't speak for them, because it was originally written for the purpose of source plasma donors or donations, but for the purposes of blood collection facilities, what I read is that she was supportive of it applying to that.
Thank you so much, Representative D'Amico. And then I just wanted to mention that the part of the bill that we are looking at actually came from the committee. It wasn't from the Public Health Committee. Sorry, it wasn't from the commissioner. It was from the Public Health Committee that we actually added the nurse part. But I do remember the commissioner speaking about the physician component and that part. And I think irrespective of what has happened, the reality is that Red Cross and many other facilities are unable to take care of the citizens of our state at this time with the current law the way it is. Is that a fair understanding, Mr. Weber?
Yes, it is.
So, and the changes that you have suggested are not going to have any harm to any of the citizens in the state, but allow them to be able to get the blood products that are necessary for life sustaining.
Yes, and we would be operating consistent with how we operate in every other state.
Okay. And I think that's the part. And we at times legislators say that there's a job security because we write a bill and then we improve the bill and then we continue to improve the bill. So this is going to be one of those areas that we'll be able to improve this, making sure that the people are safe and we can have Red Cross continue to function, because as we speak, there are people who are having transplants in our state, and there are people who are having surgeries across the different parts of the state, and they need blood. And that's a necessity. And use the example, you need oxygen, you need blood. You provide the blood, and we need to help you get that in a safe manner. So we appreciate your testimony. Seeing no other questions or comments, we'll move to the next person on our list.
Thank you very much.
Thank you. That is number 5. Which is Betsy Jett.
Good morning. I'm Betsy Jett, Senior Vice President for Quality and Regulatory Affairs at the New York Blood Center, and I want to thank you for the opportunity to offer testimony in support of SB 368 with amendments. We're a nonprofit organization providing blood products and services to hospitals throughout the state of Connecticut. In 2023, we distributed over 62,000 blood components for transfusion to Connecticut hospitals, including about 9,500 apheresis platelets. Yet we collected less than 5,000 units of whole blood and 0 platelets in the state. This means that the transfusion needs of your patients are being met primarily through the generosity of blood donors outside of Connecticut. New York Blood Center is strongly committed to providing blood for patients who need it. To that end, we urge you to reevaluate the restrictions placed on blood collection activities that prevent us from fulfilling our mission to the state. These restrictions include the need to have a physician or a physician substitute, including an RN, on site during collections, as well as the requirement for a physician or an RN to personally perform each apheresis procedure. It would have consumed almost 20,000 hours of a physician or RN time to collect the platelets that we distributed to Connecticut hospitals last year. In our view, diverting these highly skilled healthcare professionals from patient care activities is an irresponsible use of a precious resource that's already in short supply. New York Blood Center suggests amending the bill to 1, include blood collection facilities in the provision intended to harmonize state requirements for staffing with those of the federal government, and 2, replace the phrase registered nurse or advanced practice registered nurse with the phrase physician or physician substitute in the provision that eliminates the on-site presence requirement from the statute. This is the same terminology used and defined in the draft Connecticut regulations and in federal regulations. Alternatively, remove the sentence requiring on-site RN entirely and allow for a physician or physician substitute to be available on-site or remotely via two-way interactive telehealth while blood is being collected. These amendments would bring Connecticut in line with other states and the federal government without compromising the safety of blood donors. The specific wording edits we propose are included in our written testimony. And if I have a second, I'll just make one comment on the last discussion that as I read the commissioner's comments, they applied to the qualifications of a physician and the need for CPR trained staff on site, but they acknowledged the on-site presence of an RN was not necessary. Thank you.
Thank you so much for your testimony. And we wanted to thank the New York Blood Center Enterprises for providing blood products to the citizens of the state of Connecticut. And once we fix this bill, we will return the blood.
Thank you.
Is there any question or comment? Seeing none. Thank you so much for your testimony. We heard you loud and clear. Thank you. We appreciate your testimony. Next on the list is number 6, Mag Morelli. Welcome.
Thank you, Senator. My name is Mag Morelli, and I am the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services and including not-for-profit skilled nursing facilities. We thank you for this opportunity to testify regarding our concerns with Senate Bill 273, an act concerning nursing home staffing. We've also submitted testimony in favor of Senate Bill 275, and one of our members will be speaking on that bill later in the hearing. Regarding Senate Bill 273, in 2021, a new minimum nursing home staffing level of 3 hours of direct resident care was established by the legislature. Leading Age Connecticut supported and continues to support the statutory minimum staffing level. We share the state's goal to ensure Connecticut's older adults receive quality nursing home care and understand that maintaining appropriate staffing patterns is essential to achieving that goal. We object, however, to this particular proposal to create specific and separate ratios of staff based on licensure and certification status. The bill specifically asks for daily ratios of RNs, LPNs, and certified nursing aides time. While this proposal may be well-intentioned, we feel it is misguided because one staffing level does not meet all needs. It is contrary to the philosophy and intent of the state's newly implemented nursing home acuity system, as well as the public health code's requirement that a nursing home staff to meet the needs of the resident. In addition, the ratios will work against various high-quality nursing home staffing models that may rely upon a high level of licensed staff. And finally, the proposal will be costly as even well-staffed nursing homes may need to hire additional staff to meet the ratios, and the lack of flexibility within the ratios will expose quality well-staffed nursing homes to potentially costly penalties if they struggle to find coverage for last-minute staff absences. We ask that you take these concerns into consideration when reviewing this proposal, and we would argue that the disruption to the current staffing patterns of some of our highest quality nursing homes is not necessary and would be a distraction to the good work that is being put forth by our staff. We've submitted some detailed testimony on the bill, and we would just like to close by articulating our concern regarding the ability to recruit and retain an aging services workforce that can meet the needs and demands of our aging population. We ask that the state support efforts to enhance the long-term services and supports workforce through expanded training opportunities, increased funding for reimbursement rates, and other efforts aimed at attracting and retaining workforce talent within the field of aging services. I'm happy to respond to any of the questions that were asked previously of our ombudsman regarding the new statutory regulations, the new regulations that are being put in place to implement the 3.0 staffing level, as well as some of the posting staffing level concerns that the ombudsman voiced.
Thank you so much for your testimony. I had a question, but I think Representative Cook is going to ask possibly the same question. So Rep. Cook, you go ahead.
Senator, we may not ask the same question, so I'm happy to defer to you first.
Okay, thank you so much. The issue that you're talking about is if you listen to the people and the ombudsman, the long-term care ombudsman, we have a problem. The patients are not getting the care. And you will hear during the course of our meeting today that people in our state in the nursing homes are not getting the care. And it almost looks like that we have the physical bodies and administrators that are being counted as part of that ratio. And the vulnerable citizens in the nursing home need hands-on care. That's why we have to write it down in the terms to clarify so those things are not being wrongfully used when we are reporting. So that's part of the concerns. Can you speak to that?
Sure. Currently, the director of nursing can only be counted towards, which is the main administrative nurse, towards the direct care staffing in a much smaller facility. The ability to use your director of nurse or your assistant director of nursing towards the staffing levels is being removed in the proposed regulations that the Department of Public Health has put forward, and I have not seen anyone object to that removal. It will be a hardship for some of our smaller nursing homes, like a 30-bed nursing home, but there's no objection to that, and so that should move forward. There's also a definition of direct care, and I believe the Department of Public Health has always enforced a true definition of direct care as to who is actually caring for the residents on the units. We have some requirements of 24/7 RNs being on duty in all nursing homes in Connecticut, which is not the case in many other states. We also required to have a licensed nurse on the unit 24/7 on each unit. And that's caused some with the workforce issues, that's caused some concern because some nursing homes have had to restrict opening an empty unit because they just can't find that 24/7 licensed nurse coverage for those units in certain areas of the state. The posting requirement and I agree with Mairead, there are some concerns if people are not following the current laws regarding posting of your direct care staff. The state statutes have very specific requirements as to who can be posted, how it needs to be posted. Nursing home is to update that when there are changes, and you are supposed to remove anyone who's out on transportation duty. We just recently reissued the posting forms that we created for our members that outline all of this for them when the minimum level.
We lost your audio, Mag. Can you try and speak again? We can check. No, we can't hear you. Your microphone is disconnected or something. And I promise it wasn't us. We can't hear you still. Let's give you another 10 seconds to see if we can fix it. We'll go to the next person, but we do have questions, so we'll probably have to bring you back because your testimony is very important to us. Okay, Meg, you can try to join us.
Can you hear me now?
Yeah, very well.
Okay, thank you. Now, where did I leave off? Was I talking about the posting when
Yes,
you
you
lost
were.
me?
Yeah, no, we lost you the literally 1 second as soon as we couldn't hear you, I spoke. So you're pretty good.
Oh, so as I said, the new regulations will not allow a director of nursing or assistant director of nursing to be counted. Did you hear
Correct.
me when I responded to that?
Yes.
Okay, so when I was saying that I would really want to work with Mairead to make sure that all nursing homes are following the posting requirements that are on currently in state statute. It is concerning to us also if people are not updating those postings and are posting staff that's not in the building, because that is currently against state law. So happy to work on that with Mairead also. And also hopeful that when the full acuity-based system is phased in July and the guardrails come off and everyone is recognized in their rate for the staffing that they have, that those providers that have provided very good staffing over the years will be reimbursed for that staffing, and there will be incentive for others to add additional staffing to their to the floors.
Thank you. Now Representative Cook.
Thank you, Mr. Chairman. Hi, Meg. It's great to see you. And I want to thank you for always being here and willing to answer the questions that we have. But I do want to push back a little bit on the staffing ratios, because regardless of what is in statute, we know that there are a significant amount of facilities that are not following them, regardless of what's in law. So what do you suggest that we do if it's not about improving, separating them out, ensuring that they're adhered to? What do you suggest if nothing else is working at this point?
Sure. And you know, we briefly saw some ratios be put into place by the Department of Public Health, and we saw the impact on some of the high quality nursing homes who suddenly had to reconfigure what their proven staffing patterns were, just to make sure that, say, from 7 to 9, that they had the exact number of CNAs that were required, even though they were providing, you know, 5-star staffing throughout the day. But I think there's enforcement is really key to this. And I think that Mairead's role is very important, because Mairead reports when there's concerns. We have the requirement. It's not just a 3.0 minimum. It's a requirement that you staff to the needs of the residents. We are currently auditing the MDSs of all the nursing homes. That's what DSS is doing as part of the acuity-based system. We have DPH is catching up on their surveys. They are in buildings on complaints now. I know that there's been some concern that DPH hasn't been out enough, but from the perspective of my members, they have seen DPH in their buildings quite a bit. They've been out catching up on the surveys. They've been aggressively doing complaint surveys. And I think that is the enforcement is what we need to ensure is happening, making sure that DPH has the resources they need to do the enforcement, making sure that Mairead has the resources she needs, as she hears from many families and residents, and that we can react quickly to that and be able to enforce the fact that the nursing homes need to staff to the needs of the resident. There's a lot of different staffing patterns going on out there. People are meeting the current requirements for CNR and RNs, but a lot of people are taking advantage of occupational therapists when it comes to memory care. They're creating other types of staffing that alleviates the CNA of some of the work that's not CNA work, so that the CNAs can really concentrate and spend more time with residents. They're trying to be creative to create a good culture within the building where everyone feels very supported in their staffing role. And we as a association are working with DPH to try to enhance the role of management, so they understand the development of a good culture. They understand how a good staffing pattern can be created, and how a culture for that workforce will be inviting to people and will be able to retain staff. So we're working on various levels to make sure that every nursing home is providing culture and staffing levels and staffing patterns that work for the residents that are in the building.
So as much as I respect what might be intended to be happening, we obviously know that's not happening everywhere, because if that was happening everywhere, we wouldn't be sitting on over 2,000 complaints. We wouldn't have people dying in the nursing homes. We wouldn't have CNAs with one CNA for 80 patients. And I can just continue to go on and on and on and on. And this has been a conversation that's been going on for many, many years. And there's always that pushback anytime that we want to make a change, anytime that we want to require more enforcement, anytime we want to raise staffing ratios. But at the end of the day, we have residents that are fearful of their life. You know, I often say when we talk about this, that if I have one adult for every 4 to 5 infants and toddlers in a preschool program, and they're much smaller and much lighter, but I'm having one adult for 24 in some cases 80 adults that are much heavier, bigger, and the needs are vastly different. Something is much more imbalanced here than anybody wants to give credit to. And if we're supposed to rely on the administration, whether it be the owners, the building directors, or fill in the blank to do this job, if the job was being done appropriately over the years that I've been fighting for this, we wouldn't continue to have these conversations. We wouldn't continue to have people being lost in the nursing home. We wouldn't have people begging for help. And we wouldn't need to add 30 more staff to Merid's office of ombudsman to follow up with all of these complaints. And then DPH could do their job in other ways, short of following all these complaints. So there's got to be some give and take here. And if we paid people better, if we respected them better, and we didn't have to have them work 2 and 3 jobs, people would not be in a position where they're tired, they're in compromising positions, and they don't want to come to work for somebody that doesn't respect them. But the owners of the facilities are making $800,000 to $1 million at a shot. So, and I hear that you're not talking about the for-profits, Meg, so you might get a little bit of my rant frustration, but this is a problem. And it is a problem across the board. It is for-profits, it's about non-for-profits, but at the end of the day, it's about quality of life for people that have walked this earth before us. And if it weren't for them, we wouldn't be here. And it is about dignity and respect. So I am frustrated that we're continuously having this conversation. And I know it's not necessarily you, but collectively, everybody that has a hand in the nursing home world or caregiving world has a hand in this problem. And we have got to fix it, and we have got to fix it yesterday. So
No, I understand your frustration, Representative Cook, and as I said, you know, I do represent the nonprofits. We, my members tend to be the highest staffed buildings, and have been for years. They were staffed very high, even when they weren't being reimbursed for it. Our rate system is designed, has a really good design to incentivize people to staff heavily with direct care staff. We just haven't followed that rate system. We've always frozen the rates. So many of my members have gone for years getting paid much less than what it's costing them to provide care to the Medicaid resident. This new acuity system and the rebasing of the rates will recognize the fact that there are people that invested in high quality staffing levels will actually realize the rate that they deserve. Granted, it's from 2019 costs. And the state understood that because we were able to demonstrate to them that if you follow the rate system, people that are providing high quality care will receive the rate that they deserve because that's the money they're spending. And those that aren't doing that, their rates will fall because they're not investing in the staffing and the other costs that are allowed by the state of Connecticut to be spent for your Medicaid rate. So that piece, I think that piece is a great example of one way we can start to address incentivizing people that are providing the quality care and telling those that, you know, are not staffing at higher levels that we're not going to reward them for that. I do believe that we need to enforce the laws that are on the books. If someone is staffing 1 to 80, that is against every statute, every federal regulation, and every state public health code regulation that we have. And I will not defend anyone who is staffing 1 to 80. That's a reason for this Department of Public Health to come in immediately. We would support the enforcement efforts that the department wants to put forth. We need to enforce the records that the laws that are on the books. We need to insist that nursing homes staff to the level of needs of their patients. And we need to actually recognize the good homes that would encourage people that want to work with older adults, that want to work in this field, would then come into the field and know that there are nursing homes, assisted livings, home care agencies that really value their workforce and really support their workforce, and that they can come in and be valued as someone working in this field. So I think it's a multi-pronged effort. I am not going to defend anyone who's providing subpar care. And I am happy to work with anyone who wants to enforce the laws that are on the books and go in and try to increase the quality in every single nursing home in the state, not just the not-for-profits that I represent. I'm happy to work with Mairead. I've worked with Mairead before, work with the department, be able to provide the support that's needed and the education that's needed to ensure that the nursing homes are not only meeting the standards, but exceeding the standards that the state set for them.
And thank you. And I know that you're always willing to work. And I appreciate that. And I think that we're all very thankful for that. But at the end of the day, if we were doing what we are supposed to do, and that's in for-profit and some not-for-profit homes, we wouldn't continuously be having this conversation. And I think that if we put into statute that we have to have X amount of RNs, X amount of CNAs, X, you fill in the blank, you know what? That just gives us a better way to really track who's not showing up to work, who's not being held responsible, and where do we need to fix that problem as well. And I'm happy that you said that we are supposed to be staffing to to one's needs, because you know as well as I know that that's not happening either. Because if we were truly staffing to the needs of the residents that were in these facilities, that we would have one staff to maybe 2 residents, maybe one staff to 3 residents, as opposed to, like I was saying, one staff to 24 or 80. So as I'm grateful for your dedication to continue this process, and grateful for Mairead and her team, which I wasn't in here to be able to thank them for all the work that they do, something needs to happen before people continue to die. And as part of the Public Health Committee, we have one obligation, and that is to ensure that public health and safety is on the forefront of the decisions that we make, whatever that looks like, and to ensure the safety and the care for people are done top notch. Our residents deserve that. They deserve nothing less than that. And so I really look forward to us continue pushing forward, because at the end of the day, it's been too long. Thank you, Mr. Chairman.
Thank you so much. And I have another question from Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for being here today. If these proposed laws are passed as is, how will the minimal staffing requirements be enforced? To your knowledge.
They'll be enforced by the Department of Public Health. They will respond to a complaint, or they will check on survey. They will check, they can check quarterly on the Nursing Home Compare, because your payroll-based journal numbers are posted up on Nursing Home Compare. They would include staff that would not be included in these ratios, but it would give the Department of Public Health a sense of who might be staffing low, so they could come in and check your staffing levels. At any time, you need to post the levels. Every day, all day, in all 3 shifts, you are to post the levels. This is what a concern that Mairead raised, was that people that were, the postings were misleading and not corrected, and we don't stand for that. It's the law that they be updated. One of the problems is that when they were enforcing these specific ratios, which didn't even have a specific LPN ratio, it was just the RN and CNA ratios that the Department of Health had put out. We had for instance, one very, very highly staffed 5-star facility that has consistently had 5-star staffing, had 3 call-outs in a day of CNAs on one shift. They scrambled. They were able to get 1 replacement, and they were able to cover by having nurses conduct CNA work, and they were able to cover for that portion of that shift that was, I think it was a 4-hour shift, to be able to provide care. There was no care issue, no complaint, but when the department came in and checked, did a 2-week look back, they noticed there was a period of 1 shift when they didn't have the CNA levels, and they were cited. So they were, and it would have been a costly citing if the department hadn't pulled back on the ratios. So it just goes to show how difficult it can be to maintain these various specific ratios at any particular time, even if you're providing the quality of care and attending to the needs of the resident.
Okay, thank you. But does DPH do spot inspections, or did they inspect because someone called and made a complaint?
I think they were coming in on survey. And so when they come in on survey, they do a two-week look back. on your staffing.
Thank you.
They
Thank
do
you.
more than that. They do a 2-week sort of check, look back.
Thank you.
Thank you so much. Seeing no other questions or comments, we'll move to the next person on our list, which is in person over here, April Piet. Welcome. If you want to turn the mic on too. Yeah, you're welcome to read for her if you want to. It's up to you.
Would you like me to read for you? Okay. Good morning, Senator Anwar, Representative McCarthy, Vahey, and distinguished members of the Public Health Committee. My name is April Piet, this one right here, and I am a person in recovery for mental health. Thank you. Thank you. Thank you so much. I'm a person in recovery for mental health and depression. I'm a registered voter in East Hartford. I am here to testify in support of SB 370 peer-run respite centers. I think people will get more help one-on-one with a mentor or peer instead of in the hospital where the rights will be taken away by force just because someone asked for help. My sister tried several times committing suicide. She was at the Institute of Living 4 times, Hartford Hospital 3 times, and Norwich State, which is no longer open. My sister was tied up against the wall in restraints and her arms were bleeding. They took the blade away and strapped her up and they never stopped the bleeding. All they did was monitor her and they wouldn't let her see her family. They just medicated her to keep her calm, but left her in isolation for a very long time, and it made her condition worse with the trauma she experienced while she was there. The situations have not changed much since then. She is no longer with us today. I know that if she had a kind place to go to recover from her episode, she may have had a chance at recovery and a better life. Therefore, I am asking that you please pass this bill and create peer-run respites in Connecticut and support people experiencing a mental health crisis in the most humane and voluntary way possible. Thank you for this opportunity to kind of speak and share my sister's experience with you to see what this would mean to the people that need care from peers in a kinder world. April Piet.
Thank you so much for your testimony. Don't leave yet. Thank you so much for your testimony, and we're so sorry for your loss. And we want to thank you for advocating on behalf of not only your sister, but everyone who is also in need for help. So is there anything else you want to add, or you're good?
Is there anything else you want to add, April?
Yeah, I think more people should evaluate, come to the houses or whatever, so they're not alone and isolated. Check more often. Sometimes it's hard when you got a mentor, like I got Diana as a mentor, but there are so many people out there who don't have that. And we need more help in mental illness. There's so many people dying every day from suicide because of mental illness. We need to listen more, open our minds and our heart, and listen to cries. I've been in recovery for 52 years. I was in depression. I finally found a therapist, and I'm doing better each and every day. I am a U.S. veteran. I served Connecticut as well as my country. And I just want people to know that people are crying and they're hurting, and they need someone who's there to prevent any more dying by suicide.
Thank you, April. Thank you for your service and thank you for your testimony and thank you. We hear you loud and clear. And next person on our list is Anderson Curtis. Thank you, Mr. Curtis, for being here. Welcome.
Hello to the chairs of the Public Health and other members of the Public Health Committee. The testimony just now kind of shook me up a little bit. I just want to take a moment to regard my dear friend Lori, who passed away about a year ago. My name is Anderson Curtis. I am the Senior Policy Organizer of the ACLU of Connecticut. I am testifying in support of SB 370, an act concerning peer-run respite centers for persons experiencing a mental health crisis. I am here today by grace and support. I want to share the significant role peer support plays in my life. My story is not unique. Peer-run respite center means a facility that is safe, a physical safe space. Peer-run services means voluntary trauma-informed services provided to adults in a home-like environment that are least restrictive of individual freedom, culturally competent, focus on recovery, resiliency, and wellness. Peer-run services means assistance that promotes engagement, socialization, recovery, self-sufficiency, self-advocacy, development of natural supports, and identification of personal supports. The words I just used are literally lifted out of the Bill language because I'm in agreement with those definitions. The definition I like to put a little more meat on the bone is the definition of peer support specialist. Language in SB 370 defines peer support specialist as a person who has had psychiatric history and experienced severely interrupted life challenges. I want to pause for a minute on the interrupted life challenges, which unfortunately or fortunately, depending on where you sit, I have vast experience in my life. My life interrupted challenges, I'll say, are benchmarked by incarceration, the despair of addiction, and the shame of homelessness. The vicious cycle of recidivism and addiction ruled my life for over 20 years. It was not until I became tired of me that I began to contemplate change. My change process is saturated with encouraging words from peers who I did not identify with peers until I made a decision to change. And those words, those kind words came back to me as I started thinking about change. Peers helped me reach beyond my grasp. As I have the luxury of reflection, peers are priceless, and the cost of peer support is sadly best defined when it is not present and people fail. I am not simplifying this, yet I know I would not be here today without peer support. I strongly urge this committee to pass Senate Bill 370. Thank you.
Thank you so much, Mr. Curtis, for your testimony. We appreciate your speaking up. Thank you for sharing your personal perspective as well and the value of this. It really is meaningful to each and every one. I'm not seeing any questions or comments, so we'll move to the next person. Thank you so much.
All right, thank you.
Diana Hagan, welcome. Oh, thank you.
Yes, it's me again. Oh my goodness, hopefully my voice will hold out. Good morning, everybody, again. My name, I've got April's. I guess I need to shoot from the hip. I'm Diana Hagan. I am a person who is in recovery and I'm a registered voter in Tolland. I've been in recovery, thank you, since I was a child, really. And I really feel like I got care because of my race. I think that I mattered back then. I'm aging myself, but, or I'm dating myself. But now I feel like I'm an advocate for people who are living with mental unwellness. And one of the things that I do, I'm a manager of Common Ground, and I'm also a graduate student for USJ. And as I'm learning, I'm realizing that the programs that we have in place that maybe once worked are no longer working. We need better innovations. We need better, better thoughts when it comes to people that are living with mental unwellness. And Peer Respites is definitely right up there with the innovative type of thinking that can not only save state money from repeated hospitalizations that on average cost $40,000 per stay. As a manager of Common Ground, there isn't 1 week, sometimes 1 day that goes by that we are not de-escalating somebody from a crisis. This has gotten worse since the end of COVID. I've seen repeatedly my staff are spending hours trying to de-escalate someone, but we're not open 24/7. They end up in the hospital once the weekend comes by. And they're still in the hospital when we come back on Monday because they have no supports. They have no place to go. And I'm going to tell you, they don't want to go to the hospital. They're afraid of what to do if they don't go. But yet when they call for help, the police come, even the crisis teams that try to de-escalate. Once anybody who knows anything about mental health, once somebody's anxiety gets above a 6 on a scale of 10, it's very hard to bring them down. And you need to spend a lot of time to do that. And we do the best we can at a social club, at a Demas run social club, but we only have 4 staff for the 75 people that we have. So to see this and to spend so much time, it's not that we don't care, but there's a certain point, a certain level that you have to bring somebody to a higher level of care. And with no other options, we're subjecting them to further trauma, to increased crisis, because once they get there, sometimes they're restrained. All of their possessions are taken away. There's no windows, no contact with the outside world, which, here we are trying to teach people how to do occupational therapy and get back to work and school and learn a productive life. But we don't have the supports that allow them to do that, because as soon as they get the supportive housing or the job or start enrolling into school, they're hospitalized and they're going to fail at that very attempt. It's
Excuse
like,
me, Ms. Hagan, but your time is up. Thank you.
so I do support the peer run respites, and I hope that my testimony does matter, because it is a very important bill, and I hope everybody takes it to heart. It's cost saving too. Thank you very much.
Thank you. Don't go away yet. We have a question for you.
Okay.
And I'll ask my question, and then we'll have my friend Representative Claire
Okay.
Dietrich ask.
I'll do the best I can.
So one part that in having a lived experience really gives the empathy, understanding, and that connection, which is a very important part of helping out. But every decision is associated with risks and benefits. And in mental health arena, there are risks, for example, suicide risk. What kind of formal training is necessary, and has that been standardized to the best of your understanding for that? I know for substance use, there is a pathway, but for mental health and for severe depression, could you help us with this? And I think this is a question, similar theme for other people who are going to speak on this topic to help us as well.
So what kind of qualifications you're asking? for the
Yeah, or
person?
some kind of a standardization, just recovered or recovering is one very critical part, but there's probably more to that as a formal process of risk assessment.
Well, there is the mental health first aid that we try to get everybody to get certified in, at least in our organization. For me, I'm studying to be a clinician, will be in May, but I don't think everybody needs that level of care. I think the training that comes is really from mentors in the field, from experience in the field, addressing crisis situations, shadowing professionals. But a lot of it comes from that mental health first aid. But I think most of it is about what is the time that we have with the number of people we have to care for. And, sooner or later, it's going to end up to a call for hospitalization or a call to 911. And if there's no place to go, it's the hospital.
And again, another thing to keep on the radar for a conversation, perhaps with you and others, is that healthcare systems, when a person goes to the emergency room for a crisis, it appears that they are more in the protectionist mode. And then that's why you're hearing individuals come and share that they're put in a room, so they are going to be quote unquote safe, but nobody's giving them the attention with the empathy and the pain that the person is enduring. And the emergency rooms are so overcrowded that it's getting more difficult to get the first-hand one-to-one conversation in a meaningful manner that people are hoping that they would get in that difficult time. So collaboration with the existing emergency departments, with peers, would be something that we will have to start to brainstorm about as well. This bill doesn't do it, but that's something that's worthy of a conversation.
Absolutely, absolutely. I think everybody should be open to any kind of change in this current climate with people that are dealing with more and more mental unwellness.
Good. Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for being here today and sharing your experiences. Just for those of us maybe listening and not understanding as much, your Common Ground facility, you currently said, just for clarification, that everybody that works there, their motive, their training is the mental health first aid course.
Correct. They've all taken that, all the CPR training, all those kinds of trainings.
And how many facilities do you know, may or may not know in the state, do we have that are similar to yours or the same?
They're all quite unique, to be honest with you. And so is Common Ground. We're a smaller facility. There are other facilities, but with the number of people, the larger they are, the more people end up coming. So it's about staffing. If you've got, 4 staff to 75 people, that's not exactly, it's not like we can spend 4 hours on a crisis episode
Thank you.
per person.
Okay, and is your facility regulated by the state?
It's DEMIS. It's a DEMIS run.
It's
Yes.
run by DEMIS. Okay, thank you very much for your
Thank you.
testimony. Thank you, Mr. Chair.
Thank you, Rep. Denning.
Thank you.
Thank you, Mr. Chair, and thank you for sharing your testimony.
Thank you very much.
I agree completely about having a partner in getting through these kind of episodes. My concern is we just are having discussions about nursing homes where we have patients who are needing care and we don't have enough people to take care of them, and the ratios are off. And my question is, if we start a whole nother program from the state level, does this run into the same problem in a few years where there's not enough volunteers, there's not enough trained resources for the demand that comes in for these centers that we've required? And do you partner with any particular organization, hospital, that could be a better place to be to organize around rather than be its own separate entity?
My best response to you on that is that the whole point of peer respite, and respite is like a break from, like a vacation from one's life, so to speak. And you don't want it to be in like a hospital facility. You want it to have the feeling of being at home, being safe, and the stays are usually not as long. So it's a matter of having an option for people to have it somewhat of an option for them to say, no, I don't need to go there. I just need some help. I need to talk to a peer. And like you said to the gentleman before, it really helped to them to find their path to recovery by speaking with peers and by getting the help that they need. So it's more of an organic and natural relationship that occurs, rather than a professional to patient type of relationship. And sometimes that's where healing can happen.
Right, but if we were to organize this as a state around hospitals that could provide additional services and or care, instead of setting this up separately, is what I'm trying to understand. I just feel like we may be setting ourselves up for another situation where we're trying to provide care, but in a manner that cannot be sustained.
And I understand that, but I think the cost savings from the hospitalizations will be incredible. because, the stays are fewer. They're not as long. People aren't going to lose their housing and their current supports because the stay is shorter, and people can take a vacation for a few days and still not lose their job or have to be disenrolled from classes or things like that. So people can still hold on to some independence and not lose their life by asking for help. So, because losing your life can happen in many different ways. It's not just losing your physical health. It's about losing your family and your support system, which can happen. So, it's kind of like the space that you want to put it in. I believe that it's sustainable. It's been sustainable like that in other states, and I think it's time Connecticut needs to kind of look in down that road for people, because what we're doing is not. It's kind of like similar to what we've been doing for, decades, and the climate is different. And this isn't the 20th century anymore.
Thank you very much for your testimony.
I hope that
Thank you,
helps.
Mr. Chair.
Thank you, Representative Terciak.
Thank you very much, Mr. Chairman. Thank you very much for coming in front of
Thank
us.
you.
I've got a couple questions I'll ask you because you said you're on staff, so
Yes.
maybe and studying, maybe you're familiar. Are you familiar with recovery specialists, which thank you, with recovery support specialists?
Actually, yeah, actually, of course I am. I have actually referred several people into that program that are from my club. So, and they've graduated, and Common Ground has actually supported their interests even during COVID.
Thank you,
Mhm.
because when we talk about having people with certification or training,
Mhm.
the folks who come to mind first are our recovery support specialists. Did I
Exactly.
say it right? Although I don't always get the title right, they're first in my mind as the right people to be handling something like this. So I think we're talking about much more than mental health first aid here. That the right
You're right.
answer,
You're right.
the right answer is recovery support specialist.
I like that too. Yes.
Thank you. Also, are you familiar with homes with centers that sound exactly like this, except they're for substance abuse? I think we have 3 of them run in the state in the private sector.
3 of them. I'm not aware.
I think we should find out more about them because that might be the answer we have here. It's a model that already exists.
Yes, you mean but that's for substance use disorder. We're talking about also mental health.
I know we're talking about
Okay.
mental health, but the model is
Okay.
that people in recovery, the people who, if they have, making sure they have the proper training.
Yes.
Because it's useful and because it makes us feel better. They're often the very best person to be with somebody in crisis, whether that's a short-term crisis or a long-term crisis. The centers I referred to are, as far as I know, aimed at substance abuse,
Mhm.
but recovery support specialists are trained in both substance abuse and mental health. Correct?
Yes.
Yeah. They're in our emergency rooms now.
Correct.
They are in our general hospitals and on more than just the psychiatric unit. Demas has them, I believe.
Yes.
Yeah.
Yes. Absolutely.
So when we talk about this, I think that we may already have that we do have a model we want to take a closer look at, because it's possible that I'm wrong, and there's really no reason not to have their arms open to welcome people in mental health crisis, the recovery support specialists.
I think that it's a great idea. I just think that when you're mixing them, because I've worked in both fields,
Me too.
and sometimes people who have substance use need that kind of specialty with recovery support specialists, where someone with mental health needs that specialty support as well, because not everybody knows everything about everything. That's why, like, as a social worker, you specialize as well.
Yes, you're a social worker and I'm a nurse, but I'm talking about recovery support specialists, and they do know everything about everything. They are trained in both substance
Okay.
abuse and in mental health. And when they're hired for an emergency room, they're expected, and they do, walk in and handle their assignments. Either way, great job. As a nurse, I've worked in mental health and
Mhm.
substance abuse forever. 40 years experience there tells me that everybody doesn't get to be in this silo or that silo.
Sure.
So thank you very much for coming here. This is a fantastic idea. My only suggestion to you is the answer is recovery support
I
specialist.
didn't think of it. I
is-
didn't know I was going to get
you know,
answered or questions.
No,
So-
they're a resource we already have. We should be
Yes.
doing everything to have them be part of our solution to our shortages. in
And I think that would
mental
be a
health
great
and
idea
addiction
too. Yeah,
services.
let's implement that.
Okay,
Yeah.
thank you very much.
Thank you.
Sir,
Thank you. all.
And Madam Chairs, and I know you were listening because I speak so seldom but so long. I'm passionate about it. It's important to me. We have the people who are the answer.
I
Let's give them the
totally
system.
stand
Thank you.
corrected. Thank you so
Thank you
much.
very much. Good job.
Does anybody else have any
Thank you.
questions?
Next person that we have is, Representative Perillo, you have a question.
Oh, thank you, Mr. Chairman. I appreciate it. Good afternoon. I was going to say
Good
good morning.
afternoon.
So I want to try and understand and actually to piggyback on a point that Representative Denning made and then also that Representative Terziak made. I see your rationale behind there being different support givers, for lack of a better term, to those with a substance use disorder and those with a mental health problem. I understand that.
I've seen them separate themselves in my own club. So
Understood,
Yeah.
understood. I'm just wondering, and to Representative Denning's point, do we risk creating a new level, call it what you want, of provider by creating this new system? Or would we be able to piggyback off the system that Representative Terziak mentioned that's already in place? And I know that what the representative mentioned is generally SUD focused, but there is to some degree an infrastructure in place. And my sense is that you're very concerned about commingling the populations, but I'm wondering if there couldn't be a way, in your opinion, to take advantage of the existing infrastructure, but still treat the populations, the SUD population and the mental health population separately. Because as you know, there is also, while they are different, there is also quite a bit of overlap.
that's true. There's plenty of dual diagnosis. There is, but even substance use is usually happens because somebody hasn't gotten the right kind of medication and they try to self-medicate. So, everybody, what's interesting is no one size fits all, I think, for everybody. So having many options, I think is going to help people. And especially with people that are familiar and possibly look like them, which is what this bill, or what the proposal is, trying to separate, just so people can be amongst actual peers that look like them, that talk like them, that have cultural awareness to who they are, and what they might have experienced sometimes, within their own culture. So depending on what it is, I mean, yes, we could put everybody together. And I love the idea of recovery support specialists, but I think it's like, where are you putting them? And, yes, is there a recovery house that we can put you want to call it a recovery house? That's great. But we're calling it peer respites because it's a place that people can feel comfortable, feel at home, relax, decompress, de-escalate amongst, whether it's recovery support specialists or peer specialists, or volunteers that have lived experience. I think either way, it's going to be a good proposition, a good innovation for today's world. And I feel like it's going to make a big difference for, I know for the people that I work with, the people that I try to help, and for my staff, and for anybody who's in community mental health at all, because we're going to give people options. we give people options and, they're going to go to these centers or these recovery houses, whatever you want to call it. And they're going to have that option to say, let me try that. I had somebody just last week that said, I'm just going to get in the car and go. And we tried to de-escalate them and spent hours doing that. And there was really no talking to her for several hours, but then we were able to turn her around and distract her to get to where she needed to go. But by Saturday, she was still hospitalized. Still is. So, this is what ends up happening.
Yeah, I totally understand. I mean, you've identified a clear problem. I mean, there is a lack of resources, to your point, for specific communities especially. And I appreciate the goal here. And again, my biggest concern, and we're on the same team here, to be clear. When you have so many options, two things can happen. One, certain layers of those options can get lost in the government shuffle, and that some of them don't get the attention they deserve, just by nature. And B, there becomes so many options for the potential client that they don't know where to go either. So now you introduce a new concept of a navigator who's going to help that individual in need of mental health, who's in mental health crisis, then figure out where best to go. And I would hate to create with the best intentions, I would hate to create a new system that, while offering a wonderful service, can also make it more complex for the individual in need of help. So I completely understand what you're saying. I get it and I respect it. And in many ways I agree with it. I think we need to have a bigger conversation about how to, in a more holistic way, in a coherent way, within existing systems, meet the need that you've identified and it clearly exists.
Well, if I can just add to that, because I believe that the systems are already in place. It's called the crisis teams. We have crisis teams right now that go out into the communities. We have crisis teams. We have people like, I would so much prefer to be able to refer somebody to a peer respite center than to just call 911. So it would be so much better for them, and they can actually keep their life. They can keep the progress that they're making. I mean, that's the big long-term goal here. They can keep their lives. They can still stay in touch with the people that are supporting them. They go into the hospital, they lose all that. And then here we are trying to help them get back on their feet all the time, trying to help them get new housing all the time, which is another huge problem, but that's separate issue. But for this issue, I feel like this is something that can make a huge difference, give those crisis team people options. It's already in place. So, whether it's an emergency room that needs to refer to a peer respite, if it's a community mental health center that needs to be referred, whoever it is that's referring, the system's already in place. This is just offering another resource for that system so that it becomes more effective.
Okay, you make a fair point. I have to do some more research on my own because I may be missing the boat on this, and it happens all the time. So, but no, thank you.
None of us know everything about everything.
That's
So
certainly true. But seriously, thank you for bringing this to us and
appreciate
for
it.
working to find an option that helps everybody.
If you wanted to reach out to me or any of my staff or my director of rehabilitation services who is on the crisis team, I'd be happy to give you those kinds of referrals so that you can speak directly to those professionals.
Thank you. Thank you
Okay.
so much. Thank you for your testimony.
Right,
Seeing no other
blessings.
questions, we will move to the next person on the list.
Thank you so much.
Which is Karen Healy. Thank you so much, Ms. Healy. I know you have a deadline, so.
Good afternoon, Senator Anwar and Representative McCarthy and my members of the Public Health Committee. My name is Karen Healy. I'm a registered voter in Hartford, Connecticut. I'm a person recovering from mental illness. It's been 24 years of my life in psychiatric hospital between Hudson River Valley Hospital in New York and Cedar Crest at CVH in Connecticut. I am now living successfully in the community with services supports from the Department of Mental Health and Addiction Services, Capital Region, and Goodwill. Speaker of the House, Matt Ritter, recently presented me with an official citation in recognition of my 9 years of my anniversary of release of Connecticut Valley Hospital CVH in December 4th of 2014. I'm a member of the Keep the Promise Coalition. I was appointed by Governor Lamont about a month ago to the Connecticut Council of Developmental Disabilities. I was chosen to be a part of these advocacy committees because of my story and my lived experience, which I used to help other people. I'm here today to testify in support of SB 370, an act concerning peer respite centers for persons experiencing with mental health crises. A few years ago, I injured myself superficially on my arm with a butter knife. I called 911 and explained that I only hurt myself superficially and it wasn't an emergency. So I was terrified, be surprised when two Hartford cops, a female and a male cop, came and they walked into my door and said, "Where's the weapon?" And they had the gloves on, both of them with their hands crossed, one on the stick and one, I don't know, it was a taser or the gun that night. And then also they said I had to go to the hospital. They brought me outside to the ambulance, where the ambulance was in the front of my building. And they said if I touched my arm, they would handcuff me or restrain me on my way to Hartford Hospital. I was so scared that I already didn't know that it was gonna happen. That happened that night. I'm gonna add, because other people said other things, I'm gonna not finish with what I really wrote. My heart is that I've been plenty of times in Hartford Hospital in Purple Pod where the psychiatric area is. A couple of years ago, I really did something to myself where my program had to send me to Hartford ER, where I was triaged. Then they put me in Orange Pod, is where one of the Purple Pods areas for psych. I had hurt myself to the point where I went to the bathroom, it was on a coin. A coin is where a PCA is supposed to watch. They can have up to 5 or whatever, one person for doing something to themselves. I went into the bathroom. They weren't watching. I did something more to my arm. When they transferred me to Purple Pod, at that point, they had changed their bathrooms where you have to swipe to get into the bathroom, public bathrooms in Purple Pod. I went into the bathroom just being in the main ER for hurting myself and going at my arm 3 times. I went to the bathroom and I really hurt myself really bad. Till I called out and they could have badged to get in. I think that's really sad and really crazy when you have someone who was just in the main ER part for hurting themselves to the point where they had to hold her down and medicate her. I also support the people I think in Purple Pod, they're starting to have people that come in to speak to people when someone's in crisis, as my own self, I have been. When someone is a psychiatrist or a social worker or a psychologist who's been to school and know everything because they go to school. When someone's in crisis like that, they need someone who understands, who's been through the situation, where you're not judged for what you've done to yourself or why you did it. I feel that people need to be not judged for what they have as mental health or any other disabilities. That's what I have to say today. Thank you for taking your time to listen to my testimony today. I appreciate it. Everybody deserves the chance of living in the world where we're all as human as everybody else. And when I left CVH, I had told my clinical team that I'm not a label. As CVH, you're a chart, you're a label and you're a number. I don't consider myself a diagnosis like I was for all those years, being 24 and a half years of my life in psychiatric hospitals. And one thing is when I was at Cedar Crest, I watched someone. So it's serious when people say they need help, but they don't always need a hospital. Like the same, being somewhere for a couple of days where they can clear their mind. Even though I'm in a program, sometimes I wish I had that opportunity sometimes just to get out of my spot. Because I have staff, I live on my own through my agency that I'm in. But sometimes I feel just when I'm crisis mode, I have somewhere to go, not just sitting with everybody that's always knows me. Thank you.
Excuse me, Miss Healy. Okay. Your time.
Perfect timing, my God. So thank you so much, Ms. Healy, for your testimony. We appreciate you sharing your experience and in helping us have a better understanding. My co-chair has a question or comment.
Just a very quick comment. Karen Healy, I'm right here, and I just want to say thank you. We are so glad that you are here with us today, that you are alive and that you are sharing your experience. Thank you so
And if anyone
very
ever
much.
wants to talk to me, Alex and Matt Ritter, I'm a good person with Matt Ritter. They can always give you my contact because I'm always willing to speak to people about my recovery and what things that can happen, what I've been through and how to fix things. Thank you for taking your time to listen to my testimony today. Thank you.
Thank you. Seeing no other questions or comments, we move to the next person on the list, which is Ibrahim Akiwa. Is Ephraim Akiwa here? Okay, and we'll move to the next person on the list, which is Michaela Fissel. Welcome. Hi.
Can you ask me about peer certification at the end of my testimony, please?
Sure, please go ahead. Yes.
Thank you. My name is Michaela, and good morning to respected members of the Public Health Committee. I'm a member of the peer recovery community. I'm also a registered voter in the town of Windsor, and I'm the executive director of Advocacy Unlimited. Thank you for taking the time to hear my testimony in support of Senate Bill 370, peer-run respites. As a longstanding member of the peer recovery community, I stepped into recovery 17 years ago. At the age of 21, after years of cycling in and out of clinical treatment, the challenge I experienced was in the limited options available within those settings. When entering into a psychiatric inpatient setting, the goal may be stabilization, but from the consumer's perspective, it is compliance. Comply with treatment within a clinical setting is limiting for folks like myself who require a setting that is supportive of the whole person and our total well-being. The context of emergency services and psychiatric inpatient treatment are grossly misaligned with what we know supports recovery across the continuum of care. In fact, people are nearly 100 times more likely than average to die by suicide following discharge from a psychiatric hospitalization. Personally, I was one of those folks who gave up after my last inpatient stay and made the decision to kill myself. I was lucky enough to survive, and then I was blessed to connect with the peer recovery community. The entire trajectory of my life was altered forever as I continued from that time to complete 2 graduate degrees, many certifications, and the totality of my career became a focus on advancing the opportunity of recovery through peer recovery services. Based on the research, the outcomes associated with holistic approaches to mental health and peer recovery services are undeniably far more beneficial in the short and long term. However, our service system long ago, 1963, with the Community Mental Health Act, Kennedy administration, heavily invested in clinical treatment with more than 90% of our state allocation of dollars going towards institutionally rooted services. However, so many people like myself find their pathway to recovery when stepping into the peer community, mentored by people, recovery support specialists, and recovery coaches within continuum of community-based supports that include holistic, peer-led recovery resources. People within these spaces and places can recalibrate their internal experience, find meaning and purpose, and create a life worth living. Peer respites must be part of our approach as a state mental health system and as a whole community of folks who are inspired to take action and be part of the change. You have the opportunity to lead Connecticut into the future. The outcomes reported by folks who stay at peer respites are highly beneficial and include significant improvement in emotional health and coping skills, while also decreasing the odds of readmission by 70%. To date, 15 states have peer-run respites program. Connecticut has none. This needs to change. And I ask, will you support recovery and will you be part of that change?
Thank you so much for your very powerful testimony. We appreciate you sharing your experience.
Yeah.
Tell us about the part that you were mentioning about
Oh,
the
so
certification. Yeah.
Advocacy Unlimited is a designated trainer and certifying body for what are called recovery support specialists in the state of Connecticut. We have trained over 1,400 folks with direct lived experience navigating mental health, addiction, and trauma recovery to use their direct lived experience coupled with education and training to become employed in the state of Connecticut. This is an 80-hour curriculum. I am the principal author of our current curriculum, and I'm also the primary instructor. If you'd ever like to learn more about our certification program, I would be happy to follow up from this hearing.
Thank you so much. This is a very important part. Actually, Representative Terciak, and I'll continue my conversation. Rep.
Thank you very much. Great program you're running. I believe Hartford Healthcare also runs one. And you make sure that people are getting adequate training at both.
That's
right?
true.
I was wrong earlier when I said that we had substance abuse recovery centers. We should have. An RFP was put out for recovery centers, and I don't think anybody bid because our frequent fantasy that all we have to do is ask people to do things and they don't need money to get it done occasionally comes up against a reality like, sorry, nobody's responding to that RFP. You graduate enough people in a month to staff a recovery center like we're talking about. CCAR, I believe, also, they do the recovery specialist?
Recovery coaching.
Recovery coaching, which
That's
is
right.
different and not as high a level of certification as recovery support specialists.
You can say it's comparable to recovery support specialists. Recovery coaches focus on addiction recovery, RSS, our mental health co-occurring. So we also integrate the substance abuse addiction and trauma recovery as well.
Great.
Absolutely.
Because as we're talking about who would be the right kind of people to be working in these, what certification would we want people to have? I have to keep on trying to remember what we already have and what would be appropriate. Thank you very much for your testimony today and for all the folks who are with you doing the good work that you're all doing. It's really important. Thank you very much. Thank you, Mr. Chair.
Thank you. Don't go away yet. We have a lot of questions coming your way. Rep. Denning.
Thank you, Mr. Chair. Thank you for your testimony. I'm trying to wrap my head around this. I'm a nurse, so I understand the healthcare system, but I like the idea that this is outside of the healthcare system. This is actually a community-based system. So explain to me the dynamics of how this would work, tying in mental health, addiction, people who are coming or need recovery help, all into one service that would be easily managed and not necessarily completely separated, but integrated into the healthcare system.
Yeah, I think it's important to look at the models that are already established in the states that are currently operating peer respite. So there are, again, 15 states that have peer respite programs that are operational. You can look to Massachusetts and also out west as well. And so I'm not the best person to speak about how Connecticut will choose to operationalize this in our state, but I just want to note that it's important to recognize that mental health is the primary focus of peer respites. Yes.
Thank you. That's important.
Absolutely.
Thank you, Mr. Chair.
Thank you. Can I ask you about the program? So substance use, mental health, and trauma, right? Those are the three areas. And the 80 hours is including and then makes an individual be trained for all three components, even though there's an overlap, but there's a little separation there too.
Yeah, so I'm a little sweaty. Sorry. This is a big day. Okay, so primary mental health. And so when we think about direct lived experience, most of us have been through something, right? And so what we're training folks to do is to be able to reflect on their direct lived experience to find the human connection, right? And so the circumstances may change. However, the underlying emotional state, because emotion is energy and motion, we can think about how do we connect around shared human values? How do we be with folks using that empathetic listening? How do we be with folks who are in these various states of emotional reactivity so that way they can find their place of balance, grounded, present awareness? Yeah, in a supportive community of other folks who have also been there. Yeah.
Thank you.
So we use, sorry, I just want to follow up.
Yeah.
So we use, like in our curriculum, we teach things like that you would find as someone who's been through a lot of school in many graduate programs, things like motivational interviewing. That's not technically a peer approach, but it's important to recognize that that's part of our curriculum. Also dialectical behavioral therapy. We also speak about empathetic listening. And so much of what we teach about can be found in other professional studies. We just bring that in and integrate it into the kind of lived experience that many folks who participate in our program are already coming into the training with.
Thank you. And what is your organization's relationship with Demas?
Oh, well, everybody is in a relationship with Demas.
Good.
Yeah, so we're Doing this work for a while. We're considered a peer-run nonprofit. So all of us at Advocacy Unlimited identify as being in recovery, mental health, addiction, and trauma. And so we receive grant funding through the state of Connecticut to operate much of our programming.
And this is important. I appreciate your answer as well. I think Demas gets this, and they have been part of this process.
Yeah.
When you're looking at a program and you're creating a program, you start to think about, okay, what is going to be the sustainability mechanism for that? And that's why I asked that question, because right now the sustainability is with Demas, but if we are going to have many more programs based on the needs that we have in our community, then we will have to start to think outside the box how that is going to be sustainable. Can you speak to that?
Yeah, so I want to point to the peer respite RFP that was put out last year. Nobody bid on it because there wasn't enough money. They were saying the proposal was to fund at about $600,000 a peer respite that was actually going to be on site to an institution, on the grounds of an institution. And nobody bid on it because that clearly was not enough money to cover the operating costs of a peer respite and also pay folks a living wage, because we are not volunteers. This is our profession. And then, right, nobody bid on it. And then just quite soon after, there was crisis response centers or diversion centers RFP that was put out that was over $1 million. Where are you investing the money, really? Like, peer respites work. There's evidence to support the outcomes of peer respites. Why do we continue to underfund peer recovery services in our state of Connecticut? And yet we put extraordinary money into clinically oriented services. That to me points to an outdated, antiquated model of institutional care that is rooted in like the 1960s. And so I ask that we bring Connecticut forward and look to a future where recovery supports that are peer run are funded adequately to support the continuum of recovery, of continuum of care that we say that we're investing in.
Thank you so much for your testimony. Thank you for the work that you have done.
you.
You've really helped us out today, at least me for sure.
Can I follow up with information about our recovery support specialist certification and training?
Please do.
Okay, thank you.
Thank you.
Sorry.
Okay. Seeing no other questions or comments? Oh. Do you want to speak to that right now, is what you said?
No, I'll send information later.
Okay, that's what I thought. Thank you.
Yeah, thank you so much.
Of course. Next person on our list is Carol Gilbert. Gilbert. Seeing, you're Carol?
Yes,
Welcome.
thank you. Ah. Oh, hello. It goes to move. How do you, it's not on, right? Is it on? Yeah. I didn't see no light. Good afternoon. My name is Carol Gilbert. Well, it does say good morning here, but it is afternoon, right? So good afternoon, Senator Anwar. Representative McCarthy, Mahe, and distinguished members of the Public Health Committee. You know my name. I am a person in recovery for mental health. For 26 years, I am here to testify in support of SB 370. Peer-run representatives having a peaceful place to support people in crisis would be better for our community because the cost of healthcare are so high. And it is better because going to the hospital can be traumatizing for people. I think a safe place run by peers would be more effective than being forced to go to the hospital when someone asks for help. Therefore, I am asking that you please pass the bill and create peer-run respites in Connecticut to support people experiencing mental health crisis and most human and voluntary way possible. Thank you for your opportunity to speak and share my experience with you to see what this would mean. People that need care and cares to the kinder world. Thank you.
Thank you so much for your testimony and thank you for sharing your perspective. We truly value this. Thank you. Seeing no questions or comments, we'll move to the next person on our list, which is Sarah Davido. Sarah Davido.
Yes. Here. Can you hear me?
Yes.
Okay. All right. So my name's Sarah Davidow, and I'm the director of Wildflower Alliance in Western Massachusetts. I have been in my role for over 15 years, including a peer respite for over a decade. I'm co-producer of a film on peer respite. I'm lead author of the only comprehensive peer respite handbook available in the nation. Thank you for allowing me to testify in favor of SB 370 and act concerning peer-run respite centers. Although I live in Massachusetts, I have many colleagues and friends in Connecticut, and my organization has worked in Connecticut for many years with partner groups to bring alternatives to suicide, and Hearing Voices supports to your state. And by the way, alternatives to suicide is an approach I was a part of developing, and it is increasingly supported by research and is a part of training people who work in many peer respites and other environments to be able to respond to suicide or people who are suicidal. I also grew up in Connecticut and some of my family remains there, so this is very meaningful to me personally as well. When our peer respite AFIA opened, it was one of only about a dozen peer respites in the nation. And I believed in the model, but I didn't really know what to expect. But when we opened our doors for the first time on Saturday, August 4th, 2012, we had someone come to stay the very first day, and it's really never stopped since. I could tell you it's been perfect and problem-free, and that would be a lie. Nothing worth doing well comes without its bumps and learning curves, but the experience has been powerful and meaningful and often life-changing since that first day, and we are here just over the state border, ready to support again as you go through this process yourselves. I could spend the rest of my time telling you how many calls and emails we've gotten from people in Connecticut looking for peer respite because it's not available there, and that has been many, or about how many people we've had to turn away in our own state, particularly when we only had just one peer respite. But mostly I want to talk to you about the impact of peer respite, and to do that, I'd rather share our community's words than mine. The following are quick snippets from feedback we've received over the years. When I arrived at AFIA, I had been unable to sleep or eat for about a week and was having constant anxiety attacks at home. I felt hopeless, alone. After the first day, I began to sleep a bit more each night and eat small meals. I actually left 2 days early, mostly because I felt ready to face reality again. Also because I wanted to allow another person in crisis to have my bed who might have felt as desperate as I did while waiting for my bedroom. My stay at AFIA was a godsend. This has introduced me to a big community of people like me. I still attend one of the groups they connected me to every week. I am now a part of the Wildflower community where I can talk about my experiences and they have value. I can be my weird special self and be liked reasonably well, which is a strange and beautiful experience. No one judges me and people have time to listen. If you need intense support like talking to someone for hours, I don't know where else you can get that. It has been more than 2 years since I stayed at AFIA and went to the hospital before that, and I intend to keep adding to that. Knowing that I have a safety net like AFIA gives me more strength to take chances and try to move forward in my life. It's the only space where I can get connected but still have some control over my privacy and schedule. I felt really comfortable there and was able to finish my coursework while receiving support. Thank you. Thank you so much for treating me like a human being who deserved time to recover. Connecting to people who had lived through similar things and could sit with me in pain from the vantage point of the mutuality has been and continues to be life-saving. I may not be alive today if AFIA didn't exist. I don't understand why there aren't more peer respites around. What are people waiting for? Thank you.
Thank you. We were waiting for this Public Health Committee to be having this conversation. Thank you for your testimony. We truly appreciate it. Can I ask you questions since you mentioned about your 10 years of experience? What are the things that you'd ask us to be careful about as we look at this bill? What are the things not to do?
Well, I love that you asked that question because I was thinking about that honestly as I was listening earlier as well. I think one thing is it really to value what it is. It is working in so many other places. There are, I think, maybe upwards of or approaching 6 peer respites at this point in this country. And we do have a sense of what works. There is research on the outcomes that work. And so I ask that people really pay attention to that and not try and mix it in with other things. I was hearing some of that earlier. I see that happen sometimes, and it really inhibits people's ability to fully realize what the potential impact of peer respite is. So mixing it in with hospitals, where honestly, so many of the people that we see would otherwise fall through the cracks because they won't go to hospitals, or, you know, it also discounts the research or the reality of the research we're seeing right now that says actually being connected to hospitals, being anything involuntary, being in a hospital setting, even if voluntary, is increasing suicide rates. That's what the research is telling us now. So I think it's really important that we pay attention to that and trust the people who have been doing this work and not try and put it into a framework that feels more familiar. I get that urge. We're human. We do that. But I think it will take away the power of this. I also appreciate what Michaela said about a living wage. I think there were a few reasons people didn't bid on that contract. One of them is that it was situated on a clinical campus, and that it would really chase away a lot of people who come to peer respite. But you know, I think that living wage is critical. We want people who are well-trained, and we want them to stay once they're well-trained. And that means paying them what they're worth. And peer respite does bring savings. And I think it's important for that to be known and valued. Brings savings in a lot of different ways, not just in the moment, but also in the avoiding loss of job, loss of housing, and things that can be prevented with peer respite as opposed to when someone is institutionalized. But you know, it's not just that. It's also the humanity that it brings. It's the value of people's lives, the ways in which we avoid additional trauma by not being pulled into institutional settings and being able to stay in the community and go on with our lives. And so many people who are getting connected with some of these alternatives like peer respite are able to have these moments in their life and then go back into the community and live full lives and not get into this cycle of institutionalization. And I think that's invaluable. And I hope you all value it as much as I do. And I believe that you do.
Thank you so much. Another question is, in your program, is there some standardized training, and how does the workers in that respite centers, what kind of training they have outside of the experience?
So we have 4 core trainings. We absolutely value training. We think it's very important, and we think choosing what training is very important. The training that is used most commonly across the nation for peer respite is called intentional peer support. It was developed by Sherry Mead. It's been around for decades. There's research on it. It's developed, it's facilitated or was grown out of Intentional Peer Support Central in Vermont. We are able to get people on our team trained as intentional peer support trainers. And so that was the training that we use. We also use Alternatives to Suicide, which I mentioned in my testimony. It's an intensive training to support people to really be able to talk with others about suicide and suicidal thoughts they're having. It's the first harm reduction approach to suicide that we're aware of in the world. And we've been training people as far as Australia in that. So we use that. And we use training out of the Hearing Voices Network, which is also really, really valuable, teaches people how to support people who are experiencing voices, visions, unusual beliefs, paranoia. And then we do an anti-oppression training that looks at equity and interrupting some of the discrimination and biases that people have experienced that often has contributed to their trauma and sense of loss of power that has brought them to these points.
Thank you. And is your training in the range of 80 hours, like we have some in Connecticut?
Yeah, I mean, it's going to be similar. I mean, so those pieces of those training, yes, I would say that they add up to a similar amount, if not a little bit more than the 80 hours, but they'll cover similar topics. And then we do on-site training as well for people. So people get more than that by the time they're actually working.
And I have so many more questions. We'll probably bug you later too. How is your program sustainable financially?
So we are funded at this point primarily through the State Department of Mental Health in Massachusetts. That is what I'm seeing from most states. There are a few other variations to that, but most people are funded through their states, and the states are valuing them because, again, there's a cost savings in the moments. The research, one of the most prominent research outcomes that we're finding is that it has a reduction in the amount of times that people use hospital and emergency rooms moving forward. So there's a substantial savings to states in that regard. And then again, some of the other savings that I mentioned earlier of people not losing their jobs, not losing their, being kicked out of school, not losing their housing as a result of interruptions, which is a very common things that happen. So when people end up in hospital. So states have seen that value and have invested in making these sustainable in that way.
And how long you have had the program Alternative to Suicide, the harm reduction program? How long has Massachusetts had that?
So we developed that program. It started with groups. So in 2009, we started training people shortly thereafter in our state. And then we've trained people. I was just in Michigan a couple of weeks ago, training people in alternatives to suicide. So it's grown quite a bit since then.
And are there publications on some of this data around some of these?
Yep. There's a number of publications in terms of outcomes for peer respite, which I'm happy to include and send along to you. There is a growing body of research supporting alternatives to suicide. It can be tricky to get research. We've been lucky. We've trained and worked very closely with some folks in Australia that have done some university-driven research. So we have that to refer to as well as some here. But yes, there's research and outcomes available.
Good. Just wanted to thank you for your testimony. When I started to get involved in this after some of the advocates from Connecticut, I had to relearn a lot of things. And I have to agree that the healthcare systems have this little blind spot. And we're seeing that blind spot not addressing the needs. And I had to do quite a bit of a deep dive and invested more than 80 hours of my time to try and get a better understanding. But I appreciate you being here and speaking to us.
Thank you.
Seeing no other questions or comments, we'll move to the next person on our list, who's just arrived as well, perhaps from Massachusetts, Ephraim Akiva. Welcome. Thank you for being here in person.
Thank you. I gotta get closer to this mic here. I'm Ephraim Akiva. I am the Peer Respite Director at Wildflower Alliance in Northampton, Massachusetts. I imagine that I'm probably one of the people in the country who has the most hands-on experience working at a peer respite. I have worked there for 12 years, and I have worked almost every position that exists on the team. I have worked every shift there. I have seen many, many people come through the peer respite, and I have seen it absolutely change and save lives in Massachusetts. I'm also part of writing the legislation in Massachusetts for our peer respite bill, and particularly interested in the LGBTQIA plus peer respite, which we are going to be opening in Holyoke, Massachusetts this fiscal year. I believe in this wholeheartedly. I have dedicated 12 years of my life to this. I absolutely know that the system, try as it might, is really flawed. I am somebody who struggles constantly with feelings of wanting to die. In particular, as a queer and trans person, having the first trans peer respite would be incredible. That is a dream that I could not even have imagined in my state of Massachusetts, despite the fact that we are the first state that had gay marriage. I believed that I had to make this an inclusive LGBTQIA plus peer respite to get it past, our state Department of Mental Health, because I didn't think they would care enough about trans people, because most people don't. I think that there is so much to offering affinity peer respites for BIPOC communities, for trans folks, for Spanish-speaking folks. There is so little out there. And there are a lot of us, and we are slipping through the cracks of the medical and mental health system. Peer Respite is a place where people can come and bring their whole self. They can talk about things that they have never said aloud before. They can talk about things like wanting to die, like not feeling seen, not being heard, being abused within systems and family. It is a place where anybody can come and be held in their darkest moments. I consider it to be the utmost privilege and an honor to do the work that I do. I consider it to be holy work in a lot of ways, to really be there with somebody in the worst moments of their life and to hold them. I can't imagine doing anything else. I really think that there should be one in every county of every state in the United States, and I think that they should exist worldwide. My hope with creating the first LGBTQIA+ Peer Respite in Massachusetts is that it will happen everywhere, that it will be a model
Excuse me,
everywhere.
but your time is up. Thank you.
Thank you.
Why don't you finish your thought?
I really just feel like this is something that could be utilized everywhere and should be, that this is something that the hospital cannot offer, that traditional services cannot offer. And it's not even to say that I think that they wouldn't want to, in a sense, offer it. It's that they can't, and we can.
Thank you. My co-chair has a question or comment.
Thank you, Senator Armour. Thank you for your testimony and for the work that you've done. Just a clarifying question. In Massachusetts, there are affinity peer-run respites, or that is something that you're hoping to
There
establish?
is about to be. We already have secured the funding with the Department of Mental Health to open one in Holyoke, Massachusetts, which is also where I reside.
Wonderful. Thank you for that clarification. I appreciate that. Thank you, Mr. Chair.
I just wanted to thank you for personally being here in person, and thank you for the work that you're doing. If I was to try to explain a little bit about what I'm understanding, and then we did Harm Reduction Center bill last year as a body from here. And one of the lessons that we had learned was that we have to be very, very, very intentional of meeting people where they are and accepting them where they are. And that is the first step to be able to get somewhere.
Yes.
Is that, and I think that's lacking in the existing systems. And the peer respite is allowing us to get to that point as a starting point, and then subsequently seeing how we can have real conversations and understanding, and perhaps moving in a direction from harm reduction, but then acceptance moving. Of course, you start with acceptance right at the first moment, but then seeing how what help can be provided to that individual. Is that fair?
Yeah, thank you.
Okay. And in your 12 years of experience, what are as we move in this direction, or we consider moving in that direction, what are the things we should avoid?
Definitely that these are all peer driven, that they're not clinical models, and that they do not exist on clinical campuses. You know, I think that the magic is in the fact that we all have been there. You know, I'm no different than anyone else on my team. I'm no different than anybody else who comes in to stay. I'm somebody who constantly struggles every single week. And they know that. I'm open about that. And that matters.
And if I was to share a scenario, and maybe you can help, there is, if a person experiencing mental health challenges, there are multiple layers to it. And there's trauma associated with that too. While there's a peer acceptance, there may be a role of medications as well. How do we navigate that part? And also recognizing that a person may cross a threshold which may move them towards being a danger to themselves. How does that one navigate that, and what's the backup strategy?
That is a multi-layered question. So we don't handle meds. People can take meds if they take medication. I have no personal stance on medication. If somebody feels it's helpful, great. If they don't want to be on them, great. People can have a friend, a family member, or a provider come and support them to take meds if they cannot take them on their own. We just do not handle them ourselves. In terms of, gosh, what was the second part of your question? Danger to self or others. So
The
on-
self, more so self.
What?
Danger to self.
So I'm going to be honest with you. We have had people come and stay with us at AFIA who were considered violent, who were considered that they might hurt themselves or they might hurt others. That didn't happen at AFIA, and there's a really good reason why that didn't happen. In the system, when you're boxed in and you're taken away from your family, from your job, from, you know, the things that you care about, and you're being forced to take medication, forced to go to groups, forced to do things you just don't want to do, that's going to bring out resistance. That's going to make somebody angry. And that makes sense to me. And at AFIA, we're not doing any of that. We're accepting someone where they're at, and we're meeting them there. And we're asking them, what is it that you want? What is it that you would find helpful? What would you find supportive? And so because there's so much choice and freedom there, people don't feel like they need to act out in that sort of way.
This is very helpful. I want to thank you for your testimony, and I also wanted to just make a comment that we care.
Thank you.
Thank you.
Thank you.
The next person on the list is Danielle Dutcher. I was online, just checking in. Not seeing them there. I think we have Matthew Barrett. Welcome.
Thank you, and good afternoon, Senator Anwar and Representative McCarthy Vahey. My name is Matthew Barrett. I'm President and CEO of the Connecticut Association of Healthcare Facilities. It's a trade association of 160 skilled nursing facilities. Do you want to say principally not for-profit skilled nursing facilities and assisted living communities. I'm pleased to be here to testify on two bills. The first is Senate Bill 275. And I do want to offer our support for that legislation. We agree that a general policy, that a sort of a blanket policy that denies admission to a skilled nursing facility based on a single incidence of a or historical incident of mental illness would be discriminatory. We think the Americans with Disabilities Act and similar state laws protect a person from such discrimination, but the notion of elevating it under a discrete or specific state law, we support and acknowledge that that would be an important public policy to adopt. Secondly, I do want to say I submitted sort of lengthy testimony on both bills, and so with your permission, I'll summarize my testimony on Senate Bill 273, the nursing home staffing bill. Beginning with on January 8th, 2024, just 2 months ago, the Connecticut Department of Public Health has issued amended policies and procedures, very specifically delineating new nursing home staffing requirements that align specifically with the enabling legislation that directed or mandated increased staffing from 1.9 to 3.0. These rules have the force and effect of law, because the enabling legislation also authorized the agency to implement under Policies and Procedures Authority while the regulations were pending. And we anticipate those regulations will achieve final passage. I do want to say specifically, these rules are not, these rules have the force and effect of law and are in effect now. They specifically delineate minimum staffing requirements under two sort of categories: licensed nursing personnel, which would be RN and LPNs, and an additional, and I want to emphasize, unduplicated additional requirement of 2.17 for direct care that could principally or is principally associated with the certified nurse's assistant position or nurse's aide, but also the LPN position. And so you can see the LPN position can float, if you will, but not in a duplicate, but it must be unduplicated between satisfying the license requirement and the additional direct care requirement. And so what Senate Bill 275 does that differs significantly from that is it enumerates or delineates specific RN requirements, LPN requirements, and CNA requirements, which under the current staffing patterns of nursing facilities would in one fell swoop really our analysis shows that 94% of the nursing homes would not comply with the 0.55 RN requirement. 94% of nursing facilities would not comply with the CNA requirement, and 22% would actually comply with the LPN requirement. But I think that indicates that Connecticut nursing homes are using in very great numbers the LPN position, which we think is undervalued in the way Senate Bill 275 is drafted.
Excuse me, Mr. Barrett, but your time is up. Thank you.
I only had one final point.
To complete that, please.
Yeah, that in addition, there are, from a public health perspective, I think that removes the flexibility that the nursing facilities have had for many years to assign staffing in the categories where they think is needed to meet another DPH requirement, also a federal requirement that they staff to meet the care needs of the residents. And then finally, there are fairly significant fiscal implications with because 74% of Medicaid nursing home recipients are Medicaid recipients. Increasing staffing and those amounts significantly would increase Medicaid expenditures and constitute an unfunded state mandate. And so with that, I thank you for the opportunity to offer comments on both bills.
Thank you. Senator Summers has a question or comment.
Yes, thank you for your testimony. On 273, which is the staffing bill, my question, I've heard from a lot of different long-term care facilities that they're going to struggle, if not be unable to meet this requirement because their staffing is fluid and it is based on the needs of the patient. So there has to be this flexibility to move between LPN, CNA, and RN as far as the delivery of care, and putting the categories in silos, I'll put it, is really putting them at a extreme impact if they can even hire the people to meet this requirement for those specific silos of care, which may in fact not be the most appropriate for the residents of that particular facility. Is that a correct assessment the way I'm describing it?
Yes, Senator Summers, I think you are correct in that assertion. And I would even ante up that a little bit by saying that with the 2.17 requirement associated with the CNA position alone, that really is an increase from the existing public health code requirement of 1.26 to 2.17. That's when you compare that to enabling legislation that updated or increased the minimum staffing level under Public Act 21-85 from 19 to 30. The CNA increase is almost 80% of the overall increases. And in this environment of staffing shortages, I don't see how our nursing homes could comply without having to turn to, and I think very unsatisfactorily turn to, temporary nurse staffing agencies that they've had to work, to rely on more and more, even before the public health emergency, but certainly in very increasing numbers during the public health emergency, and that's where we find ourselves now. On the other point, related to the other category of the license category right now combines RN and LPN. And it's not oddly, it makes sense to me that Connecticut is relying more on LPNs. But with 74%, with 22% in compliance, or strike that, with 22% not in compliance, I would see the shift away from LPNs towards the RN position, which is really a quality formula if you can hire the RNs. So there again, I would see our nursing homes increasingly turning to temporary nurse staffing agencies to have to meet these requirements if they were to go into effect as written.
Can I ask you, do you know of temporary staffing agencies? I know that the the amount of money that they charge in some cases, not all of them, but is extraordinary. Is there such a thing as a temporary staffing agencies for LPNs that you're aware of?
Yeah, I believe that the temporary staffing agencies, many of them from out of state, provide CNAs, LPNs, and RNs. And yes, I think you're correct. In fact, this is fresh in my mind because there legislation was introduced in the aging committee that would cap the fees that temporary nurse staffing agencies can charge skilled nursing facilities. And many of the speakers talked very directly about costs that were well in excess of 2 times or 200% of what they would normally pay for their own staff.
So if you can imagine 200% more than what you're currently staffing for a nurse or in your facility based on you not being able to comply because now we're looking at siloing you by licensure of RN, LPN, or CNA with ratios that this legislature has decided are appropriate, but that may not be necessarily appropriate for the patient in your facility. So I think that's really eye-opening for many of us. And I do support that bill in aging. I think it's a good bill. It caps it at 200% because it's just becoming untenable. So for facilities like your own, if you cannot meet the requirements, especially now with this siloing effect, and you can't hire or bring in temporary staffing through staffing agencies, do you ever run into where they're not available and you were just not compliant? Then what happens?
Yes, I think there are plenty of instances of that, especially when under the former policies and procedures that were withdrawn and reissued or amended by DPH, there was actually a stricter requirement, not dissimilar to the requirement in Senate Bill 275. Although that now withdrawn policy didn't spike out the LPN at 0.29, it did specifically increase the CNA category alone to 2.17 in a way where you couldn't count the LPNs, as even when providing direct care under that category. So there were a number of regulatory citations and violations issued by the Connecticut Department of Public Health during that period of time. And going forward with the revised rule on January 8th, 2024, I would still be concerned that there will be situations that while our nursing homes are very clearly overall and overwhelmingly staffing over the 3.0 level that was directed by the legislature in Public Act 21-185, there's still instances of during shifts or on weekends or other periods of time due to callouts where they dip below, probably not the 3.0, but maybe the 3.0, but they would dip below even the 0.84 combined LPN RN or the combined 2.7 that could be LPN. So I do worry about that. And I think as a first measure, they will go to the temporary nurse staffing agencies. And from a public health perspective, it's not the desirable outcome. The nursing homes have complained to me that it's not the sort of consistent assignment of staffing that they have, was longstanding their quality formula. And so it really would move us, I think, in the wrong direction.
Thank you for that. I think it's for people watching this hearing, it's a little confusing to learn of all the different regulatory requirements that we put on long-term care. Switching over to Bill 275, I wanted to ask you if you have experienced or if you know of some of your homes, perhaps, this has come up repeatedly, somebody who may be presenting as an Alzheimer's patient, who may be presenting as someone who has mental health issues, who is prescribed a psychiatric medication sometimes, I'm going to pick on Haldol, to help maybe terminal anxiety, being rejected from entering into a long-term care facility solely on the basis that they have received psychiatric help or care. And what has happened in many times, or what has been reported, is that patient is forced to be placed at home, maybe where a family cannot care for that patient, then back in the ER. I know that there are people that are going to be testifying on that today and submitting written testimony. So you're saying today that you agree that that should not be something that happens. Obviously, this is not a violent situation, et cetera, but something that should not be instantly rejected because someone has been either had a mental health help or coming from a psychiatric facility or has is prescribed a psychiatric medicine.
Yes, I do agree. And I am aware that there are recent federal rules that really, seek to crack down on the off-label use of certain antipsychotic drugs, and nursing homes are increasingly penalized when residents are prescribed those medications, and they potentially could be fined by the federal government for doing so. But having said that, that in and of itself is not a basis for denying admission to a skilled nursing facility. And even though I'm not familiar with the exact fact pattern that you described, Senator, I'm definitely aware of instances of alleged discriminatory behavior based on a broad category of a particular resident that has triggered Department of Justice investigations against Connecticut skilled nursing facilities. And this is why we have a very clear position that you may not have a blanket policy. A blanket policy in these areas is clearly sort of on its face discriminatory, and that you must evaluate these requests for admissions on a case-by-case basis. If there's a denial, especially, I think there should be heightened scrutiny on a denial with a person with substance abuse treatment issues or on medication-assisted treatment, or even with mental health diagnosis. And that the reason for the denial must really be clearly indicated in the case record when that happens. It is possible, obviously, under the law to deny admission, but it can't be based on the diagnosis in and of itself.
Just a follow-up question. So our referrals are electronic. So if you're in the hospital, an electronic request goes out. What would you say for someone who is maybe in the hospital on a psychiatric medicine? Maybe it's off-label because they are maybe an Alzheimer's patient that has terminal anxiety, but the record instantly comes back rejected saying, sorry, we don't have an appropriate bed, even though there's beds open in that facility.
In fairness, Senator, I might need a little more facts than that, because there actually is quite a strong body of law and a process in Connecticut that actually seeks to prevent the inappropriate institutionalization of persons with diagnosis like that, mental health diagnosis, in skilled nursing facilities. This grew out of the federal Olmstead Act, and in Connecticut. And around the country, but Connecticut has a pretty rigorous process. There's a contract with the Connecticut Department of Social Services. They refer to it as the pre-admission screening process, where they're seeking to make sure that Connecticut nursing facilities aren't inappropriately accepting persons with mental illness diagnosis who could be treated or cared for in a least restricted setting, perhaps in a home care environment. And the state does have a duty and obligation under the Olmstead decision, in my view, to provide home and community-based services for those when those circumstances are present. But so in other words, that may be in the pre-admission screening process, that they may say you may not accept this person with mental illness. They must be served in a different environment. But that would all be happening sort of behind the scenes, that review going on. In the case that I would be, what I think you would be more concerned about is when they pass the level, these screenings, and they're eligible for admission. That's when I think this enhanced scrutiny has to be occurring. And if it can be demonstrated that the admission is being denied based on the diagnosis alone, especially if there's a limited incidence of historical incidence of mental illness, that would be discriminatory on its face.
Thank you. That's what I'm getting at, and that we have, quite a few reported cases of the person is appropriate for long-term care. They've passed the pre-screening, but being rejected or being told there's not an appropriate bed when there are beds open for, various reasons. My last question, and I will let you go on to other things or let other people have chances. And I'm not sure if this is true, but I have been told by certain long-term care facilities that if they have a certain number of residents that are on psychiatric medications, it can affect their quality rating. Is that accurate? Or
Yes, I think.
somehow it can affect it, and it's a federal law. And I wanted to see if someone could explain that to me. Thank you.
Yeah, and first, I do want to express disappointment that there's a rise in number of cases that are being reported to you in this way, and I'm happy to follow up on any of them. I think what you may be referring to is the stricter review of antipsychotic medications that CMS is doing on nursing facilities to provide, essentially implement a policy that assures that nursing homes are not caring for persons with these underlying diagnoses and prescribing medications as a form of chemical restraint, which is really also clearly against the law. And so I think that may be what you're referring to. There's a, call it an anxiety from the skilled nursing facility community that if they accept these residents, they're at risk of being penalized and having lower quality ratings. All I can say is that in and of itself is not enough to engaging discriminatory behaviors that might land you in the crosshairs of the Federal Department of Justice for a discriminatory admissions policy.
Thank you so much for all your answers.
Thank you, Senator Summers. Thank you so much. I do not see any. Yeah, Representative Denning has a question.
Thank you, Mr. Chair. Thank you for your testimony. I'm a nurse and I'm very familiar with staffing ratios and needs in nursing homes. And my question is, as in your association, have you had any members that have failed in the past 5 years financially?
Yes, emphatically yes.
Significant? I mean, my question is and I'm kind of taking this over for Representative Cook, who's not here, is that we have patients that are not being taken care of. And I know it costs more to hire nurses, but the for-profit nursing homes are continuing to make a lot of profit. And I know that you can hire nurses and they are more expensive, and that they, if you go through a service, they cost more. And therefore you don't have the continuity of care because you really want to have people who are devoted to the people who are there. That's what you want, is a good culture of care in your institution. My question is there any institution that is paid a significantly higher more rate to keep their nurses than what the standard rate has been?
I'll try to answer your question to the best of my ability, Representative. It is a cost-based prospective reimbursement system that now has an acuity-based sort of add-on component to the rates. And so generally speaking, staffing costs are actually in the personnel costs are the highest costs in the skilled nursing facility cost structure. And so facilities that have long-standing or have higher direct care cost ratios, that should be reflected in higher rates to the facility. And then several years ago, not that many years ago, but several years ago, then Commissioner Deidre Gifford instituted 2 reforms in the way nursing facilities were to be paid. I think there was the view that just paying across the board inflationary adjustments was not the policy that this administration wanted to pursue. So they created an acuity-based component that I just mentioned a moment ago that would sort of incent or provide higher rates for caring for higher acuity residents, and your cost structure would reflect that. And under implementation right now or development right now is a value-based payment component that would reward your facility with, we hope, an additional incentive payment. And one of the areas would be your staffing patterns. Higher staffing patterns would be a quality measure that would award you more facilities. But there isn't a single rate that applies to every skilled nursing facility because all of their cost structures are different.
So would you rather, one last question, would you rather us not pass this bill and have much stricter regulation and higher fines for when this is violated with the current law?
Well, I would say that I view the current regulatory system to be quite rigorous and the fines meaningfully high. And so I wouldn't favor increasing the fines in any way, shape, or form. But if I had to choose, I would say don't pass this bill.
Thank you. Thank you, Mr. Chair.
Thank you so much. Thank you for your testimony. Thank you for staying with us for the time you have.
Thank you, Senator.
Next person on our list is Danielle Dutcher, on remote access. Welcome. And thank you for your patience with us.
Thank you. It means a lot to be here today. I'm actually in Texas, and I'm going to be presenting on maltreatment and trauma in special education. So I'm here in support of Senate Bill 370 for peer-run respites for people who are experiencing mental health crisis. This past year, I experienced a discriminatory traumatic event myself, and it completely shattered me as a person. I did have a solid support team in place that included family, friends, a clinical and mental health providers. However, these supports were not enough for me. And as someone who has access to privilege at times, it's important to note that not everyone has access to those supports that I did. And I do consider myself lucky to be alive today and speaking to you. Because at some point I lost count of the nights that I spent feeling completely alone and helpless, and really just wanting to stop existing more than anything. And this is exactly why we need peer respite. Night after night, I've suffered because the only option was to be committed. I'm privileged to have a team that understood that that option was not what would make the most sense for me. And, you know, have studied harm reduction, because we know that people who, are more 100% or 100 to almost like 100% more likely to commit suicide after being discharged from psychiatric hospitalization. A peer respite would give people like me access to something that's voluntary, non-carceral, and that's literally, life-saving. It's very difficult for me to be here and speak to you, and I have a lot of passion about this issue, but given the lack of support in our state, again, I just want to highlight how lucky I feel that I am to be able to speak today. Peer respite is, can serve as a lifeline for those that are in crisis in Connecticut. It will not only save lives, but it's more cost effective than our current clinical model. And what I really love about this bill is that it includes equitable measures to ensure that those at the intersection of overlapping discrimination have peer respites for them. So we're including Black, Indigenous people of color, the LGBTQ community, and Spanish-speaking communities. And one thing I did want to share is that I recently had an experience with a state employee where I told them that non-carceral voluntary programs resulted in me not taking my own life. And without skipping a beat, that state employee asked me to quantify what it was that I had gotten from a peer-led program otherwise. So I think that this conversation is something that really demonstrates the lack of understanding, training, awareness, and capacity that's endemic in the, what we have currently for people to receive support. For this reason, I really implore you to place value in the lived experience of folks like myself that are brave enough, because we need things that aren't clinical models and aren't run by the state for folks to feel safe. So I thank you for listening to me today.
Thank you, Ms. Dutcher, Danielle, for your testimony, and thank you for sharing your experience. I can speak for myself. This really has helped me be better able to understand why this is important. So I appreciate your testimony. Seeing no other questions or comments, we want to thank you. I hope you come back home safely when you're well, and then appreciate your help. Next on our list is Jeffrey Sento. Welcome, Jeff. Good to see you again.
Good afternoon, Senator Anwar, Representative McCarthy Vahey, and other distinguished members of the Public Health Committee. I want to start by thanking you for allowing me to speak here today. I don't believe that I could give you one good reason why we should have peer respite in the state of Connecticut. I want to give you 50,000 reasons why. In 2023, we lost 50,000 people to suicide across the United States. Peer Run Respite is one of those safety nets that would just catch a large quantity of those people who don't want to go and seek traditional healthcare services. In 2020, we legally incorporated as an organization. I represent rockingrecovery.org, and my organization's name is Recovery Innovation for Pursuing Peer Leadership and Empowerment, better known as Ripple. We were able to incorporate because that's what I decided to spend my stimulus check on. We are not funded by any other agency. We have an annual budget of about $1,200 a year. One of the things that we saw a need for immediately during the pandemic was all the people who were feeling isolated. They had nowhere to go, no one to talk to, and depression, suicidal ideations, anxiety, these are things that were going off the charts. We launched an online peer support group, and it quickly grew to be something a lot more than I anticipated it ever becoming. I was one of the lucky few who had an essential job working at a plastics plant, making barriers between cashiers and customers at things like pharmacies and grocery stores. While I was working, I received a phone call from an individual from our group crying on the other end of the phone, just asking me, Jeff, what would happen if I called Mobile Crisis? Knowing that this is more than I could deal with at work, I got in touch with my co-host, Desiree Barton, who's also a recovery support specialist. She put out the message on social media. We had somebody who was in crisis. We opened our Zoom room, and within about 20 minutes, we had people from as far away as New Jersey chiming in to offer support. She sent me a screenshot about an hour later, and it was a Zoom room with 3 recovery support specialists and the one person who was in crisis sleeping in the corner on her screen. And they told me that they were not going to shut down the room because they wanted her to be with folks when she woke up. They didn't want her to be alone. A peer run respite gives us a very valuable tool in the sense that it gives us the needed time that we need to help other folks. After one of our alternative to suicide support groups, we had a member ask us for a little extra time, and Desiree offered to stay on with her. That call lasted another 14.5 hours. That was a conversation that should have happened in a respite. Desiree and I work off of a laptop and a cell phone. That's what we have access to. And we have held hundreds of groups over the last 3 years. We saw a need, we tried to fill it. Right now, I'm telling you, as far as peer respite, there is a need, and I will do anything that I can to help you fill that need. Thank you.
Wow. Thank you, Jeff. Thank you. Very, very powerful words. And I don't have words. I don't have questions. I just have gratitude.
Thank you.
Thank you for what you're doing. Okay. You're going to be staying here for the timing, right?
I'm not going anywhere.
Good. I need to come and hug you. That's why I was asking. Next person on our list is Commissioner Carlos Martinez Rivera. Welcome, Commissioner.
Good afternoon. How you doing, Senator Anwar and members of the Public Health Committee? I just became commissioner of the Commission for Persons with Disabilities in East Hartford this year, after a 6-year battle of wanting to be on the chair, wanting to be on the chair, but I took the decision that I wanted to serve people. I believe that the Recovery Support Specialist Committee, the community as a whole, we are very powerful and we have each other's backs. When I had COVID-19, I believe in 2021, I went to Jeffrey, to his peer support group, after having an experience at Middlesex Hospital where the doctor cussed me out and told me that I was going to give his family COVID-19 and kicking me out of the hospital. Jeffrey quickly went on the Middlesex website and started typing an email to the director of the hospital. 2 days later, the director of the hospital called me. She was stuttering, couldn't even say anything. She was like, "I'm sorry." And I was like, Okay. And I believe as the person that is a recovery support specialist, the respite will work because we will have a lot of people that care about people and people certified in order to serve others. It's like Dr. K taught us, nothing about us without us. And also that we walk the walk and we talk the talk because we are members of the mental health community, serving other people in the mental health community. So I believe that Connecticut needs to be in the future, and we need to have peer ran respites because it helps others and will help me. Thank you.
Thank you. Don't go away, Ed. You may have somebody who may have a question, but I just have a comment. Thank you for the work that you do, and thank you for being such an engaged citizen, not only on the individuals who are experiencing challenges and disability, but also on the town issues. I've seen you at almost every town council meeting in East Hartford. So you're a true engaged citizen who's trying to make a difference, and you make us all proud.
Of course. Thank you so much. Any questions?
Representative Terciak.
Thank you very much for the work you're doing and for your testimony. Dr. K, is that Karen Kangas?
Yes.
A good example of how one person can make a profound difference, huh? Good for you. I'm sure she's proud of you. I'm proud to know her, and thank you very much for.
So I want to say something on record. When I took my recovery support specialist course in 2015, because I have ADHD, I'm always hyper. Dr. K spoke with the people at Institute of Living, and they gave me like a special microphone. And then I could, if I needed to get up, I get up and I do what I needed to do, and I could sit here at the course and I could still talk if I wanted to. And then at the end of the course, when she was speaking, she gave the most motivation speech about me. And it was the best thing and changed my whole entire life. I have a very different aspect on the peer community. We are strong, we are here, and we're willing to help.
Great. Thank you very much. Thank you for your indulgence, Mr. Chair. I appreciate it.
Thank you.
Any other questions?
Carlos, thank you so much.
Thank you.
Next person on our list is Cara Delaney. Welcome. Good afternoon, and thank you for being here all day or all morning and afternoon.
I'm glad to be here. Thank you, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Dr. Cara Delaney. I live and work in Farmington, Connecticut. I am a practicing obstetrician and gynecologist and a complex family planning specialist. Thank you for accepting this testimony in support for House Bill 5424. I have the privilege of taking care of patients throughout their lives. With maternal mortality on the rise, the trust between myself and my patients is essential. This bill is a way for Connecticut to once again show themselves as a leader for expanding patient rights and provider protections. HB 5424 ensures that healthcare institutions do not prohibit providers from delivering medically accurate information and referrals that may not be in line with institutional policies or expectations that prohibit certain types of healthcare. And this includes full spectrum reproductive health care and gender affirming care. This bill is not based on theoretical situations. I have previously trained in settings where I was not allowed to talk about abortion as an option, even when a patient asked directly for that information. As a healthcare provider, the feeling of helplessness is one of the worst chest-wrenching moments. The lack of communication with patients has been seen as a lack of support, and patients have bared the brunt of self-referral. Limitations on counseling in the exam room will have patients floundering about next steps and seeking unverified sources for information on often stigmatized medical subjects. To practice at the highest level, we want to practice openly without fear of reprisal. This is not about abortion care alone. It is about gender affirming care, birth control, sterilizations, and other ways that outside forces can restrict discussions about medical decisions. Passing this bill is also an opportunity to improve health equity in the state. Self-referrals will be more difficult for patients who do not speak English, who have limited family support, limited internet services, and less financial means. By protecting providers' free speech to give medically accurate information to patients and provide timely referrals without the specter of employer retribution, we take a step forward towards progress in the health equity space. While I do support this bill, I want to suggest changes to Section 3, which specifically calls out services related to complications of pregnancy, including but not limited miscarriage management and ectopic pregnancies. Medicine is nuanced, and I firmly believe that we should avoid legislating the practice of medicine. I do think that miscarriage and ectopic pregnancies are important and can be life-threatening. But I do suggest some changes in the language to that section. So I support HB 5424 and respectively urge the Public Health Committee and Connecticut General Assembly to vote in favor of this bill. Thank you for your time.
Thank you so much, Dr. Delaney, for your testimony. Do you have a written testimony with some of the changes that you have suggested?
I do have a written testimony, but I did not include the changes.
Would you be able to share the specific changes with us so we have that in written format?
I will do that.
Thank you. And are you able to speak a little bit when your employer was restricting your communications?
I can say that I was not in the state of Connecticut, but there are certain ways that employers can exert power on their employees, and it can result in not being able to communicate with our patients as fully as we would want to. And I, at that time I was not in the state of Connecticut. I was elsewhere in a state that now has banned abortion care.
Okay. But can you speak to the internal trauma and the moral injury that a physician or any clinician would feel when something like that is happening?
Yes, sir. As physicians, we take oaths to uphold our patients and our patients' autonomy to the best of our ability. We want to perform our healthcare duties with integrity and compassion. And if we're not able to communicate with our patients, to counsel them and to refer them to trusting sources, then we are not able to uphold these types of oaths.
Thank you so much. This is helpful. Yes, Representative Dauphiny has a question.
Hi, thank you for coming today. I'm just curious. It sounds like where you were working, you were limited to what you could say and couldn't say to your patients. Is that correct?
That is correct.
I just wondered why you chose to work there. If there were a place that wouldn't let you do that, wouldn't you want to go to another place? I'm just trying to understand.
That's a really great question. And it's really timely in terms of how practices are currently after the overturning of Roe versus Wade. So there are 15 states that have currently banned abortions. And so while physicians that are practicing in those states would rather be in places where they could fully practice medicine, many of them have chosen to stay there to take care of their patients and to take care of patients that are not able to move and to seek employment elsewhere. So there are lots of reasons why people stay and work in places that they feel like they cannot fully practice medicine.
Thank you. I appreciate your testimony.
Rep Rader.
Thank you. Thank you so much for your testimony and for being here today and sharing your personal experience as a physician. It's the best example of why we're considering this legislation. And I just wanted to make a comment and then a question. You spoke about, is it 37 states that you believe now have limits on abortion care and reproductive care?
So it's 15 states.
Yeah.
And then 22 states have not bans, but restrictions, and then there's other states that those types of bans or restrictions are currently in courts.
Right. And so it would make logical sense that we may be, and you can speak to this too, having an influx of patients seeking out care in states like ours, where those services are still protected under our law. But understandably, there are some medical facilities due to administrative reasons or others that are trying to limit the care you can extend. So I'm just saying that your services are even more valuable now in a state like ours. And the reason for this legislation is even more important now because the ability to seek this kind of health care in numerous other states has become limited. And to your point, so I just wanted to ask, do you see that there's actually an increased need for this now than maybe even a few years ago?
I think there is so I don't know if there's an increased need from the standpoint of like patients are directly coming to Connecticut in terms of that type of volume, but I do think that since the overturning of Roe versus Wade, that people have a better understanding of what birthing people have had to deal with for many years. And this is something that is not new and is coming up now because of the way that reproductive health care has been highlighted. I hope that answers your question, Representative.
It does. Thank you.
Okay.
You're being really honest and I appreciate it. Thank you so much.
Thank you, Rep. D'Amico.
Thank you, Mr. Chair. Thank you, Dr. Delaney, for coming here to testify. I always enjoy seeing people from Farmington come to testify in front of us. So there's a piece of testimony that was submitted by someone also in favor of this bill 5424. And she talks about what this bill does and what this bill does not do. And I just want to read you a line or two from it just to elicit some response, if I could. She says that what it does not do is force any provider or patient into providing or participating in care that they do not want to. And then she goes on further to say what it actually does do, it actually protects religious freedoms by ensuring that providers and patients who do not subscribe to a certain set of beliefs are not forced to subscribe to or orchestrate their medical care around other people's religious beliefs. Would you say that you would be in agreement with those statements?
Yes, I am in agreement. This bill does not force anybody to take part of any procedures or conversations that they do not feel comfortable with. What I call this type of bill is a conscious provision. So for people that feel strongly or feel like they want to provide medically accurate information to patients, they have the ability to do so without fear of reprisals from a place that they work at, their boss, etc.
If I may, one more, Mr. Chair.
Please.
So in the bill, and maybe this is already, I might have missed it. You might have had this discussion with one of my colleagues, but in the bill, it refers to medically accurate and appropriate information and counseling. Is there any reason why a hospital would not want their members of their staff to give medically accurate and appropriate information and counseling to their patients?
That's a great question, and I wish the answer was no. But I think that if you are at certain places that have policies based on that have policies that that are like morally based or have religious aspects to it, there are certain things that come into medicine from those types of policies that could prevent open conversation with patients. For instance, in other places in the US, such as in Texas with the bill SB 8, which I'm sure you guys have heard about, providers cannot speak about abortion. And a lot of institutions have put in policies where they cannot refer patients for abortion care as well. While this is hopefully not happening in Connecticut, I think that this bill will put Connecticut as a leader in terms of how we are protecting our providers, and then also making sure that patients are getting care that they respectively need.
Thank you very much. Thank you, Mr. Chair. Appreciate it.
Thank you. Senator Summers.
Yes, thank you. And thank you for being here. I have a couple questions. First, are you aware of any hospital in the state of Connecticut that the practice that you've described where you came from is happening now?
I am not.
Okay. I keep getting asked, why does Connecticut need this law if we're providing a solution to a problem that's not existing here in the state of Connecticut? So that is interesting to sort of digest. In addition to that, I would like you to walk me through, if I was a patient coming to see you in your former place, which is not Connecticut, when you say that you would, you could get in trouble from your boss. If I was a woman going in to see you for a particular procedure, what would the conversation be like? If I'm asking you about an abortion service, what would you be allowed to respond? And how would your boss reprimand you, or what would happen to you if you gave me accurate information? I am not somebody who believes that the government should get in the middle of a doctor and a patient. So I would like to have you walk me through what that looks like.
So in terms of what that looks like, you would still be able to counsel the patient as best you can about options. But if you were not, for instance, allowed to refer, you could do things that are not within the policy and be risking your job. So you could give the patient information via a note. You could turn your computer screen so that they could see what you were looking at in terms of an internet search. There are definitely ways that that people have shared information with patients that are not going to be documented, so that we can still be within the oaths that we took in terms of providing accurate medical care. So I'm not saying that we as medical providers are not subversive in some minor ways, but if we are fired, if we are penalized, it's going to prevent other people from being able to care for patients in the best way possible. And we would not be able to take care of that population of patients anymore. And so the consequences of not abiding by these policies are really huge.
So are you here because of that reason, that you couldn't provide the kind of care that you wanted to for your patients in the other state, and you came to Connecticut because you can?
I'm here because I believe that that the patient and provider relationship is sacred, and that really the only way that we can cultivate an environment of trust between ourselves and patients is to let the patients know that we are going to be at their side, walking with them, giving them accurate information. So while I, as a sole physician, do not know of any cases in Connecticut, it doesn't mean that it is not happening. And it is also helpful for the future. And to let patients know that the state of Connecticut is in alignment, that they trust them, and they also trust any conversations that happen between them and their providers.
Thank you. I meant, are you in Connecticut? Sorry, not why are you here, like to testify. I meant, did you come to Connecticut because of that? But thank you for your answer. And and I do appreciate it. Do you know of anybody or your colleagues in the former state that may have deviated from what was required of the hospital? Did they lose their credentials? Did they get fired? What happened?
No, not that I know of, like in those types of cases, but I know that there have been cases of people that have not been allowed to practice in the state because the medical boards have not let them in because of how they practiced in other states.
Thank you.
Thank you. I just wanted to also follow up on some of the questions. I'll start off with a statement. I agree with the mindset that what is going to happen between a physician and a patient is sacred and it needs to be protected. But if the physician's employer is going to get in the middle of it, then the government and the state has to get in the middle of them so that they can actually let the patient and the physician be able to make the best decision going forward. And I think that's what this bill is about, frankly. It's not getting in the middle of it. It's trying to keep people from the middle of it. We're talking about Catholic institutions. We have not been able to say it, and then let's have that conversation, because in the state of Connecticut, there were mergers that were in plan that did not move forward because of the concerns of many of the people who have been public about it, that did not want those mergers to happen because of the what is called the ethical and religious directives. And I think your concern and your testimony is referring to the ethical and religious directives that would have some limitations to the care that women will get for their reproductive rights, right?
That's correct.
And so it's not coming out of the fact that you had an experience in another state. The fact that there is a active effort and there's a directive for some of the institutions, even in the state of Connecticut, which follow that path. It is for that purpose. And could you also, if you're able to share the diversity or the type of populations that some of the institutions, large institutions serve, and then how they may be lack of opportunities for care for the individuals in these institutions?
I am not a part of a religiously affiliated institution myself. And so I cannot comment on what types of populations that they currently serve.
Okay. And I may have a few more questions, but what I'll do is I'm going to go to my friend, Representative Dauphiny, and then we'll come back and circle around if others have any questions. Representative Dauphiny.
Thank you, Mr. Chair. I know sometimes I've already asked a question, I know, but sometimes things come up and it makes you think of other questions. So you had said that in the states that you practiced, you were limited, but in this state, abortions are readily available and those sorts of treatments you spoke about are readily available. So there are choices on where you're working, and this bill pertains to this state. Can you speak to that? I'm just a little confused.
So access to abortion is one thing. And then the ability to actually get an abortion is another thing. And so when you arrive in an emergency room or in a hospital or a clinic, you are going there because that's where your insurance is, because that is where your zip code is. And so you don't go in thinking that you are not going to get the same type of care or counseling or referrals as you would anywhere else. And so I don't know if I answered your question, but patients, while they do have access to abortion care, that's not just what we're talking about too. They could need follow-up care, and they could need access to, yes, abortion care and those types of services that they may not be able to get if they arrive in one clinic or one emergency room than if they went to one like 20 miles away.
So the facilities that you worked in, had you signed an agreement to the Catholic Hospital ethical directives that they had, or was that your limitation? I'm just, again, trying to understand.
So you're talking about my, when I was in in a previous state.
When you said you were limited, yes.
It was limited by the boss that I had at the time. I did not work for a religious institution. I do not think that this pertains to only religious institutions.
So it's your belief that we shouldn't have hospitals that embrace religious beliefs that wouldn't want that kind of counsel to their patients. Is that what you're saying? Is that why you support this bill?
Like I said, I don't think that this is specifically about religious institutions. This could happen in any institution.
I don't know of any other institution that would limit it. So I'm thinking it is about religious institutions, but thank you for your comments.
Thank you.
Representative Garcia.
Thank you very much. Thank you for coming here in front of us and talking about your experience. I appreciate your recent comment that this isn't about specifically about religious institutions. This is about informing patients, providing access. In my lifetime as a psychiatric nurse, I have seen where there are nurses who are not in favor of ECT, and yet it's being recommended for a patient. And I've never seen a nurse get disciplined for saying, I don't want to participate in the pre-op medication, or I don't want to participate in the education. The hospital makes sure that the patient gets the information and the services that are needed, and nobody's forced to violate their rights. So thank you for appreciating that this is about not just abortion. This is about protecting both providers and patients. That's not from another state, and it's not abortion, but it's my experience about things where healthcare providers feel differently. And nobody would ever think just because they were the charge nurse on second shift, or because they were the psychiatrist in charge of this or that they had the right to keep options from the patient that other people, that the patient might be interested in. So thank you very much in testifying here for the rights of all nurses and patients in particular that I've seen in my past. Appreciate it. Good job. Thank you.
Thank you, Representative.
Thank you, Representative Persiak. Seeing no other questions and comments, we appreciate you being here. Thank you for your testimony.
Thank you for your time.
Thank you. That brings us to the next person on our list, which is Frank Carbone. Okay. Sorry about that. Denise Lumpkin. Yeah. Thank you for everyone who's here and the ones who are online. These are complex and important and emotional bills, so we just are taking our time, so appreciate your consideration. Welcome. Thank you.
Good afternoon, senators and representatives and distinguished members of the public health community. My name is Denise Lumpkin. And I'm a person in recovery for mental health. I am here to testify to support the SB 370 peer-run support respite centers. A few weeks ago, I went what I call a meltdown because of things that were going on at the group home. I called my sister. She said I needed to go get a hotel room to get some rest and a break. I live in a group home with 22 people and staff. There was no respite for me. So the other choice is going to the hospital. That would make matters worse. You can help a lot more people for less money than having them get traumatized in the hospital and make matters worse for patients. Where people can get better, and if they had peers who understand to talk to and to place and a place to feel peaceful. We need these. We need these respite homes. When I needed one, I didn't have one, a respite to go to. They were going to send me to the hospital because staff did not know what to do with me. And that scared me. Instead, they called into community, and I worked with the crisis team to help me stay out of the hospital. This time it worked. But who's to say if it would work next time? Therefore, I am asking, pleading, that you please pass this bill and create peer-run respites in Connecticut to support people who are experiencing a mental health crisis in the most humane and voluntary way possible. Thank you for the opportunity to speak and share my experience with you. To see this would mean the people that need care from a peer and the kinder world. Thank you.
Thank you. Thank you. Denise, we appreciate your testimony so much. Thank you for being with us this morning and this afternoon. And we truly, truly appreciate you being here. This was very powerful and very moving, and thank you for that.
Thank you.
And my co-chair has a comment.
Denise, I would like to add my thanks, especially because it comes at a cost to come before us. It takes a lot of energy and emotion, and you are making yourself vulnerable so that we can learn and hopefully help so many other vulnerable people. So thank you for what you've just given us, the gift you've given us. We are grateful. Thank you. You have a good evening and take care.
Thank you. We'll move to the next person on our list, which is Shannon Carter. Welcome. Thank you for being here.
Good afternoon. Can you all hear me?
We can.
Cool. So my name is Shannon Carter. I am a lifelong Connecticut resident. I'm a person who struggled with their mental health, and I've worked in public health for the majority of my career. I'm here to testify in support of SB.
Shannon, if you can come closer to the mic.
Closer?
Yeah.
This better?
Yes, that's
Okay.
better. Thank you.
Yes. Okay. I'm here to testify in support of SB 370 peer respite centers. And I'd like to share like a little personal anecdote to kind of illustrate that. So when I was 15, I was hospitalized for suicidality. Amidst dealing with anxiety and trauma, I had a few suicide attempts. During this time, I felt immensely alone and alienated. I struggled to connect with peers and my family. I struggled to see a way out, and I needed help. The option for help at the time was a trip to the Bridgeport ER, leading to a hold in the psych ER and a 5-day stay at Silver Hills. Even with a stay at what is considered the nicest, for lack of a better term, psych hospital in Connecticut, there was negative consequences to my hospitalization. I had trauma responses to institutional settings. Heavy doors would send me jumping out of my seat. My feelings of alienation and inability to connect with my peers worsened. I felt like I had no control over my body or my life in a way that led to continued and worsening self-destructive tendencies, including self-harm and substance misuse. Further, because of the trauma around it, I was resistant to engage fully in therapy for years afterwards. As an adult, I continued to have suicidal ideation, but due to fear of being hospitalized, I avoided engaging in mainstream systems of care. I leaned on friends with similar experiences, even though they were not necessarily equipped. While my experience of hospitalization kept me alive for a few days that I was in there, it created a much deeper uphill battle to mental health recovery. 13 years out, almost to the day actually, I have not finished disentangling the impact of my hospitalization on my life. I am also want to acknowledge that I'm a white middle-class person. I appear to be able-bodied. I'm not someone who is systemically dehumanized by a carceral medical system. I was a minor at the time, and I didn't lose my job or my housing. And even with those insulating factors, being hospitalized stripped me of a sense of autonomy and made it harder for me to recover with the intersecting mental health crises that I was dealing with. Therefore, I'm asking that you pass this bill and create peer-run respites in Connecticut. This would support people experiencing a mental health crisis in the most humane and voluntary way possible. Also, as a non-binary person, I'm particularly interested in the trans affinity respite. I hope you will consider my written testimony as well, which goes into broader detail about the broader context of these types of programs. Thank you.
Thank you so much for your testimony. We appreciate you. Seeing no questions or comments, thank you so much for being here. We're going to go back online for a little bit to hear from Dr. Mark Becker. Dr. Becker, welcome.
I thank you. Honorable Chairman, ranking members, and distinguished members of the Public Health Committee, thank you for the opportunity to testify in support of SB number 368, an act concerning source plasma donation centers. My name is Dr. Mark Becker, and I'm the Corporate Medical Director for Grifols Plasma. Grifols is a global healthcare company that develops medicines derived from plasma. Grifols operates one of the largest networks of plasma donor centers in the US, including in the states of Massachusetts, Maine, and Rhode Island. Grifols does not currently operate any source plasma donation centers in Connecticut due to regulations that differ from federal regulations in the areas of staff qualifications, supervision, training, and duties. SB 368 will direct the Department of Public Health to adopt regulations that follow established federal laws and regulations for source plasma collection centers. We believe the federal regulations are comprehensive and have a long history of ensuring the safety and quality of medicines made from plasma, as well as the health and safety of the donors related to the donation process. We appreciate the Department of Public Health staff and their efforts to draft regulations concerning source plasma donor centers. However, these regulations place substantial burdens on potential plasma donor center operators. In particular, the requirements to qualify for the role of center director, which include a minimum of 1 year of specialized training in blood banking, are more restrictive than federal regulations, and due to the limited number of physicians with these qualifications in the state, make it very difficult to both identify and maintain qualified candidates. While this highly specialized background may be necessary in a hospital setting where blood and blood products are being ordered and administered to patients, or where therapeutic apheresis is taking place for patients with serious medical conditions, the primary activities taking place at a source plasma donation center are the assessment of donor eligibility based on federal requirements and the collection of plasma for further manufacturing from healthy donors via an automated plasmapheresis process. Plasma donation is a low-risk procedure, with most donors experiencing no adverse effects. To meet federal eligibility criteria for plasma donation, individuals must be in good health and free of serious chronic medical conditions on the day of donation. Donors that do not meet these criteria are deferred from donation and counseled to seek medical advice from their personal healthcare professional. Federal regulations require that the center director be licensed to practice medicine in the state in which the center is located and have been trained to oversee donor center personnel and the relevant procedures related to determining donor eligibility and collection of plasma by the automated apheresis process. We believe that the training programs we have in place for center directors are robust and that they complement the breadth of knowledge all physicians obtain during their medical training and clinical practice. Across the source plasma collection industry, licensed physicians from both primary care and many specialty backgrounds have served as center directors and have competently provided necessary oversight to ensure donor health and safety. We want to be part of the communities in Connecticut, and we are committed to the health and safety of our donors and ultimately the health of the patients who rely on our medications. Thank you for your consideration of this legislation pertaining to the collection of source plasma in Connecticut.
Thank you, Dr. Becker, for your testimony, and thank you for being here again today. And we welcome you almost every year, and we're going to welcome you this year, and hopefully we'll get this right this time. But you're always welcome to come and speak to this committee. Seeing no questions or comments, we'll move to the next person on our list, which is in person over here, Jennifer Tirado. Welcome. You need to turn it on. Perfect.
That helps. All right. Good afternoon, distinguished members of the Public Health Committee. So my name is Jennifer Tirado, and I am in support of SB 370 of peer respites in Connecticut. I'd like to preface this with, I'm an employee at Advocacy Unlimited. I am the coordinator of a network called Alternatives to Suicide, the first of its kind in Connecticut, a harm reduction approach to suicide prevention. And I'm a trainer in multiple peer support disciplines in another position through Wildflower Alliance. So I would like to share an anecdote with you all, if I may. Upon being admitted to one of my hospitalizations, I've had a few, my personal belongings were sifted through, as is the norm in this environment. And one time there was a male staff that noticed I had a notebook with spiral binding. This notebook was my journal at the time, one of my most prized possessions. He offered that I could keep the journal on the unit, but if that's what I wanted, he would have to break the binding since it was made of wire and I could potentially hurt myself with it. The only way to keep one of my most prized possessions would be to watch someone destroy it in the name of safety. I was going to tell him, no, please put that away if that's my only option. I would rather not have it at all. I've dealt with loose leaf paper in a unit before. However, another staff whispered to him, just let her have it, it's her journal. He paused for a moment, his eyes full of paternalistic concern, and then with some hesitation, he did hand me my journal, binding intact. Because of this second staff person having empathy and being human, not blindly following procedure, I was able to have my journal with me. I was trusted with the binding of my own journal. Tiny windows like this really stand out in that kind of environment because of the restrictions. And I could be glad, and I am, that someone stood up for my rights in that moment, but I'm more saddened that this is what mental health care looks like, that I'm glad to maintain scraps of dignity. I know I'm worth more than that, and so are all my peers who are testifying before you today. Destroying that binding, honestly, even suggesting it, was so hurtful. And if I were in a peer respite, I'd like to say, having my journal with me would not have been a question. I would not have needed to negotiate my dignity or whether my belongings should remain intact for my own safety. So that's what I have to say to the state of Connecticut. If the hospital is my only option, please put it away. I don't want it. What I want is someone to come to me with understanding and say, I can keep what's helping me, even if it looks dangerous. What gave me hope is not the person who is following procedure. It was a person who decided to follow their own mind and have empathy. By the way, that person was right. I never hurt myself with that binding. If anything, that journal really helped me through the hospitalization. I was able to maintain hope in that moment because someone didn't follow protocol. Sometimes it's a protocol that risks harm in the name of safety, and that's what hospitalizations do. The wired binding that seems so dangerous in the moment can actually be the very thing that's keeping us together, especially if there's someone by our side who trusts us. This is what we need more of. This is what peer respite can offer. Thank you for the opportunity to share my lived experience.
Thank you, Ms. Tirado, for your testimony. Thank you for the work that you do. Tell me about the work that you're doing, and then if you can share with you how you're making a difference.
Sure. Thank you for asking. So we provide community-based support groups throughout the state. We get other organizations that are doing it now to get funding through DMIS, but we originally were funded on a COVID grant. And we provide community support that's all peer-based, non-clinical, and is a harm reduction approach to suicide prevention. Actually, a couple of my facilitators are here today who are contribute to the network. And we make a difference because people can come to us and not have to worry about restrictions, not have to worry about hospitalizations. They could speak frankly of suicidal urges. And instead of jumping what I call the panic switch and like, oh, you got to go hospital now, they can rely on their peers. They can reach community and understanding and a sense of connection. And together we'd explore what it means, what has to die so that we can live. Usually something has to end or change in someone's life when they're contemplating the thoughts of suicide. And we discuss it together, and folks get that sense of connection and purpose. And that's what's often missing. As I could tell you, I've spoken to many, many people who've been suicidal, and there's always a sense of lack of connection and a lack of purpose. And we really come together to just provide solidarity to one another.
I wanted to just, the mindset is that when we start to talk about suicide, we say trigger alert. So there's a fear as a society that we have, and that fear is at a much higher level in the healthcare world. It is super protective from maybe legal reasons, but also from their understanding perspective. And your focus and their work is embracing that conversation and not having that fear lens. Help us break that down, because this is completely different to how majority of the people are hardwired in Connecticut.
Thank you, Senator. Yes, we really like to break down the conversation, and we find that because of that, what you're saying, and I know people do it for good intentions, people get afraid to go to hospital. And oftentimes clinicians will ask me, oh, is this the first, is this where people go when they're before they go to crisis? And I often say that actually this is where people go when crisis services have failed them. I could speak from my own experience and people who I know, that we go to the hospital. Oftentimes we receive services in other regards. Some of us may take medication, some of us have therapists. And we know, because of what you're saying, it's true that there's some things we cannot tell our therapists. There are some things where even the clinicians we trust the most, there's a limit to what we can share with them. And when we're in group together, we can talk about that openly. And I know that's tough for some folks to grasp, but it works. And Sarah Davidow was speaking to this earlier today. There's increasing support that alternatives to suicide is proving itself to be evidence-based. One of the biggest factors that changes is people's relationships to their thoughts of suicide. It doesn't necessarily stop the thoughts of suicide. What it does, it changes a person's relationship to it. So instead of thinking, oh, I'm feeling suicidal, I should end my life, they may start thinking, well, what has to change? Or what do I have to change in my life? Or what connections do I have to make? But we're seeing that the use of force and coercion, it's proving itself in studies that I have attached in citations in my testimony, that it's not working. And we need to try something else in Connecticut. We really do. We're really overdue for this.
And Mr. Otto, if somebody's there who has not asked for any help, who's listening to you right now in our conversation, they have underlying issues which are resulting in them having suicidal ideations and thoughts. If you were to talk to them, what would you say to them?
Well, I would say that, first of all, I've been there, and thank you. First, I would thank them for sharing that with me and confiding in me, because that's a hard thing to talk about when many of us have been traumatized by the system and being sort of hospitalized for it. And I would ask them what's going on in their lives. And is there something that has changed recently to make them feel suicidal? And maybe share some of my experience and just really explore with them, what is going on, what is something, what is something that we have to change? Is there anything in your life that we have to change? Is there anything that we can talk about? Is there anything that the group can provide you right now where we can't, and I'd be honest with them, I can't fix as much as I'd like whatever's bothering you, but I'm here to listen and I'm not going to call any force on you at all. And often that's something that could really get folks to open up, especially the whole group of people who understand what it's like can be surrounding someone saying that to them.
And does your group have a website?
Yes, thank you for asking. Our website is Toivo. I work at Toivo Center Advocacy Unlimited. It's toivocenter.com/alternatives to suicide with like dashes, alternatives -to-suicide. I did reference it in my testimony.
But Toivo is TOIVO
Correct.
.com.
Okay,
toivo.com. Is it
No,
starting?
toivocenter.com. I apologize. toivocenter.com, all one word.
Okay, toivocenter.com,
Yes.
CENTER. Okay, thank you. Seeing no other questions or comment. Oh, wait. Representative Claire DeCiccio. Thank you.
Thank you, Mr. Chair. Thank you for being here today. And I think it's really important for all of us to hear all of your, your personal testimony and the struggles that people go through on a daily basis. You had mentioned at some point in your testimony about how some people don't want to share everything with their therapists, but and I may not have heard you and I apologize. Did you say why?
Great question. Thank you, Representative. So often we don't because of that liability that the therapist may feel to call crisis. And we may be in a place where we've been hospitalized. I've been hospitalized a few times, and I know that I know that's my only option. Honestly, when I'm feeling at my most terrible, I don't want to even tell anyone because I know where it's going to lead. And I know it's only as very limiting effects. And that's why people will not share with their therapists. Oftentimes they feel more comfortable sharing with people lived experience.
Thank you for that clarification and thank you for doing what you do on a daily basis. I know we appreciate it up here and the residents of the state of Connecticut do every day. Thank you.
Thank you so much.
Thank you, Representative Claire DeCiccio. Okay, thank you so much. We'll move to the next person on our list, which is Claire Serkis. Welcome.
Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Claire Serkis, and I'm a second-year medical student at UConn School of Medicine, and I'm a resident of Farmington. I want to thank you for accepting this testimony in support of HB 5424, an act prohibiting adverse actions against healthcare providers for providing certain healthcare services. This bill would protect healthcare providers offering medically accurate information and counseling to their patients and provide needed healthcare in line with the accepted standard of care for their patients facing pregnancy complications. As a medical student and in my time working at Planned Parenthood before medical school, I cannot even count the number of times I met a patient who came to us with no information, misinformation, or disinformation after seeking care at an institution that does not provide comprehensive reproductive health care or restricts their providers from even discussing it. And that is only accounting for people that were actually able to make it to the clinic that provided the services that they needed, excluding the many patients who may have wanted or needed more comprehensive care but never got to a place where they could receive it. Access to comprehensive reproductive health care and gender-affirming care are not only the standard of care according to the governing medical professional organizations, they are absolutely legal in Connecticut. And more so, Connecticut has been a leader in a time when so many patients are being unjustly denied access to this essential and often life-saving care. Despite Connecticut's leadership, 1 in 6 hospital beds in Connecticut is in a hospital that prohibits a range of reproductive health, including contraception, sterilization, many fertility treatments, and abortion. These same institutions have also moved to prohibit gender-affirming care. These refusals can result in the denial of life-saving and time-sensitive care that can be vital throughout a patient's life. What is even worse is that many patients throughout the state may not have the option to go to a hospital that abides by this standard of care and provides full and unrestricted access to reproductive health care, creating a massive health disparity. Patients in rural areas and urban and underserved areas are particularly impacted by this. More so, these patients might not even be aware that these institutions can deny them medically accurate information, even in emergencies. This creates a massive threat to public health and the moral obligation we have to treat our patients when we take our oath to do no harm. This bill aims to remove a very simple barrier, which to ensure medical providers are not punished for providing their patients with medically accurate information and referrals, or for providing necessary and often life-saving care in the setting of pregnancy complications. What it does not do is force any provider or patient into providing or participating in care that they do not want to or are obligated not to for religious or other reasons. It actually protects religious freedoms by ensuring providers and patients who do not subscribe to a certain set of beliefs are not forced to subscribe to or orchestrate their medical care around other people's religious beliefs. There's a reason physicians are licensed to practice medicine, not health systems. There's a reason physicians have to go to 4 years of medical school and 3 to 10 years of postgraduate training, and health systems do not. That's because as physicians and medical providers, we train and learn the expertise to recommend the most appropriate and medically sound treatments possible to patients. Those should not be limited by the moral refusals of someone who's not even in the room with the provider or the patient, especially because all we are asking is for providers to not get punished for providing this care and information. Not a single provider or patient would be forced to act or practice in a certain way because of this law. It would simply be protecting them from giving their patients medically accurate information that, quite frankly, anyone should expect when going to the doctor. This bill is critical to ensure providers are not punished for following the standard of care and ensure that all patients have more equitable access to care. I strongly support HB 5424 and respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably. Thank you for your time.
Thank you, Ms. Circus, for your testimony. Can I clarify a couple of things?
Sure.
Did you say that you have interacted with patients who had been restricted care?
Yes. Before medical school, I worked at Planned Parenthood, and I have interacted with patients who came to us after not getting the care elsewhere.
Could you elaborate a little bit and share examples?
Sure.
As much as you can.
Sure. I want to be mindful of like patient privacy and all of
yeah.
that, of course, but patients are denied a number of things. And then it's not restricted to just religious institutions, but a wide number of services are not necessarily provided, including contraception and abortion care. And this applies to patients who might be seeking contraception not to prevent pregnancy, but to alleviate menstrual cramps and things of that nature. And so I've met patients who have come to us after being like either denied that care or not being given information from their own doctor. And it just created another step in the process for them to have to go to another clinic and find the place that they could actually get that information. And so I think it's really important that whoever you are, wherever you work, you're able to at least clearly give that information to your patients so that they can, conveniently access the care that they need.
Thank you for that. Yes, Representative Dauphiny has a question. or
Thank
comment.
you. Thank you, Mr. Chair. So I just want to be really clear. So is it your belief that even if it's against someone's religion, that they should have to refer you or perform a procedure that they're against? Is that how I understand what you're saying?
I would say that's not what I said. I would like to clarify that a little bit.
Okay.
In my testimony, referenced how no provider would have to participate in anything as a result of this bill. The moral refusals apply to the person in that situation. So this would protect a physician or a provider who does give that referral, but it wouldn't force a provider to give that referral. And I think I mentioned in my testimony, as well as my written testimony as well, that I think everybody has a right to their own moral code and their own moral beliefs, and that this bill wouldn't be forcing somebody into participating in something that they didn't want to. It would merely be protecting people who do give that to their patients, as is the standard of care.
So if you're working for a facility that prescribes to a certain religion and you understand that when you work there, you're saying that in spite of that, you should be able to give them information that would go against the institution itself.
I think that it's important that physicians are able to make those decisions at the discretion of the patient that they're working with in that moment. And I think that no patient should be limited. Like I said in my testimony, not every patient can choose or even knows that the institution that they're receiving care at can deny these things. And so I think it's important that physicians are able to make that decision and providers are able to make that decision at the discretion of the patient that they're working with, and that the patient shouldn't be denied that information, most importantly.
So just so I can be clear, so if there's an institution, a religious institution that doesn't prescribe to some of the things that perhaps you're talking about, and there's an agreement that if you work here, that's how you'll perform your practice, and you agree to these that in your contract, you're saying that that's not okay.
So I think that it should be clear that, and I'd like to, there's some other providers speaking later who I think would maybe be able to better speak to this, but it's not a requirement for you to be of a specific faith to work at a institution that is of that faith. And so I think that it's important that providers are not restricted in their own right and to practice medicine, but also as individuals to, and for their patients as well, to not be forced to subscribe to those religious beliefs. Although I think that patients should be able to make the decisions that are based on their own moral code, and that could very well include, prescribing to those beliefs that we've been discussing.
Thank you. I think the providers wouldn't be forced if they chose to work there, but thank you for your comments.
Thank you.
Thank you. I just wanted to go, no, I just wanted to clarify and then explore this a little bit more. As a medical student, if you were going to, or as a physician in future, if you're going to go to be at a facility and working and taking care of that, that facility cannot come between the patient and the physician relationship. It's providing the care. They may have the moral responsibility and they would be very upfront with that, and that's their right. And then you're not questioning that at all. But what you're saying is that when medically necessary, you have the responsibility, not the right, but the responsibility to do the right thing for that patient. And you should not have to fear your job or your position or disciplinary action if you were to guide the patient, what the patient may need. Is that how you're reading it?
Yes, I'd say that's very well put.
Okay, thank you. Just clarifying. Anyone has any questions or comments? Representative Miko.
Thank you, Mr. Chair. Just real quickly, I just wanted to say thank you, Claire, for coming to testify today. And I think your Farmington education has served well. Thank you, Mr. Chair.
Thank you. I thought you were going to have a quiz because of the Farmington education. Good. Perfect. Seeing no other questions or comments, thank you for your testimony and good luck with your education.
Thank you so much.
Moving on to the next person on our list is Juan Rios. Welcome.
Hello, how you doing today? My name is Juan Rios, and I would like to testify today for testify on personal recovery for mental health. I'm here to testify in support of SB 370 peer-run respite centers. PR respites would help people in society by reducing healthcare costs for mental health, by giving them a safe place to be in times of crisis. It would make the economy better by making healthcare costs lower so expensive hospital stays are not necessary. Therefore, I am asking that you please pass the bill, create peer-run respites in Connecticut to support people experiencing a mental health crisis in the most human and voluntary way possible. Thank you for your community. And I just like to say, I would like to lower down health costs for hospital services only, because the reason why is because, well, and when you're in the hospital, you feel sick or ill, you don't feel like it's your day, or you probably may feel better, but in the hospital, it's better to make insurance go down after when you're finished with your hospital. Most people survive. Most people don't survive. Being in the hospital, it's very hard because a lot of families wonder, and it's a very drastic moment to being in the hospital. I just want to reduce it down. Also, to make the economy better by promoting healthcare, and by making taxes and bills much easier to go down, but it's very hard in sense. But it's not like it's not going to kill nobody. You know, it's not like you're gonna struggle forever. It's not like you can stay and witness the day that, witness the day that, that work is gonna present you. But work is completely different from the aspect of of health. And a lot of people go through that in their own senses, but some people just reframe it all, regret the fact that work and health is very important. But the problem is that it's a society and the economic woes today. President's not doing so good. It's okay to talk to the president if you had a chance to meet up with him. But I feel like it's very hard because there's a lot of police, a lot of brutalities, a lot of crazy things happening, and we just want to regret it all, and make the economy a better place to live and a society as well.
Thank you so much, Juan, for your testimony. Appreciate it. Muchas gracias.
Yeah, is there any questions or comments at all?
I think you're very helpful, and I want to thank you for your courage to speak in behalf of not only
Yeah.
yourself, but a lot of other people. So we appreciate you.
Yeah, thank you so much, sir.
Thank you.
You're a good help, sir. Take care to all of you. It's always best to love your family, whether good or bad, wrong or right, struggle or don't struggle. It's always best to love somebody that cares for you and care for them back. Thank you.
Amen. Agree with you. All right, Lynn Evans. Lynn Evans, are you here? Oh, you are. Welcome.
Well, thank you.
Take your time. Take your time.
Yeah. Dear Senators, good afternoon. Senator Anwar, Representative McCarthy, Barney, distinguished guests, and of the Public Health Committee. My name is Lynn Addison, and I'm a registered voter in the town of Manchester. I am here today to testify in support of SB 370 per respite center. My story might help some people like me. When I was a teenager, I was put in an institution by my parents. My experience was that it was a nightmare. I wish that there had been a respite place for me to go rather than the hospital. The services I received were nothing. It made me awful bad. Then maybe my parents might have not put me in a place like that. But I did get the help and get better. If you could have a peer respite site, I've got my glasses. Oh, now I can see. One study found that people who stayed at a peer respite were 70% less likely to return to a hospital for mental health crisis. When I was older, I ended up in another home called Goodwill in Bridgeport. My doctor and my case manager intervened and helped me find this wonderful place. It was, I wish there had been someone I could talk to, and this place helped me get better. Now I'm a senior adult suffering from depression and anxiety. I wish there was a place that I could go to get help. There are no places like this anymore. Now I'm recovering from anxiety and depression. I attend Intercommunity Common Ground Learning Center / Clubhouse. It has helped me grow. Therefore, I am asking you to please pass the bill to create a peer respite center in Connecticut in support of people experiencing mental health crisis, the most humane, voluntary way possible. Please vote yes to this bill. Thank you for the opportunity to share my story with you and what it would mean to me. Thank you, Lynn Evans.
Thank you, Len, for your testimony and appreciate you for speaking up and helping us understand this better. I see no questions or comments, but thank you. And that brings us to the next person on our list, number 31, Crystal Piet. Welcome. Take your time. Take your time.
Good afternoon.
Yeah.
There. Right here. Okay. Good afternoon, Senator Awar, Representative McCarthy, Vehi, and distinguished members of the Public Health Committee. My name is Crystal Piat, and I'm a person in recovery. We need houses in a home-like setting for the mentally unwell instead of sending them to a hospital or mental institutions, which they lose all their connections from the outside world. In a peer reset, we would feel safe and get over the crisis with peers who know what they are going through and who has similar experiences. We can overcome their mental health challenges and get back to their lives without losing their jobs, homes, family supports, which can happen. Therefore, I am asking that you please pass the bill and create peer-run RIPSTES in Connecticut to support people experiencing a mental health crisis in the most humane and voluntary way possible. Thank you for this opportunity to speak and share my experiences with you to see what this would mean to the people that need the care from peers in a kinder world. I thank you.
Thank you so much. Don't go yet. We may have a question for you. Thank you first for being here with us this morning and this afternoon and being part of the conversation. Do you have personal experience as well?
Well, I have experience in the past, and till this day, anxiety, the whole 9 yards, and I had no place to go. A single parent, raised my son by myself. I was in relationships and abusive ones, and my son was abused, and I had no one to talk to. So when my son was in the high school and talked to his principal at the school in East Hartford, and the principal talked to me and says, I know you have problems. And I said, I have nowhere to go, no one to talk to. I'm afraid to go to the police or whatever because I'm nervous. I'm a type of person that's very nervous. And she gave me a number to call. And I called, it was Intercommunity. And they came to my house and I felt at ease. I was nervous, but I was at ease. They say, come, and meet people. They have different issues with mental health. And I've been here over 20 years. And I'm thankful because if it wasn't for them, I would be underneath 6 feet under. And my son is doing good now. He's married. I'm going to be a grandma for a second time around. So, he has a good job, knock on wood. And, it's hard. We need people out there in Connecticut to get a place for people that has mental issues, not bring them into institutions and in hospitals. Because my older sister had the same thing. My sister April talked earlier. And I seen what she went through. And I wish no one to go what my sister went through. She was abused in the mental institutions. She was in Norwich State Hospital way back in the day. And it's hard. You know, they're supposed to help you. But when I see the nurses and the care in the institutions, no. People don't have to be treated like animals, because we're not. We're human like anybody else. And I need this bill to be passed, because we need a place that we could get the help we need. And it would be a home setting. You feel free. You don't have to be worried about cops coming in, tying you up and all that stuff. We don't need that. We're humans. So I like this be passed.
Thank you. Thank you so much. Crystal, we appreciate you and thank you for your passion and thank you for your courage.
Thank you.
Thank you for your courage. We appreciate you.
Thank you.
The next person on our list is Dr. Iana Lyles. Welcome.
Hi, welcome. Are you guys able to see me?
Yes, we can.
All right. Sorry, I'm in between patients, so if I seem a little rushed, I very much apologize. My name is, well, to Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Dr. Iana Lyles. I am from Newington, and I'm a board-certified OBGYN physician here in Connecticut. Thank you for accepting this testimony in support of House Bill 5424, an act prohibiting adverse actions against healthcare providers who offer medically accurate information and counseling to their patients and provide needed health care in line with the accepted standards of care for their patients facing pregnancy complications. I've submitted a testimony, and so I'll only kind of highlight a few things through it. As a physician and trusted healthcare partner, I pride myself on making sure my patients have the most up-to-date and evidence-based recommendations when providing care. I've also worked at a faith-based institution, and you'll see in my testimony, faced a lot of conflict in trying to walk that line of providing medical care within what we consider standards in the OBGYN community, with sort of practices that aligned with that institution. And for me, it led to a lot of anxiety, stress, frustration, even burnout to the point where I actually ended up leaving that institution to go to provide care at another place. And as you can imagine, that just further exacerbates the healthcare crisis that we have with access to clinicians who can provide comprehensive healthcare. It's my understanding that this legislation is not giving physician or other clinicians the right to act outside of what the institution will allow, but will really just first strengthen that patient-clinician relationship that, you know, people come to us with trusted information that they're going to get what everything is available. It also allows patients to be able to choose from the full breadth of the medically acceptable treatments for whatever condition, reproductive health care, whatever it may be, that's available, but also will allow us to make referrals if we're in an institution to the places where patients can receive that care. For me, it also protects physicians from reprisal. I can tell you it was a lot of stress to always be worried about losing my job, about, I'm sorry for the background, got to get rid of that. Sorry, I didn't realize that. It is always fear of losing my job or any adverse actions against me, which completely breaks down that physician relationship and ability to practice care, especially because I trained 8 years to do this, 4 years of medical school, 4 years of residency, only to be told that I can't provide at least counseling, which is the bare minimum that every person has a right to have access to. So, you know, outside of that, you know, it has been difficult for the last few years with everything going on politically, and I won't get into that because that's not within the scope of this practice, but it's been stressful to provide care, and having legislation for like this helps our patients, it helps our clinicians, especially in the state, if they're in those institutions. And I would respectfully urge not only the committee, but the general body to consider supporting this legislation. Thank you.
Thank you so much, Dr. Lyles, for your testimony. I wanted to explore with you a little bit more. So your employer restricted you to offer options? Is that what I heard?
It had guidelines about what you were able to do and not do. it was unclear where the counseling came in. And so that's where the stress came in, because you never knew if you were to counsel someone on an option that was available in the community, what could potentially happen to you.
And it was in the written format, or was it a verbal communication?
Written.
Written. And did your contract also suggest some of those things directly or indirectly?
I cannot remember because it was a couple years ago, but it was the institution had a written policy, and you had to agree to policy before you could sign the contract.
And so from your perspective, how should I say, the patient-physician relationship, it almost appeared that there was somebody else trying to control some aspects of it.
Oh, definitely. I always tell patients it's not just me and them in the room. It unfortunately is a lot of other individuals in the room, not even just, outside of the healthcare institution that you happen to work through. So yes, it never feels like it's just me and the patient being able to make a decision. I have to take the input of a lot of other individuals who may or may not have had a medical background in making it.
Okay, and could you explain to us a little bit about how that impacted you personally, being in that position, and how uncomfortable? We talked about moral injury to clinicians in some of these situations. Can you speak to that?
For me personally, it was a lot of anxiety and stress, a lot of worry. I took a lot of work home with me, which means that it impacted my family. And so I personally became burnt out, became tired. I could tell how my interactions with patients, you feel constrained and you want to say something, but you're not sure how to say it. So I don't know if it was moral injury as much as I could not practice the oath that, to do no harm, and to not be able to tell people things felt like I was harming them. And so I felt that I was put in an uncomfortable position to either violate my oath, stick to my job, or have a job, or make sure that my patient gets the care that they need. And which I don't know that a physician should be put in that place.
And Dr. Lyles, I have a number of my colleagues who have questions. I'll start with my co-chair.
I imagine.
Thank you, Mr. Chair, and Dr. Lyles, thank you for being here and for sharing your experience with us. To follow up on what Senator Anwar said, can you give us a specific example, as he asked earlier, one of the other folks testifying, of what that would look like if a patient was coming in, and an example of a situation where, as you said, you were not able to tell people things that you felt would result in you not causing harm. So if you have an example or two, I think that would be wonderful.
I will meld them together because I have to protect patients, their medical history and things, but some of it will resolve around abortion care. So someone who's coming in with an unplanned pregnancy and asking options, not even indicating that they want to have an abortion, just what can I do? I didn't plan this. And so that's part of the place where you feel constrained. What can I say and not say within the confines? Not even that I can provide it, but just to tell you what options exist. So that is specific examples that I encountered several times. Sometimes it would be around just talking about birth control and if birth control would be covered or not, or if someone deemed a birth control method to be an abortion type medication, which they are not, if that provision was even allowed, and how you can work that in and say it in a way that doesn't break your confidentiality or the rules that you've agreed to.
Thank you for that. And thank you for clarifying that you did refer to an example related to counseling for abortion, and other areas, including birth control. So this bill would actually not just include abortion, counseling or options and talking about that. It's also things like birth control.
As well as pregnancy. I should have mentioned that I've seen it in the pregnancy realm with complications, and how do you walk that line of someone being sick and what options they have within the institution or where they can get those options. I have seen several times as well.
Thank you. I also appreciate you mentioning that I think we've had situations, or there are situations certainly, where a pregnant person learns and knows that the baby is not going to be able to sustain life outside the womb. and there are choices to be made, but what you're saying is in a situation like that, you're not sure. You weren't sure what you were able to say and what you were able to counsel in terms of options.
Correct.
Thank you. Thank you, Mr. Chair.
Rep. Dauphine.
Thank you, Mr. Chair, and thank you for your testimony today. A couple of questions. Was this place that you worked at in Connecticut?
Yes.
And you signed the contract and agreement with their, if you will, stipulations and how they wanted you to communicate with the patients prior to taking the job?
Correct, because you could not sign the job contract without signing that.
So I just wondered why you worked there. Why didn't you work somewhere that would support, your belief system and how you wanted to practice?
Excellent question. I mean, unfortunately, as people would like to believe, the job market is not that great. And when you come out of training and you're looking for jobs, you kind of get the first job that you can get. So it wasn't like I had a pick of the litter to be able to choose a place that would align with the goals. That did come later on. And so it was a choice of not have a job or have a job. In addition, a lot of the patient population that tends to be at some of these institutions are target populations that I enjoy taking care of. So I felt that it was my duty that at least if I'm there and providing some type of care, that was better than no one fulfilling the position for that patient.
Thank you. I appreciate your answer. I know that if something were violating my belief system and it was something that I didn't want to do, I certainly wouldn't work there, but I appreciate your testimony. Thank you.
Thank you.
Representative Gilchrist? No, okay. Anybody who looks at me, I just think they are going to answer. So that's, I have another question. Could you talk to us about health equity issues in women's health in our state? If you can touch on that topic, especially reproductive rights and reproductive women's reproductive health.
Yes, I think our state is more progressive compared to many other states, but we still have a long way to go, acknowledging individuals who are gender diverse and making sure that it's not just women, but people with uteruses or different gynecologic organs in the care that they get. We definitely have a maternal crisis in terms of, race. So Black women or Black individuals who are seeking gynecologic care, getting equal services or equitable services compared to individuals who are not of African or Black descent. So I think we still have a long ways to go. I think we have a lot of people who are passionate and in the work and doing the trenches, and they're in a variety of different places. And so making sure that if those individuals happen to align in institutions that may not allow all the options, that we can at least open up and make sure that everyone gets the same choices as opposed to only partial choices.
And do you read this bill as forcing clinicians to do something, or is it just saying that if they are in a situation?
I read this bill as protection for the clinician to be able to counsel. You are not forced to do anything. That is part of, as a physician, we are trained not to do that. We have the medical decision-making capacity to do that. So this bill in no way, shape, or form do I read as forcing. It allows me to be able to counsel and not have that fear that I had for several years of if I even say that word, what's going to happen to me, as opposed to I'm going to do this despite what my institution says. That would be negligence in my mind.
Thank you. This is very helpful. Thank you for your testimony and thank you for being here. And I know you had to wait for a long time. So seeing no other questions or comments, we'll move to the next person on the list, which is number 33, Mr. Peter Wolfgang. Welcome. Thank you for being here with us. And thank you for waiting this afternoon.
Thank you. It's on, right? I'm Peter Wolfgang, president of Family Institute of Connecticut Action, and I'm speaking against HB 5424. I want to begin with a quote from the columnist Chris Powell. The real rationale for forcing medical providers to allow abortion referrals is to stamp out contrary consciences and religious beliefs. Ironically, the people doing this stamping out tend to be the same ones who speak of the benefits of diversity. That's what you're doing with this bill. You're attacking real diversity. This bill is a blatant attack on Catholic healthcare and religious freedom in our state. This bill undermines Catholic hospitals in our state. It cleverly omits the word Catholic, but Senator Anwar You put it right out there in the back and forth with Kara Delaney that this is about Catholic hospitals. I think Representative Tersiak said, well, it's not only Catholic hospitals, it can be others. But really, who else is opposed to abortion? We're talking about Catholic healthcare. This weakens the oversight and control that Catholic hospitals must maintain to ensure their Catholic mission. The services not provided by Catholic hospitals can be obtained elsewhere, particularly in Connecticut. Direct attack on the religious freedom, that's what this is. This is a direct attack on the religious freedom of Catholic healthcare. It's the first step in forcing Catholic healthcare to provide abortion and gender transitions in Connecticut. And again, I come back to that quote from Chris Powell. The real rationale for forcing medical providers to allow abortion referrals is to stamp out contrary consciences and religious beliefs. Ironically, the people doing the stamping out tend to be the same ones who speak of the benefits of diversity. Connecticut is a very, very pro-abortion state, or if you prefer, pro-choice, pro-reproductive rights, whichever your euphemism of choice is. There's no need to attack Catholic hospitals in this way. There's plenty of other places where you can get abortions, you can get gender transitions. That's all we have in the state are these few institutions that don't want to do this. And even they cannot be left alone by the state. You're going to attack even those. So I ask you not to do it. I ask you not to pass HB 5424. Thank you.
Thank you for your testimony. It was like you had still 1 more minute to go, but we'll probably use that in our Q&A. So I wanted to clarify. First of all, thank you for being here and thank you for speaking your perspective. It's very valuable and we appreciate it. And I also want to mention that the Catholic hospitals have a lot of compassionate physicians, clinicians, and they provide very good care. There's an area where there's a disagreement and that we can have a little bit of a conversation around that as well. I did not read this as a mandate for clinicians. And that's why I was clarifying and I wanted to make sure nobody else did either. And the rights of the Catholic institution, they are there and then you're not shy about it either. So that's very good. The issue that we're talking about is when there is a specific need that comes in and a clinician identifies that, the clinician should feel comfortable recommending the option to go to where the care would be provided. That's what the question is. Did I understand the bill wrong?
So I disagree that this protects Catholic hospitals. What it does is it prevents Catholic hospitals from being able to tell their employees, no, you cannot make referrals for abortions or you cannot make referrals for gender transitions. Did I read the bill wrong? Does the bill not prevent hospitals from telling their own employees, no, you cannot do it? It says explicitly that they can't be disciplined and so forth if they make those sorts of referrals.
So again, if the patient requires a treatment medically, you would restrict them from getting the referral to the place where they can get that?
But Senator, what do you mean when you say if a patient requires a service? Like you and I imagine, are on the opposite side of the issue of legality of abortion. The Catholic Church has a specific position on this. So your idea of like requires may be quite different from that of the church. And look, the Catholic Church has been in the healthcare business longer than anyone. They know a thing or two about this. St. Francis Hospital here in Hartford was founded by Catholics in the 1800s. They should be left alone from the state. They should not be made by the state to be forced to get in the way of, the state should not come between the employer and its employee when it comes to protecting the mission of the Catholic hospitals. The Catholic hospitals don't want to be complicit in abortion or gender transitions. And that is what this bill would do. And it would actually, as I said in my testimony, I think it would put us one step down the road to still more. So it should be opposed.
So again, Mr. Wolfgang, the nobody's coming and stopping the Catholic hospital from doing what they're doing. It's the patient's need and a clinician who is speaking to the patient when the patient is going to be able to get a care somewhere else on the specific need that they may have. It's not only abortion, it could be more than that. So And again, if there's any other hospital in the state who's restricting any care, the patient needs that, that's probably very right thing for a clinician who knows that there are other options available to move in that direction. So restricting that clinician and disciplining them makes me think that maybe this bill is much more needed than many may have thought initially. Again, that's just me speaking, but I know we'll have more conversation. I know my co-chair has a question or a comment, and then we'll wait. I have Representative Jillian Gilchrist, and then we'll have Representative Daphne.
Thank you, Senator. Thank you for being here today. You quoted Chris Powell twice. Who is Chris Powell in relation to this topic?
He is a well-known columnist here in the state of Connecticut, writing for decades, syndicated in newspapers throughout the state.
And does he have expertise when it comes to reproductive health care?
I think he has expertise on a whole bunch of things. That's why we all love him.
All right. Other question having to do with this proposal. So to build off what the senator was saying, if a woman arrived at a Catholic affiliated hospital and it was determined that she had lost the baby she was carrying, what are you suggesting that hospital should do?
So Dave Reynolds from the Catholic Conference can drill down more specifically on those specific instances. I know I think you guys scheduled him to be like one of the last speakers of the day, but he knows those ERDs inside and out, and he can give you those specific instances and what the church does and does not allow. I don't know, what the church would say in every single instance. What I do know is that the church has been doing healthcare for a long time, that the church is opposed to abortion, that we're in a state, and particularly a state government, that favors abortion, and that this bill comes between the employer and the employee and affects Catholic mission. As to every specific instance, if the child's has already died, unfortunately, inside the woman, Dave Reynolds, I'm sure, can speak to those sorts of specific examples when he testifies.
All right, then I'll ask you, since you came here to testify today, if a woman presents at a Catholic hospital and it has been determined that she's lost the baby, would you be opposed to the medical provider letting her know that there are other hospitals in the state who can treat her, and then providing her with information on the various treatments that she could receive?
Well, if the baby is expired, if the baby is dead, then there's not a life being taken, which is what the church is opposed to. But again, in terms of the specific ins and outs, I would say Dave Reynolds could give you greater detail on it.
Okay, thank you. Thank you, Senator.
Thank you, Representative Daphne.
Thank you, Mr. Chair, and thank you for being here today. Just curious, are you aware, you were saying that the St. Francis has been here, I don't know how many years, and the Catholic institutions have been here. Have there been cases where people's lives have been at risk because you don't perform gender affirming care or abortions?
I'm not aware of a single one. My wife's written testimony, she's next in line after me. She's Director of Public Policy. Actually, she won't be able to speak, so you'll be able to go to number 35. But her testimony does drill down on that a little bit. Dave's testimony drills down on the gender transition, but I'm not aware of a single such instance in the state of Connecticut. Had there been such an instance, it probably would have made the press, but I'm not aware of any.
And do the people that work at these institutions sign these contracts freely, understanding the moral philosophy of the church and what they stand for and what they don't, and the constraints in which they'd be working in?
Yeah, that's the thing that's kind of amazing about all this. Of course they do. I mean, they know what they're getting into. And you had a couple speakers. You've got several bills that you're listening to. You've only had a small handful of speakers on this bill today. I think I may be the first one speaking in opposition to it, but I was struck by the first speaker that I heard. What she went through didn't even occur in the state of Connecticut. So in Connecticut, we've got plenty of healthcare institutions. I think we have maybe 20 something hospitals in Connecticut. If you choose to work in a Catholic hospital, particularly in a state that is so enamored of abortion rights, I mean, there's other places you could go to work. If you go to work for a Catholic hospital and you sign that document, well, you've made a choice, and this isn't, this isn't some other part of the country where abortion is restricted. This is a state that can't tout its love for abortion rights enough. So I don't understand, what the issue would be. Even Dr. Lyles, who testified right before me and said that she felt very constrained, because she was at a faith-based institution. I recognized her right away. We had a bill that passed out of this committee, became law, against the pregnancy centers. She testified in favor of that bill and spoke openly about the fact that she was working at St. Francis Hospital and made abortion referrals. She said that in open testimony to this committee. So obviously she couldn't have been that constrained. I just don't see a problem here. This looks like a solution in search of a problem.
Yeah, I would agree with you. And the word forced has been used several times. I think, do you see this as the Catholic institutions being forced to be compliant to a mandate of allowing things to be said or treatments to be referred to or the like with regard to the employees that they hire?
Yeah, I think there's an element of the state forcing the hospitals. It reminds me somewhat of all the issues around the federal healthcare mandate of about 10 or 11 years ago that caused the Little Sisters of the Poor to sue the federal government. The Catholic Church does not want to be complicit in things that violate its faith. And it's not the role of the state. We're about 250 years into the Republic, into the history of the United States of America. And Catholic healthcare got along just fine in all those years. It's only in recent years with these agendas that have popped up, these ideologies, that now we're going to force Catholic healthcare to do new things that violate the mission that it has always had throughout the entire history of this country. That should be resisted. Again, I love Chris Powell, the way he framed the issue. I think it's an attack on diversity. You're attacking the existence of Catholic healthcare in the state of Connecticut.
Yeah, I think it's interesting at a time when everyone is just desperate for nurses and doctors and therapists, that anyone would feel forced to work at any one particular institution. There's tons of jobs across the state and across the country. So thank you for your testimony.
Thank you.
Thank you, Representative Denning, then Representative D'Amico after that.
Thank you, Mr. Chair. Thank you, sir, for your testimony. I appreciate your standing of where you're coming from. I'm looking at this from a little different issue, which is first, what is the document that you were talking about with Representative
Dr. Lyle, she spoke right before me.
So, I mean, but what document was it that you have doctors sign before they can work at your hospital?
Well, again, I would defer to Dave Reynolds, but I think we're talking about the ERDs, right? It's in Dave's testimony. There are these ethical directives by which Catholic hospitals are expected to operate.
Okay. And so I understand that somebody coming in, I'm a nurse. If I wanted to come in, I would operate underneath those directives if I took a job. As medical and healthcare advances occur, I assume that the church will evaluate each and every one of them to decide whether it's within those ethical guidelines.
Yeah, I would argue that a lot of times the church is on the cutting edge of a lot of that stuff.
And I
yeah.
appreciate that. That's really, I mean, I appreciate all the service that churches and religious organizations have done for education and healthcare in our history. What my question is now is, if the church is going to say there are services that do not fit in with that ethical guideline, should the church be posting that somewhere in the hospital on situations to let the patient know these are services that are available that are not performed at this institution?
Maybe that is something worth exploring. I can't imagine that anyone doesn't know that the Catholic Church isn't into abortion, for instance. But if people don't know, maybe that's something worth exploring rather than a mandate on Catholic healthcare to make them complicit in things that they don't want to be complicit in.
And I would see that as a better solution. I don't see this bill as actually forcing complicity. But I do think that there should be, I've taken care of a lot of people. Not everybody is educated as they should have been. They did not go to study hall. And I do know that there are a fair number of people who are not aware of the position. And I would think that if
people who were coming into your institution were aware, or at least made aware of what opportunities were made of that you did not perform, that's kind of what the doctor would be doing anyway, correct?
I'm sorry, you're asking me
If
what?
if you were the hospital telling the patient, these are the things that we do not do, wouldn't that be the exact same thing as the healthcare provider saying the exact same thing?
I don't know that it's the same thing as telling the employer of the healthcare provider, you must allow the healthcare provider to make referrals for these things that we don't do here in our hospital. Now, having something up on the wall saying, look, we don't do abortion or gender transition, that's one thing. Tying the hands of the entity and saying they're not allowed to tell their own employees that you can't make referrals to these things, I think is something else.
Okay, thank you for your time. Thank you, Mr. Chair.
Thank you, Representative D'Amico.
Thank you, Mr. Chair. Thank you, Mr. Wolfgang, for coming in to testify.
Thank you.
So I just want to ask one or two questions, just so I can understand your position a little bit better. So we've heard a lot of talk this afternoon about people's religious freedom and their belief systems, and certainly I wouldn't want to tread on anyone's belief system or their religious freedom. But is it your feeling that someone's belief system or their religious creed, call it what you will, should supersede the right of a patient to get accurate medical information?
I think in a place like Connecticut, that patient has the freedom to go somewhere else, and that person's religious beliefs won't be violated at all. But if you're saying it will violate that person's religious beliefs to adhere to Catholic standards when they go to a Catholic institution, it's the Catholic institution's beliefs that are being violated.
Their beliefs are being violated?
Their beliefs are being violated if you're telling that Catholic institution, because this person's non-Catholic, you have to allow referrals for abortions and gender transitions.
But this bill simply says that, if I'm reading it properly, it says that they have to provide, that no one can be prevented from providing medically accurate and appropriate information and counseling. That seems like something that we should expect from every medical provider that any of us ever go to.
Right. Medically accurate and appropriate. Who could disagree with that? Except it's the 21st century. A lot of people are cool with abortion and transgender stuff, and the Catholic Church is not. So what may seem very sensible to you may not to the church. And the church is really just standing by the principles it's always had, and they shouldn't be coerced by this gentle sounding language in favor of things that they're opposed to.
But just to be clear, Mr. Wolfgang, we're not talking about coercing the church, and we're not talking about coercing the hospital. As I read it, we're talking about basically putting a gag order on the provider. You can talk about this, but if you work in this hospital, you can't talk about this other stuff. So all of their years and years of training has to be under what you're suggesting. All of their years of training has to be constrained somehow. You can only talk about certain things that you learned in medical school, but you can't talk about other things that you learned in medical school. Does that seem like the right way to practice medicine?
It does seem to me the right way to practice medicine for a Catholic church to tell, Catholic hospital to tell its employees, you can't talk about killing the unborn child. You can't talk about genital mutilation. Now, we use pretty language. We talk about gender affirming care or what have you. But this is from the Catholic Church's perspective, and I would argue from reality. These are the things that our society now accepts, but the church still doesn't. So underneath all this pretty language, this is what this bill is trying to do, and the church is right to oppose it.
Because we're not supposed to get into arguments, Mr. Chair, I think I'm going to leave it at that. But I thank you for your answers. I truly do, Mr.
Thank you,
Wolfgang.
sir.
I appreciate it.
Thank you, Rep.
Thank you. I'll remember that.
Yes, indeed.
Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for your testimony today, and just some clarifying questions, and I apologize if you already answered them. So this bill, from my understanding, it's not forcing any religious or Catholic hospital to perform a procedure.
That's correct.
It's just enabling the providers to give out more information. So the patient is truly informed about all their options.
It's forcing the Catholic hospital to allow its employee to make referrals for abortion and gender transitions. That's what it's doing.
But also, it's only if they want to. It's not forcing the provider to give information or referral, correct?
I think only if they want to is a distinction without a difference. I mean, okay, only if they want to. Well,
Okay.
if they want to, they should go work somewhere else.
Okay, thank you. But also you mentioned that these people will pick these hospitals, and sometimes where if I have to go to a Catholic hospital, it may be one because it's near where I live and there's not another hospital very close to me, or it's within my network and my insurance. So it really isn't giving me a lot of options as to where I am forced to go, because it has to be somewhere near me or in my network for providers. So you're saying, oh, people can just go to another hospital. Yes, in a perfect world, yes, they could just go somewhere else, but that's not always the case. And to your other point, if you're a Catholic or religious hospital, are you denying treatment to someone that has HIV or the LGBTQ community, if you're going by what the Catholic or the religious community is thinking?
I am not aware of anything in the Catholic ethical directives that say you can't treat someone with HIV. You know,
Or you can't refer someone with HIV?
and Connecticut too is an extremely, we're one of the smallest states in the country. I just don't think whatever the seeming difficulties are so insurmountable that we need to violate the first clause of the First Amendment, which is religious liberty.
Okay, thank you for your answers.
Thank you.
My co-chair, Representative.
Thank you. Thank you, Mr. Wolfgang. And as I have often said in this room and in others, the beauty of democracy is that we are able to have these conversations despite our very extreme, sometimes differences. So I appreciate you being here and this conversation. Just to follow up on what the good ranking member was just asking, would you agree that a patient, particularly one who is facing an emergency, isn't always thinking about the religious affiliation of a hospital when they present at a hospital?
Well, no, I imagine not.
Thank you. I think that's an important point, because while the majority of the conversation today, and certainly this bill, is focused on providers at those institutions, those who are patients, including myself, I live in an area where there are two wonderful hospitals, one of which is religiously affiliated, especially in emergency situations, are not thinking about which place to choose based on that at all. So I appreciate your answer. Thank you, Mr. Chair.
Thank you. Senator Summers, did you? You're good. We're good. Anyone else has a question, comment? Going once, going twice, and gone. Thank you so much.
Thank you, Senator.
Thank you. And the next person I have on the list is Leslie Wolfgang, and we heard
She couldn't make it.
Okay, but we have a written testimony and we
Yes,
appreciate
you
that.
guys have a written testimony.
Thank you so much.
Thank you, committee.
And next is Dr. Lee Nathan. Welcome.
Thank you. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Clarities Ditria, and distinguished members of the Public Health Committee. I thank you for the opportunity to testify in support of Senate Bill 370, an act concerning peer-run respite centers for persons experiencing a mental health crisis. My name is Lee Nathan, and I am a psychiatrist who's been practicing in hospitals and publicly funded clinics, including DEMHS-funded and DEMHS-operated settings in Connecticut since 2014. I've completed fellowships in public psychiatry and consultation liaison psychiatry, which is the subspecialty of psychiatry that works with patients admitted to the medical hospital or to a medical center. I currently practice that form of psychiatry at Hartford Hospital and lead initiatives in person-centered care for the Institute of Living, including in our inpatient psychiatric hospital and outpatient clinics in our emergency room. I have submitted written testimony and will share it now with some additions, and I offer this in addition to the written testimony of Dr. Javid Sakara, our chair and chief of psychiatry at the Institute of Living, who also testified in support of this bill. Among my priorities is reducing the occurrence of injury or harm related to emotional distress or crisis. And I have the hearts and minds and health of the people of Connecticut in my mind as I share my testimony today. If I could design a place for people to find aid during an emotional crisis, it would look exactly like what is being proposed in this bill. A comforting, home-like environment a shared space where common ground and familiarity of circumstance brings people together during challenging moments, private areas for guests to sleep in which they hold the keys, and an understanding that talking through difficult emotions with others is an effective means to resolving them. These places would be staffed by peer support specialists. I thoroughly enjoy working with peer supporters and trust them to meet the needs of people in emotional distress without a clinically credentialed person or a clinical framework involved. They have expertise that I don't have. I've seen time and time again how they use, quite frankly, something I can only call intuition that comes from experience to support people in tough moments better than I can for longer than my schedule permits. I enjoy working shoulder to shoulder with peer supporters on my team, and I think it makes us better doctors when they are empowered to speak and advocate so that they inform our clinical practice. But I feel confident that they can manage the sorts of situations that people have described earlier in this hearing without us, and I think they can manage them well. As we have heard, peer respites are by definition separate from the continuum of clinical care that hospitals and clinics offer, and it's important that they remain that way. Even so, they have an important role in the mental health system's response to emotional distress. For many instances of emotional distress, emergency evaluation or hospital care is simply not needed. It's just like managing other chronic conditions. People with seizure disorders or diabetic emergencies often learn to manage these conditions on their own without hospital care being needed. The hospital will always be there, but there are other things we could try first. Peer respites would offer non-hospital avenues for managing such conditions. But sometimes things do evolve into something more serious. In my current role, I frequently meet with patients admitted to Hartford Hospital for medical or surgical reasons and who are having emotional distress. And I see sometimes multiple times a day what serious bodily injury from emotional distress looks like. In other words, I meet with people after they have survived a suicide attempt. Emotional distress is very uncomfortable, yes, but it is the action based on that distress that introduces the need for medical or surgical care, and that can cause permanent damage to the body. I think often what we as a healthcare system could have done differently to divert these kinds of events from ever taking place, and what we need to do to keep from losing people to suicide. I say far too often to people in medical beds, hooked up to monitors and IVs, or with their legs and arms in casts just coming out of surgery, we nearly lost you. We very nearly lost you. And thus we begin working through that in addition to the feelings that they were having before things got that bad.
Excuse me, Dr. Nathan, your time is up. Thank you.
Please go ahead and finish your thought if you could, Dr. Nathan.
Sure. These kinds of injuries can be physically disabling, and I've seen them directly result in immediate loss of housing, loss of job, and prolonged separation from family, already compounding the existing suffering that is, in my mind, completely preventable. I could go on other topics as well if you'd like.
Well, let's do questions and then see if people had. I wanted to start with a question. I first wanted to acknowledge and thank you for being here, and also Dr. Sukera, because as I was learning about this and I wanted to talk to a psychiatrist and then look this entire process from a psychiatric and an academic psychiatrist perspective, he was very instrumental and reassuring that this is the way to go from somebody like yourself and him and others who have felt that this is the necessary and a very useful option. So I wanted to thank you for that. And I also wanted to talk about something that's linked to this. We heard from a number of patients today, and I think you are also alluding to this, that the healthcare systems have created a very protective mindset to the point that they are not recognizing the immediate and extensive need of empathy, acceptance, recognition, and comfort to the patient. And they're looking at it from a protective perspective and not necessarily providing that. Do you think there's an opportunity to reassess those options, even if these two pathways remain separate, but there's probably an opportunity for growth in the healthcare systems on this?
I fully believe that. I think we need to dig deep and try to understand the root causes of that way of thinking and practicing. And I'm eager to do that. But it's true that there's a sense that people can't talk with their physicians about how they're feeling, which just frustrates me as a doctor, that people very reasonably feel like they can't be honest with me because they're concerned of a coercive measure being taken. It takes people sometimes years to begin to trust me enough to tell me about what they went through in the past. And I found out way too late from people that they were going through things and they didn't tell me And they wanted to tell me so that I knew, so that we could talk about it after the fact. It just seems completely illogical. And like I said, we'd have to dig pretty deep and really look at all the reasons why physicians and healthcare providers are in this situation. My patients, so that why the public is in this situation where they can't speak freely about how they're feeling to their own doctors.
Thank you for acknowledging that. I have one more question, and I'll have my co-chair ask. One of the other parts that we are exploring in this committee is about the emergency room crowding. And then right now, within the emergency room crowding, the individuals seeking mental health, that's one of the larger groups. And that group, because of the lack of enough beds, is suffering the most because they are in some situations in the emergency room in 5 days or so. And we have heard those horror stories where any healthy person, if you put them in an emergency room for a few days, they will be unhealthy physically and emotionally. So this would help improve that aspect too. Can you speak to that?
Sure. So these would offer an appropriate level of support to people who are experiencing certain kinds of emotional distress. It would be an option, a choice for people to utilize before they think of coming to the emergency room. It would be a place where if they learned about it in an emergency room, they could go there from the emergency room if they chose to. I share printed information. We heard from Jennifer Tirado and Sarah Davidow about Alta Sioux. I hand that information to people so that they know that they can go to an Alta Sioux group if they're feeling they want to speak freely about how they're feeling. I'd love to be able to give this printed information to my patients wherever I'm practicing so that they know that they can go to a peer respite before thinking of coming to emergency room if they feel like that would be a reasonable course of action. And like I said, the people at the peer respites, I trust them to know when things might require emergency level of care and to call 911 if needed or 988. So I think it would be a good way to reduce volume in emergency settings and hospital settings.
Thank you. Thank you so much. And I'll hand it over to Representative Kristen McCarthy.
Thank you so much, Doctor, for being here. And I appreciated the questions from my good co-chair, and would like to mention that our vice chair, Representative John Michael Parker, said to say hello, and he is out working on some climate bills for us. But in the meantime, I want to thank you for your comments, in particular, how difficult it is for people to talk about how they're truly feeling, and how so often in this world it's not okay to not be okay. And what you're saying and what I want to say is it's okay to not be okay, which I think is a book that someone is sharing with me. So but it's okay to not be okay. And I also want to thank you for reminding us about 988. I will often use the opportunity to do brief commercial announcements. Don't forget, 988 is available. I think something that you just shared is also something I wanted to underscore, which is that you trust, as a medical provider, those in peer respite centers who are working with those who are coming in to call when it's medically necessary. And as we've heard testimony today, it occurs to me that the fear or the liability is part of what occurs, because there's a sense of concern that people might be at risk of harm to themselves or others. And I appreciate you sharing that with us. And I think that's an important point. The question I have, I know I'm finally getting to my question. One of the things you said in testimony was that peer respite is separate from the continuum of care, and it's important that it remain that way. Can you just put a few more sentences on that statement and talk about why that is?
Sure. It has to do, as I was alluding to earlier, a sense of comfort speaking about one's full experience. There's a limit, understandably, to what people feel comfortable sharing with a person who has statutory authority to invoke involuntary or coercive practices. I completely agree with you. It's okay to not be okay. But it's risky to not be okay in front of a person who can fill out a peer, a police form or a APRN form or a PEC, all the forms by the state that result in loss of liberty. And that's been true for much of the existence of our country. So it's part of our culture that people know not to say certain things. And it saddens me because I can be most helpful, just like any other physician, when I know what's really going on. But that's a place, peer respites are a place where they can get down to the nitty-gritty about what's really going on and actually work through the problems.
I really appreciate you highlighting that. It's counterintuitive, isn't it? When
It
we-
really is. It took me 10 years as a practicing psychiatrist to wrap my head around this. But when I did, it finally clicked.
Right. When people need the most help, they are sometimes most afraid to tell the full truth because there isn't that sense of trust. And ironically, the sense of safety, which is what they need and seek. And it seems that so much of it is about judgment. Although I often say here too, it's not about assuming intent. I think providers are trying to keep people safe, but this is such an important tool. And I think the conversation with you has been really helpful in highlighting some of these really important pieces. Thank you, Mr. Chair.
Thank you. I see the hand of sorry, I was going to say Dr. Representative Reddington Hughes.
Oh, you're on mute.
Muted. Can you unmute? There.
Thank you, Doctor, for being here today and sharing these really great observations with us. A common thread this whole day is that really our mental health, procedures that we have in place right now really are not working. And my question has to do with, the peer approach and the mental health system itself. I mean, is this our only way through? Because if we treated mental health the same we do as physical health, I don't think that we'd be having this conversation.
I think peer respites are a start. I think they're a necessary starting place. They're literally physical spaces where people can go. But yes, there is a great divide between how we handle crisis situations in medical crises, surgical crises, substance abuse crises, and mental health crises. They're just, the laws are different. So that guides practice. And while I believe in the necessity, it's important to be able to support someone when they can't make decisions for themselves, and to help people through a difficult time. Yeah, things don't work. Things aren't working perfectly all the time. It's a big conversation that I think we should have.
And if I'm understanding correctly, there still seems to be quite a stigma attached with just the reach out for mental health services in general.
Perhaps, I think a lot about what is the underlying cause of stigma. And when people are in a position where they're not sure if they'll be forced to do something or go someplace where they don't want to go, that can stigmatize the conditions that are associated with that. It's not true for medical situations, that there's this loss of liberty that's at stake. But I think the stigma, there's a lot of different reasons for stigma, but I think one of them relates to the lack of freedom to speak freely about what people are feeling.
Well, thank you for speaking on this and for giving those that are in crisis hope without having to lose their liberties.
My pleasure. Thank you.
Thank you, Doctor. And Nathan, seeing no other comments, I just wanted to share with you that you are an amazing psychiatrist. I can see you've got empathy, you have kindness. And so you're welcome to come to this committee. We are ready for any therapy you may recommend for us after the end of the session.
I regret that I couldn't be there in person. Thank you very much. It's a
Welcome.
pleasure to be here.
Okay, we move on to the next person. That is Dr. Nancy Stanwood. Welcome.
Yes, hello. Can you hear me?
Very well.
Excellent. Thank you so much. Senator Anwar, Dr. Anwar, Representative McCarthy Vahey, and honorable members of the Public Health Committee. I am Dr. Nancy Stanwood. I'm a board certified obstetrician gynecologist with over 20 years of experience in medical practice, and I serve as the Chief Medical Officer at Planned Parenthood of Southern New England. I'm here today testifying in support of Raised Bill 5424, an act prohibiting adverse actions against healthcare providers for providing certain healthcare services. As the state's largest provider of family planning and sexual and reproductive health care to over 45,000 patients last year at our 14 health centers across Connecticut, Planned Parenthood believes that all people should have access to high-quality, affordable health care as a human right, regardless of who you are, where you live, your income, or if you have insurance. I would like to thank this committee and the Connecticut General Assembly for taking swift action over the past 2 sessions to expand access to essential reproductive health care, including abortion care, and to safeguard the healthcare professionals who provide this care. I'm here before you again today to ask for your support to ensure that patients get the healthcare they need when they need it. This bill would protect healthcare providers who offer medically accurate information and counseling to their patients and provide needed health care in line with the accepted standards of care for their patients facing pregnancy complications. The goal of this bill is simple: to ensure that healthcare providers do not face disciplinary action for providing evidence-based care and accurate information to their patients. During a time when other states have created climates of fear, intimidation, and uncertainty for providers caring for patients experiencing pregnancy complications, this bill would make it crystal clear that science, providers, and patients are respected and protected in Connecticut. And it would also serve to correct an imbalance in how we approach the issue of conscience in medicine. Historically, both federal and state governments have protected negative conscience, that is, protecting healthcare providers who opt out of providing care that violates their sense of conscience. This bill would protect positive conscience. What is positive conscience? I exercise my positive conscience in my medical practice by providing abortion care, which I see as a human right to dignity and bodily autonomy, and which my conscience compels me to provide. If I were forced not to provide abortion care, I would be morally injured. This is not theoretical to me. Many years ago, I was called on emergently to care for a patient hemorrhaging dangerously at 3 months of pregnancy, where the life-saving care the patient needed was abortion care. The patient was at a hospital that forbid abortion care, and I needed special permission to provide the emergency abortion. How dangerous for the patient and how morally agonizing for me would it have been if the permission had been withheld? When a patient goes to the hospital, they should be confident that their healthcare provider will be allowed to provide the best care possible without fear of reprisal. This bill will support patient-centered, evidence-based standard of care practice that protects the integrity of the provider-patient relationship. I strongly support House Bill 5424 and respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably. Thank you for your time and consideration of this critical legislation. I'm happy to take any questions.
Dr. Stanwood, thank you so much for your very well articulated testimony. I love the framing of negative conscience and positive conscience, and also reminding us of the issue of pregnancy complications, which I had referenced earlier in questioning and speaking with another person who is here to testify. We have a question, Representative Dauphiné.
Thank you, Madam Chair, and I thank you for your testimony today. I just wanted to make a comment that really what this bill does is it doesn't allow the Catholic institutions to opt out with their conscience And that's, I think, the troublesome piece of this, but thank you for your testimony.
Thank you very much, Representative Dauphiné. Thank you for being here with us, Dr. Stanwood. We appreciate your time today.
Yes, and I would want to just add to what Representative Dauphiné said. To my mind, this really is about the patients and making sure that they are able to get the care they need when they need it, and they're able to be safe, and they can trust that their healthcare providers will not be gagged or threatened for providing full counseling and evidence-based care. Some people might say that if a doctor doesn't agree with some restrictions at a religiously affiliated hospital, that maybe they shouldn't work there. And that's certainly true. But patients go where there's the closest hospital. Patients don't necessarily recognize that there might be limitations on the type of care that they could receive, particularly in an emergency when the ambulance might take them to the closest place. So I think it's really critical to center patients in this, that this is about making sure that patients have access to safe, evidence-based care.
Thank you, Dr. Stanwood.
Thank you. And seeing no questions or comments, we appreciate your testimony. Thank you so much.
Thank you very much.
And the next is number 37, Megan Scherer. Welcome. Thank you for being with us all day.
Hello, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Megan Scherer, and I'm the Policy Advocacy Manager at the Hispanic Health Council. I'm here to testify in support of SB 370 peer-run respite centers. The Hispanic Health Council is the largest service provider for the Latina community in the state of Connecticut. Our mission is to promote equity and address health disparities for Hispanics, Latinos, and other vulnerable communities through research, advocacy, and culturally resonant services. The community at the Hispanic Health Council is predominantly Latino, Spanish-speaking only, and undocumented. Throughout their lived experiences, they have faced immense amount of trauma, but have limited resources due to being uninsured and the language barrier. Oftentimes, with this immense amount of trouble, they are struggling with their mental health, but do not have access to care. When they do find a therapist that speaks Spanish and takes uninsured clients, they end up being put on a wait list for months due to the limited resources of bilingual and culturally appropriate therapists. And so they're on these wait lists for months, and their mental health often worsens. The next option is to go to the hospital, which could lead for them to be forced into inpatient hospitalization. And when inpatient services happen, they're very rarely culturally relevant, nor provide services in any other language besides English. Being forced into hospitalization in conditions that are not culturally relevant, nor in your language, only creates more trauma and makes it more difficult for people to recover. This is why I believe peer respites would be a great service for the Spanish-speaking community in Connecticut. This would provide the community a space where they can articulate in their native language what is happening, as well as someone that understands their culture. Because a lot of the time in the Hispanic and Latino culture, mental health is very taboo, and it's a difficult thing to talk about. So to have people that can understand in your culture what is happening and help you articulate your feelings in a non-judgmental mental way and meet where you at would be an incredible thing to have for this beautiful community I work with. And I don't have to go on the statistics or data. It's in my written testimony. People have shared it today, but I just think this would be an absolutely incredible thing for the community I have, because I know they are struggling. There's limited resources, and they are working every day so hard, and there's oftentimes no help for them. Peer respites will not only help the Spanish-speaking community, but also the Black and Indigenous people of color, transgender, queer questioning, intersex people, and people of other marginalized gender identities, and for those that hospitalization is not the support they need when experiencing a mental health crisis. These peer respites provide more humane, community-based mental health services. 15 other states have passed peer respites. Now I believe that Connecticut should be the 16th. Therefore, I'm asking that you pass SB 370 and create peer-run respites in Connecticut. Thank you.
Thank you, Ms. Chair, for your testimony. It's very helpful. Can I draw a parallel to this and just for the sake of a brief conversation?
Yeah.
You know, there's this data that came out that if in the school system, a teacher is of the same ethnic background, the outcomes for the children is much better. Their likelihood of going to higher education and then becoming professional world, if that's the right thing, that their likelihood is much better. So there's something about affinity that shows itself in different ways. Do you see that there's something about that same affinity is leading to better outcomes in communities?
I 100% agree with that. Pretty much a majority of the staff at the Hispanic Health Council, there's very few that, like me, is white and works there. We are majority Hispanic and Latino Spanish-speaking workers. And we have community health workers that do maternal health, like doula programs and midwives. And this, we just see an absolute increase in trust in the system, as well as also positive results that don't lead to death that often happen when they don't have someone that understands the language or culture. We just see an immense amount of more positive experiences with systems that often the community I work with does not trust, because they have someone in the room advocating with them for them and helping them understand what is happening. And it is so important just to have someone that looks like you and speaks your language in the room with you, so you are more comfortable and you have more trust in the system.
And along the same lines, there was this conversation about a respite for LGBTQIA. Do you foresee different communities having their own respite centers, or they should have people of all different backgrounds who can help out when?
I think it's beautiful to have people that look like you, speak your language, and also understand the experiences that you're going through to be provided that care. So as this bill expands, to see more respites for more affinity groups, because I think that will have a huge impact on the treatment of the person, as well as the success that they're able to live their life with dignity and justice and have all the support they need and continue daily knowing they have a support system that they could go to that is not going to lack understanding, not because of education, but lack understanding because they don't know the background identity and because they don't live that identity.
Thank you. This is very powerful, very helpful for many of us. So I appreciate you being here and thank you for your testimony. Seeing no other questions, we'll move to the next person on our list.
Thank you.
Which is Emma James Burke. Ms. Burke, you're on.
Hello, esteemed members of the Public Health Committee. My name is Emma James Burke. I use they, them pronouns. I am a non-binary person in recovery here to advocate for SB 370. I co-instruct Advocacy Unlimited's peer recovery support specialist certifications and training program, and I co-facilitate an Alternatives to Suicide support group. Peer-run respites make room for nuanced human experiences. Like many people, I have often minimized feelings of suicidality out of the fear of a carceral response. We fear that if we seek support, well-intentioned people might respond by insisting on psychiatric inpatient programs. This disconnects us from the supports we do have in our lives and can rapidly escalate those feelings. In Alternatives to Suicide support groups, we're able to navigate these experiences without fearing our consent will be violated. We find healing in our communities. This model is practiced in peer respites like AFIA in Massachusetts. Peer-run respites offer the possibility of affinity spaces. For trans people seeking recovery through inpatient programs often carries greater risks. I'm here today to advocate for trans people who are afraid to share their stories about inpatient settings. Trans people experiencing non-consensus reality have been denied hormones they took before hospitalization, causing emotional distress and physical changes. Trans people experiencing suicidality have had to leave treatment for their safety when other participants have become fixated on them for being transgender. Trans people have been unable to participate in group therapy and even the most basic stabilizing activities, like eating lunch among their peers. Trans women are especially affected by this, and it shows in their high rates of death by suicide. Peer support by and for trans people will give us opportunities for safer, more active participation in recovery services. Peer-run respites are the brave choice. 15 other states have peer-run respites. Instituting 8 peer-run respites, including affinity spaces for Black, Indigenous people of color, trans, queer, and intersex people in recovery, and Spanish-speaking people seeking recovery, would make Connecticut a national leader in the evidence-based practice of providing recovery support services through peer-run respites. Inpatient programs might seem like the safer choice, but the facts show people often experience an uptick in suicidality after discharge. For better outcomes at a lower cost, invest in this program. Thank you.
Thank you so much for your testimony. This is very helpful. Could you just explore that a little bit further with me, that you're saying that after the inpatient admission in a psychiatry unit, the risk of suicidality goes up?
Yes. I have on me a fact sheet. I believe it's 100 times more likely to die. Yeah, people are the general population after inpatient, right, is nearly 100 times more likely than average to die by suicide following discharge from psychiatric hospitalizations. And the rates of suicidality and suicide attempts and completion of suicide is much higher in the transgender population. So while I don't have a specific figure for how likely it is for trans people to die by suicide following discharge from psychiatric hospitalization, I imagine that must be higher than 100 times more likely.
Okay, I thank you for your testimony. Really appreciate you being here with us. Thank you. Seeing no other questions or comments, we'll move to the next person on the list, which is Mindy Wallen.
Thank you.
Welcome.
Hello.
Yes, you're on.
Okay. Good afternoon, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Mindy Wallen. I am a certified recovery support specialist and the parent of a young adult with chronic mental health issues. I'm here to testify in support of SB 370, peer-run respite centers. As a parent of a 24-year-old with a long history of psychiatric hospitalizations, I have witnessed the value of peer support services firsthand. After a string of over 20 psychiatric hospitalizations between the age of 13 and 15 years old, it was a wraparound intensive in-home program that provided peer support services to my family and my child that interrupted the never-ending cycle of ineffective and traumatic treatment programs and allowed our family to heal and find footing in recovery. At 17 years old, my child courageously came out as non-binary, gender non-conforming. It was then that I decided to move our family from Texas to Connecticut in search of inclusive, safe spaces as they moved into adulthood. While I've been impressed with the mental health and social service supports available in Connecticut compared to Texas, it has been challenging to access ongoing mental health supports that are safe and informed for young adults who are members of the LGBTQIA+ community. We have powered through in isolation at times when intensive treatment would have been beneficial, fear of adding additional trauma in existing treatment settings. I've witnessed the consistent misgendering, lack of education, and all judgment my child has experienced while accessing medical and mental health services. I do not blame them for being afraid to seek treatment, knowing they will not see themselves reflected in their treatment team or peer groups. I also know that the invasive and often restrictive approach to inpatient hospitalization is not what my child needs during times of crisis. What they need is a safe, supportive, trauma-informed environment that will provide encouragement and companionship while they work to stabilize. This is the spirit of peer respite centers, and I cannot emphasize enough what a game changer having access to this type of programming would be for my adult child, and honestly for me as their sole source of support. Therefore, I am asking that you please pass this bill and create peer-run respites, including specialized centers for transgender, gender expansive, BIPOC, and Spanish speakers in Connecticut. Peer respite centers are in the cutting edge of trauma-informed mental health care. They're cost-effective and proven to be successful throughout the country. I wake up every day to stories of young lives tragically lost due to a lack of support and outright hatred directed to the LGBTQIA+ community. The fear I have of losing my child too early is real. Passing this bill will bring us one step closer to peace of mind and hope for a brighter future. Thank you for this opportunity to speak and share my lived experience.
Thank you so much, Ms. Wallen. We appreciate your testimony, and I'm glad you're in Connecticut. Are you connected to the right resources right now?
Yes, yeah,
Okay.
we're very well connected. And like I said, I do have the recovery support specialist certification. So, but in spite of all that, there's, this type of peer respite would be a great help. There's been a lot of interruption to my child's, education, ongoing career, vocational supports, having to take a break to go into more structured programs has really held them back quite a bit.
Yes, we hear you very clearly. Thank you so much for your testimony. Seeing no questions or comments, we'll move to the next person on our list, which is Margaret Watt. Welcome.
Thank you, Senator Anwar, and good afternoon, Senator Rep. McCarthy Vahey and distinguished members of the committee. My name is Margaret Watt, and I'm here as the Public Policy Chair of NAMI Connecticut. With much thanks for raising Senate Bill 340 as a bill that would bring peer-run respite to Connecticut. I'm here because NAMI Connecticut strongly supports this bill. We've watched in recent years as Connecticut has worked to respond to the nationwide mental health crisis by rolling out the 988 system. We've seen significant work done to raise awareness of the hotline, build out mobile crisis, and support inpatient access. Most recently, the state has invested in establishing immediate behavioral health access for youth through the urgent care centers. What we believe has really been missing is building out the full continuum of care, having a vision of a mental health system that serves everyone with no wrong doors, but the right door for the right need for each individual person. So a full continuum of care means we need alternatives to inpatient programs for people in crisis because not everyone wants or needs to be hospitalized. A full continuum of care means establishing immediate access to support for adults in need because crisis is not limited to youth. It means having programs for people who have specific needs, like Spanish speakers, aren't an afterthought, but are fully supported. This is where peer-run respite comes in. Peer respites, as you've been hearing throughout today, are a low-cost, recovery-oriented, evidence-based model that provides a safe and trauma-informed place for adults experiencing a mental health crisis. Note all those adjectives I used. As you've been hearing today, psychiatric hospitalization is generally not low-cost, nor is it usually recovery-oriented, not necessarily safe, and many people are no better upon discharge than upon admission. In fact, many are still suicidal. You're hearing a lot of testimonies today where people are sharing their personal experiences of feeling forced into care, traumatized, or marginalized by psychiatric hospitalizations to the point where they avoid behavioral health services or even give up on life. Nobody wants any of that. I also want to acknowledge that not all psychiatric hospitalizations are involuntary or traumatic. So here's another example. I have a friend who has had lifelong treatment-resistant depression. She lives alone and she has no family support. When she becomes suicidal, she checks herself into a hospital voluntarily, not for therapy or recovery, but simply to have a safe place to stay because there's nowhere else for her to go. So what an expensive treatment model that is. I think the fact that the Connecticut Hospital Association and the IOL at Hartford Healthcare are testifying today in support of peer respite shows that our psychiatric providers recognize the need to provide options for adults in crisis. We know no one program model fits all needs. Our neighbors in New York, New Jersey, Massachusetts have all developed respite programs to respond to the need, and it's past time for Connecticut to do the same. So we ask that the state establish and fund peer-run respites to serve our adult population, giving them others to connect with who can understand and support them due to their own lived experiences and training. We also ask for at least one peer respite for our large Spanish-speaking population. It's unrealistic to expect anyone's emotional needs to be met in an environment where at best they're having a language line translator for them. You've got to be able to communicate. We also ask for a respite for the transgender.
I'm sorry,
care-
Ms. Watt, but your time is up. Thank you.
All right, thank you.
Why don't you just complete your thought?
Just that we also do need an affinity respite for the TQI population. And Senator Anwar, I heard you ask a minute ago about the suicidal statistics in the TQI population. 40% of that population made a suicide attempt, according to the most recent data.
Wow. Thank you so much. We do have a question. In some of the other states, are you able to speak to the 14 or 15 other states that have this law?
I really can't give too many examples. We had a speaker from one of the Midwestern states at NAMI Connecticut's educational conference last year. But I'm not sure if you use the term law, and I don't know whether there's a law about this in every state, or in some places they've just stood up the service.
Okay. Can I just ask you a question to have a better understanding of where the respite would fall in the continuum of care? So I'm just going to say a few things and you can correct me if I'm inaccurate. So there's a person at home, there's an outpatient, they would have a psychiatrist, they would probably get respite at the same time, but they may need intervention from medications and conversation from the existing system. And if it becomes more significant, there's intensive outpatient care. And then during the course of that, a mobile crisis unit can come in if there's help. But the mobile crisis unit or the calling of the 988, there's a potential of a triage to the mobile services versus the 988. If there's a formalized system for respite care, they can divert the person directly to the respite care. Is that kind of the model that has evolved in other places? Is that what you foresee?
Beyond that, so people can self-refer and not have to go through the 988 mobile crisis options at all. I feel like the system you're describing could also exist, right? There can be referral, there can be self-referral. I almost feel like you were describing that graphic that was going around the state when 988 was being rolled out a couple of years ago, and it showed, this percent of people will be taken care of on the phone call, and this percent of people will go to mobile, and this percent of people will be sent to a facility. And on that graphic, if you know the one I'm talking about, it actually lists crisis and respite as post-crisis options without referring to pure respite either. So the true access to a respite care should be, I'm about to experience a psychiatric breakdown. I recognize the symptoms. It's happened to me before. Like my friend that I referred to, I am going to check myself into the respite proactively. Why do I need to call mobile crisis? Why do I need to call 988? And at the same time, some people are calling 988, or mobile might say to them, how would you feel about going to this place? I think it's the no wrong door approach.
This is very helpful. Thank you. Appreciate your testimony, and we could probably talk about this topic for a long time, but we've got a lot of other issues that, my co-chair does have a question.
Thank you, Mr. Chair. Hello, Margaret. I just
Hey.
to say thank you, and it's wonderful for everyone else to see what a rock star you are. I knew you would have the data, and you're a great resource for us as we continue to explore this, along with so many of the other folks who are here in this room, who I'm looking at now, and who've been here all day with us. We were commenting earlier about what a well-organized group this is, and I want to thank you for your efforts for so many years. Thanks, Mr. Chair.
Thanks. And if I can just, I want to give huge kudos to Keep the Promise Coalition for bringing this whole issue together in the coalition that you cited. And I also want to thank you, Rep. McCarthy-Vahey, for being at the forefront of peer issues since you were first elected, and we worked together on that first bill to try to make peer support reimbursable. So thank you.
Thank you. Seeing no other questions or comments, we move on to the next person on our list, which is next Liz Gustafson. I was looking at you on remote, but I'm thinking we're going to see you, or you can dial into Zoom from there. Welcome.
Hi, good evening, afternoon, technically, happy hour. Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Liz Gustafson, and I am the Connecticut State Director of Reproductive Equity Now. Thank you so much for the opportunity to testify in support of HB 5424. Reproductive Equity Now works in Connecticut and across New England to make equitable access to the full spectrum of reproductive health care a reality for all people. In a post-Roe world, Connecticut continues to make significant progress to protect our state's healthcare providers who are doing all that they can to provide medically accurate and compassionate care to their patients. In order for us to continue meeting this moment, it is paramount that we continue our bipartisan efforts to break down barriers and protect the providers who are offering this life-saving care. Anyone seeking comprehensive sexual and reproductive health care should be able to expect information regarding their health, counseling, and medical care that is in line with clinical guidelines and best practices. And providers should not be limited or barred from providing such information or care. Just as Connecticut led the way by enacting the nation's first SHIELD law to offer a critical layer of protection for reproductive and gender-affirming care providers, HB 5424 would follow through on our state's commitment to protecting providers at all healthcare institutions. I do want to clarify what this bill would not do, which is ban religious objections to reproductive care, and it would not force individuals or institutions to provide care that is against their moral or religious objections. Rather, what the bill does do is provide employment protections for providers who choose to share medically accurate and appropriate information with a patient about their health status, recommended treatment, or possible referrals if needed. The bill would protect these providers from discipline, retaliation, or other discriminatory action by their employer for offering medically accurate and appropriate information to their patients. It would also align Connecticut with federal law to ensure that providers at all healthcare institutions are not prohibited from providing timely and life-saving treatment for pregnancy complications, including treatment of ectopic pregnancies and miscarriage management. If failure to do so would violate accepted standards of care. Any delay in seeking time-sensitive reproductive health care, including pregnancy-related care, is a threat to public health. Institution-wide policies that inhibit providers' ability to follow clinical guidelines and provide medically accurate information, counseling, or relevant referrals not only undermines the patient-provider relationship, but also undermines the patient's agency when it comes to making an informed decision about their own health. Providers must be able to empower their patients with the medically accurate information and resources to make fully informed healthcare decisions, as well as referrals for relevant or recommended services available elsewhere in the community without fearing discipline. Reproductive Equity now urges the committee and Connecticut General Assembly to pass HB 5424. Thank you so much for your time and consideration.
Thank you so much for your testimony. You just heard the testimony from Mr. Wolfgang earlier, and their reading was that if the institution has taken a position, the clinician who's going to work in that institution has, in some respects, promised that they're going to follow everything that the institution wants. And we were not able to connect on the patient's rights and the clinician's rights perspective. It was more of the institution's rights. Can you break it down and how you see it to counter that argument?
Yes, this bill and this legislation is clearly a provider protection mechanism. And to ensure that providers who choose to provide that medically accurate care and meet that patient where they are, that they will not face repercussions for doing so. Again, as mentioned, any delay in accessing time-sensitive, essential reproductive health care, such as pregnancy-related care, is a threat to public health. And this would protect the providers that continue to show up for their patients and seek and want to show up for their patients, and ensure that their rights are protected as employees of these large institutions.
So go ahead.
Thank you, Senator. I'm certainly interested in any other questions you have. Liz, thank you so much for being here with us and for your work together with so many in the state and beyond. Are there other states who have enacted similar legislation?
Yes, it is Washington, I believe, particularly the part of the bill that ensures institutions do not prohibit their providers from providing timely, essential treatment for life-threatening pregnancy complications. So,
one of the question was, it almost appeared from the earlier testimony that any clinician who is working there is given a gag order on options in certain kind of care. Is that how you heard it too, or is just me hearing that?
Yeah, providers who may work for institutions with different moral or religious beliefs are essentially barred from providing medically accurate information or care that is aligned with the standards of care. And this bill is essentially a mechanism to ensure that their speech and their constitutional rights are protected and that they are able to continue doing their job and following their ethical and medical standards.
And there was another statement made attributed to a columnist stating that the fact that we are trying to protect the clinicians providing the care or making the appropriate recommendation if necessary, and not mandated, but if necessary, and then saying that this was against diversity in every shape or form. How does, I was having difficulty understanding that. So were you able to explain that or help in understanding if that's against diversity?
I also have a difficult time understanding that perspective.
Okay. All right. Thank you so much. I appreciate your testimony, and I'll see if anybody has any questions. Seeing none, thank you so much for being here. Thank you. The next person is on line number 43, Earl Miller. Welcome.
Oh, hello. I apologize for my video being dark. I'm the Director of Community Supports at the Wildflower Alliance, where the respite in Massachusetts is. But I'm actually calling today to talk about my experiences staying at AFIA, which happened about 8 years ago, and how that was different from what I'd experienced at traditional providers. I had reached a point in my life where things were really, really challenging, and I called and just spoke to someone, waited a few days to get in. What didn't happen that historically has happened for me at hospitals is I wasn't asked to recount every trauma that had ever happened to me, every abuse, every hardship. They just merely took me at my word that things were hard and allowed me to come in. There's been a lot of attention today to the support that staff provide. One of the most helpful things at AFIA was getting to spend time with the other folks staying there, including a night in which I got to listen to someone play guitar for a couple hours, which was really nice. I think it's important that the folks who stay there were treated as equals with the folks who work there, that people were empowered to spend their time how they chose to. One of the things that's missing in our current system is kind of transparency about what it looks like. For some folks, I recognize that a hospital is experienced as a caring place. For folks from my community, it is often a place that we are brought to by police. It feels carceral. You can't leave. You're strip searched in front of someone. And there is no end date. So in some ways, while I think folks think it's a harm reduction to the criminal justice system, at least if you're incarcerated, you know when you're coming home. AFIA was much different than that. It was just a house in a neighborhood. I didn't feel like a potential danger to folks just by being there. It was a place that was kept up. There was backyard space to go outside. The folks who worked there were responsive, and I could wake up at 2 o'clock in the morning and have an hour-long conversation with someone if that's where the day led me. And when I left there, they didn't give me a sheet full of referrals to places that weren't going to be able to take me anyway. Folks talked to me about being able to come back if I needed to, and they talked with me about the resources that they were aware of and that I could call back if I needed more support. One of the nicer things that happened is that Christmas, which was the first one I'd spent with my children, spending most of their time in a different state, they invited me back to the house to have a meal with folks. It isn't just a place you go for once. It's a place that really supports you after that. And I've heard folks talk about the workforce developments. I know this has been a long call and I will not try to extend it. But a lot of the folks who work there stayed there. It is a place that generates its own staff by the way it treats folks. And I can speak as someone who spent a lot of time in hospitals. When someone finally treats you like you matter, like you are deserving of dignity, it's a place you want to spend some time with. So not only did I have that experience, but I've also then came and worked at this community and fed my family off of this experience. So I think Connecticut deserves respites. I'm someone who spent about 12 months of my life in St. Francis in Portland, Connecticut. And I know that even back then, there were folks talking about creating more humane opportunities for folks. When you're struggling, it shouldn't all look like locked doors and potential restraint. There has to be something more, and folks deserve it. And I think you'd be surprised that some of the folks who find themselves in the most strictest places might be much more responsive to places that allow them to go home. I was able to go work and do things in my regular life while I was there. It was a game changer for me. So I guess I'll stop there.
Thank you so much. Appreciate your testimony. So there's one is the peer respite treatment, but the other thing is that you are also connected in so many ways that group is also a group that you want to spend more time in, not necessarily during crisis, but in the absence of crisis. Is that the sense I got?
Yeah. Yeah, I would posit that a lot of what we consider mental health conditions are really a lack of community, a lack of feeling like you belong and like there's a place for you. And AFIA solved many problems for me that were temporary, but the long-term one was that I had a group of people who 9 years later continue to care about me and invest in me, and that has been more meaningful than anything else.
And there's a separate bill we'll probably have a conversation of in future. There is a part about loneliness in there. So the question is that is loneliness and lack of purpose a component of the issue? And then when you're connected with your peers, that sort of improves, and that is part of the therapy and improvement too?
Yeah, I would argue that it's a byproduct of what traditional cares look like. They tried to keep me so safe that I wasn't allowed to participate in my community, and feeling like not just that other people care about me, because any provider will care about you while you're there, but that I matter in the long term, that the mere fact that I exist. And we know that peer-to-peer supports work. We don't have this conversation in the recovery community because we know that AA and NA work for some people. In the mental health system, we have pretended for too long that somehow some medication is going to solve what is largely a social ill. You're far more likely to be homeless, to die early, and then people in your community see you as someone who is potentially volatile, because all you hear in the media about folks like me with a mental health condition is that we might be potentially violent, despite no data saying that.
Thank you. Appreciate your testimony. Oh, we have a question from my colleague. Go ahead, please.
Sorry, Mr. Chair,
Representative.
I didn't mean to go after you. I just wanted to really thank you for, it's more of a comment than a question. I really wanted to thank you for your testimony today, because I think that you have so well summed up so much of it and exactly what the bill is trying to get at. But most specifically, that last piece that you said about how people with mental illness are portrayed in the media, I think it is really difficult because, especially because we have folks who, when they see gun violence, immediately say, well, they must have been mentally ill. You know, it leads us down a path when in reality, if we are actively building community for a variety of groups, there are so many social ills that we really, I think, could be, you know, warding off. So I just want to thank you. And I also want to congratulate you, because you're clearly in progress and have made so much progress. And I just think that's wonderful. So thank you so much for sharing your story today.
Thank you. I hope that if nothing else, the last few years, which have been full of pain and despair for lots, have taught us that all of us are capable of having a very, very bad day and feeling very, very hard things, and that the only solution to that has ever been empathy. Everything else is just a bandage.
Thank you, Representative Kavros-Tigraw. Representative Wielander.
Thank you, Mr. Chair. Thank you for your testimony today. And I just want to sort of give a shout out to Western Massachusetts. It's where I grew up, and I'm really proud of the work that people have put into bettering our community in that area. And I'm excited to see that Connecticut might be taking steps forward as well on this area. But I think you made it clear with your testimony that this type of support made a huge difference in getting you through that difficult time. But what I really would like to hear is, has the presence of the, is it Althea House? If I'm pronouncing it?
Yeah.
Is the presence of the house in the community, do you think that has changed how the area responds to people who might be in mental crisis, a mental health moment of crisis?
Absolutely. So I'm someone who, in addition to the role I'm in, has occupied several roles. I worked for state government, local government. I've worked in public safety. And in all of those spaces, there has been real benefit to AFIA. But I would also encourage any of you who get the chance, come out and see it. It isn't that far from you. The neighborhood is glad to have it. People are excited to have a property that people care about, to have people in the neighborhood who see themselves as part of the community, not just this isolated thing there. And I've heard folks today talk about why people don't reach out for help. And one of the reasons is once you ask for help, there's no way to unask for help. When you are in a psych ward, you are there till they're done with you, regardless of if your kids need you or your family needs you or your job insists, you are there. And to pretend as though somehow your problems are going to be compassionate and solve themselves while you're there is a little bit of an illusion. While I was at AFIA, I was able to do lots of productive things to make the day a victory, as well as kind of the long-term things. And I think for folks in the area, having a place that isn't going to treat you as less than, I also think it's quick ad here is providers go to AFIA too, to pretend as though people working in the mental health field aren't impacted by it and also don't need spaces to go that isn't going to affect their employment is really challenging. This is a space that's open to all folks, and I think that's really important, and all of us may find ourselves in need of this place at some point.
Thank you so much for expanding on that. I think you've made it very, very clear that not only does this help people who are seeking care in those times, but also it helps reduce the stigma and build stronger communities for everyone. So thank you so much for your time. Thank you, Mr. Chair.
Thank you. I just wanted to, Representative Wielander's question triggered a question for me, and I just wanted to ask that. Have there been situations where the planning and zoning locally in the community have made it more difficult? Connecticut is an interesting place where we have sometimes issues with the planning and zoning issues. Any thoughts on that?
Yeah, so I'll say I wasn't around for this period of it, but what I know is that when they opened AFIA, they brought cookies to the neighbors. They did an open house for folks. There was a lot of work done to ingratiate themselves in the community and to act as a new community moving into the neighborhood. I think certainly there have been moments where the community is concerned, and a lot of that comes from you hear about someone with a mental health condition committing an act of violence somewhere, and you wonder, are those folks in my community? And I think the better question is, aren't those folks in your family? Aren't those folks in your workplace? Those folks are everywhere, and the vast majority of them don't commit violence. So when that comes up, I think you'll find, particularly the Wildflower Alliance, our community is always going to be eager to have those conversations with folks and to see our neighbors as either current partners or partners who just haven't quite gotten the chance to have that conversation yet. I think that spirit of togetherness is always going to be really important in this.
Thank you so much. Appreciate you being here. Seeing no other questions or comments, we'll move on to the next person in our list, which is Wilder Ebert. Welcome. Take your time. Thank you for being here with us this morning, afternoon, and I think moving towards evening. Can you turn the mic on? Perfect. Thank you.
Thank you. Thank you, Senator Anwar, and members of the Public Health Committee for taking the time to hear my testimony today. I am here in support of SB 370, an act regarding peer-run respite centers. My name is Wilder Ebert. I use they, them pronouns. I am a non-binary trans person and an individual of the LGBTQIA+ community. I am also a rare disease patient with chronic illness, and I'm fully disabled resident of West Hartford. I am living with both physical and mental health issues. I lost my job to disability in 2019, and my life was upended, and I found myself needing more support, which led to my first encounter with residential mental health services. I went through over the course of the years, a series of attempts to get critical mental health services in a system not equipped to handle those with physical health issues in the form of chronic illness and especially rare disorders. I quickly learned that mainstream mental health programs themselves, a tough love approach, often assumed that substance abuse was critical to mental health services as well. With someone like myself, that couldn't be farther from the truth. In fact, this approach actually led to a rapid decline in my physical health, and with withdrawal of medications, while requiring those for substance abuse, which I did not need. There's been earlier testimony today regarding lumping those two things together, and I strongly do not approve that. I spent many times in inpatient services and hospitalizations, both in Boston, Massachusetts, Brattleboro, Vermont, and Los Angeles, California. And those programs were detrimental to my mental health and well-being. They were a sense of entrapment and fear. They were very judgmental, and they created more trauma than they helped. I found myself increasingly suicidal after each failure to find help, and this led me to voluntarily going to emergency departments for psychological help, which you've heard testimony on earlier today, throwing me into a place with bars on the windows, shoelaces taken away, violent individuals, no contact with family. I feared for my safety, and I was forced to take medications and things that I did not need, that weren't identified, and I couldn't refuse them. I suffered from complex PTSD, including medical trauma, as a large part due to these experiences. Purple Pod to this day creates trauma. With options exhausted, I became desolate and went through a series of well checks through police, and that created more trauma and fear. In desperation for help, I started enrolling or tried to enroll in online mental health programs, but was told if I couldn't guarantee my participation in all classes, that I shouldn't enroll because of a tough love policy. I couldn't guarantee this, and therefore was refused enrollment. It was about this time that I came into contact with Ripple and Jeff Santo and learned about Pure Respite programs. When I looked into these programs and found AFIA, I immediately submitted my application, and within a week, I was in the AFIA program. This model saved my life. It was a very simple support model, but it removed the barriers to accessible care that I had encountered in all the mainstream programs. I had looked everywhere for everything. Here I had 24-hour support with trained peers. I had access to my own medications and food so that I could continue my self-care as needed. I had access to my phone, my family, my support system, my therapist. I could continue with my appointments with them. I could come in and go like an adult and was treated with respect. Peer respite programs provide access to those like me who are below the poverty level and cannot afford the cost of other care programs, whether they have insurance or not. This did not require insurance reviews, prior authorizations, intervention from medical professionals, referrals, etc. I was able to request my own intake on my own time when I felt that I needed them, and they were there for me. Peer respites are accessible, they are affordable, they are evidence-based, they are personalized, they are minimally intrusive, and they allow a person's social life and work balance to remain intact. They are less humiliating, more private, they are trauma-oriented and non-clinical.
Excuse me, Ms. Rowan, but your time is up. Thank you.
Why don't you complete your testimony, please?
Thank you.
The remaining part.
Because of these things, I was finally able to find the care that improved my mental health services, a sense of safety, adaptable to my complex needs, my reduced stress of fear and in accessing care, decreased suicidal ideations, and a sense of hope, not shame. I fully support a network of Pure Respites in Connecticut. These would provide one of the greatest impacts to the mental health care system here in Connecticut and would make Connecticut a leader in efforts to improve mental health service and accessibility and save lives. Thank you for your time today, and I welcome any questions about my experiences.
Wilder, thank you so much for your courage to share your experience and also help us recognize that our systems, in many respects, rather than being helpful or not helpful, they're harmful. And so initial trigger of a trauma, and then the systems created the trauma to be much significant. And I appreciate your testimony. Representative Tersiak.
Thank you very much, Mr. Chair. Thank you very much for coming here. I wanted to speak because you mentioned something that I think is important. You were able to take your own medications, even your food. I'm really concerned about the medications though, because there are many people who believe that these kinds of places are anti-medication, that if you go there, you're not going to be able to take medication. I was very happy to hear from you that you had a good experience and that you were able to stay on your medication. Clearly, medication alone is not enough for everybody, but for so many people, it's a big part. So thank you very, very much for coming and making that point. I can't thank you enough for it. It's great.
Could
Thank
I
you.
elaborate just a little bit?
Of course.
Part of the reason I was not successful in residential treatment programs that I tried, especially in California, that were substance abuse and mental health combined, was that everybody came in with this model that they also had substance abuse. And they removed medications from my care that were critical to my physical health and forced me to take medications that were related to substance abuse, which I needed none of. This actually made me almost unable to participate in the program, and I lost a week's worth of covered time just trying to adapt to the removal of medications and how ill I was feeling, and the medications that we were giving me was not working. Ultimately, it cost me it cost me disability and further issues with my physical health, declined rapidly upon leaving the program and trying to readjust. And when I was at AFIA, I have a port in my chest and other things. So I was able to take my IV medical supplies with me and be in a private room and still have access to those and wear my backpack with my medical stuff and take all of the medications that I have for my rare disorders, which is quite lengthy. And in other programs, I was not allowed access to those things.
Thank you very much. Thank you, Mr. Chair.
Thank you.
Thank you. We appreciate you being here. Thank you.
You're welcome. Thank you.
And next person on the list is Olivia Rowan in person. Welcome. Thank you for being here. Thank you for your patience. Can you turn your mic on too? Perfect.
Hi, good afternoon, everyone. My name is Olivia Rowan. I'm 23 and I'm a person who has needed mental health services and worked in the mental health field. I'm here to testify in support of SB 370 peer-run respite centers. My personal mental health recovery journey began in the middle school. My parents noticed I had become anxious, depressed, and withdrawn. I saw several therapists and guidance counselors, but nothing helped. When I was 14, I was admitted to inpatient psychiatric care because I was suicidal. What ensued was 6 years of consistent hospital stays in residential facilities. In those years, I experienced improper physical restraint by staff, prolonged periods of extreme sedation, facing punishment if I used a friend's preferred pronouns, and many providers who tried to shame me into recovery. I've seen people lose their jobs in their homes seeking help, left in bed restraints or seclusion rooms for hours, be relentlessly screamed at and had their rights taken away. Communication with the outside world is limited and monitored by staff, which makes reporting mistreatment incredibly difficult. Due to these experiences, I used to hesitate to reach out for help or downplay the severity of my struggles in fear of a misunderstanding sending me to the hospital. I didn't want to scare someone who couldn't understand or call a hotline and end up with police at my door. My illness felt criminalized. A major turning point in my treatment was when I was 19 and introduced my PTSD diagnosis. I was fighting it out of shame and denial. I asked my provider how she would know, and she shared her story. She told me about a traumatic experience in her life and how it affected her moving forward. I had never felt more seen and understood in my mental health journey before. This type of experience allowed me to be more vulnerable in my treatment and let go of shame. I now work with a mentor only who has similar lived experience, and I'm able to be direct about my mental state. I haven't been hospitalized in almost 4 years. Still, there are times when I have the urge to say, I'm not going to hurt myself. I'm just sad today. Just as a reflex, and I have full confidence in the effectiveness of expanding peer services in our state. if I had access to peer services earlier in my treatment or even knew about them. I would believe my mental health journey would not have been as painful as it was or lengthy and expensive. The trust I have in this approach led me to become a certified peer myself. Receiving clinical care can be valuable in mental health treatment. Totally. At the same time, only a person with lived experience can tell someone in crisis that they have been there, right where they are, and they really get it. Therefore, I am asking that you please pass this bill and create peer-run respites to support a more individualized and humane approach to the mental health system in general. Thank you for this opportunity to speak and share my lived experience about this with you. I'm happy to answer any questions.
Thank you so much for your testimony. And I think we are seeing a trend where we are not doing a good enough job in many of the traditional mental health and crisis situations. So my ranking member has a question or comment. Representative Clarity's teacher.
Thank you, Mr. Chair. Thank you for coming here today and telling us exactly what many other people in Connecticut have gone through being in your situation. So it's encouraging to us to see people that have gone through this process. And now congratulations on being a peer mentor yourself. I think it's wonderful to have people, your peers. You get to, like you said, someone comes, oh my God, you went through this. You know what I'm going through. And that's very important. And in the state of Connecticut, we try and pass laws that help people. And before this, going to the ED was your only option. But now we have other options and we see how truly successful those other options are. So I want to thank you again for coming here because your story has touched so many hearts today, and I'm sure will continue with your work as a peer counselor. Thank you.
Thank you.
Thank you. Seeing no other questions or comments, we appreciate you being here. Thank you.
Thank you guys for your time and approaching with curiosity.
Of course. And next is Thomas Burr. Welcome. Good morning, good afternoon, and good evening.
Yeah, I think it's still afternoon, right? Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Thomas Burr. I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. And I am here today to testify in strong, emphatic support of SB 370, the Peer Run Respite Bill. This is actually one of our top issues for this session. As the country's largest grassroots mental health provider, or mental health organization, we know that getting access to treatment in a timely fashion is a key to recovery from a mental health condition. You should have already received the fact sheet from Keep the Promise. If not, we'll make sure you get it. And you do have my written testimony. So just briefly, I just want to touch on a few things that have been brought up during today's legislative hearing. We've had a lot of testimony about inpatient hospitalization, and I'm not here to throw that model under the bus. For some people, that's their safe space. It works really well for some people. But I can tell you from my own personal experience with my son when he was in the throes of his bipolar disorder, it was absolutely traumatic. He at times in inpatient settings was forcibly restrained, forcibly medicated, and on more than one occasion to the point where it just soured him on the whole medical model. He wanted nothing whatsoever to do with inpatient hospitalization, even though there were times he was in crisis and it was really the only option for him. I think if we could roll back in time and this peer-run respite model was available, it would have been a much better fit for him. And unfortunately, his story, as you've heard today, is not unique. I have run into a handful of people who say, oh no, the inpatient thing worked well for me. I've run into so many more who says, no, it didn't work at all. In fact, it was really traumatic and awful. So I do want to say that these things are very cost effective. I know this model, this bill comes with a fiscal note, and I get it, you know, guardrails, oh my gosh. But when you factor in that peer-run respite costs literally 1/10 of what your average inpatient hospitalization stay would go for, and that people who go through that model don't often end up going back to a hospital situation, this will more than pay for itself. And it'll be a much more humane and better treatment for a big chunk of the mental health world. And, you know, again, it minimizes costs in the long run. You know, it keeps people out of the hospital. And I think there's a study referenced in my testimony, 70% less likely to return to the hospital, which is huge. And again, these peer-run respites get good results. The peer-run respites report improvements. You've heard some of the testimony. Some of the exit data from AFIA peer respite indicates that 92% of guests reported improvements to their emotional health and 62% of guests reported greater satisfaction with their coping skills. So, you know, simply put, the peer-run respites just really fill a huge gap in our current mental health system. And I think it just is, at this point, you've heard all the testimony, it's really kind of a no-brainer that we really need this additional place for folks to go, which I think is much more effective and much more certainly humane.
Excuse me, Mr. Burr, but your time is up. Thank you.
I was just going to summarize.
Okay, great.
So yeah, just please, you know, pass this bill favorably audit committee, and I appreciate the chair for raising this bill. And just as a quick aside, I did a study of our membership, and 97.6% of them support this bill as well. And with that, I'll end. Thank you, and I'll happy to answer any questions you might have.
Sure. I have a number of questions. I'll start and then we'll circle around. I just wanted to ask you, this bill passes. There's going to be enough of the sites across the state. DEMIS has some funding, which is limited, and people are trying to get funding through DEMIS through RFPs. How do we make it sustainable? What would be the mechanism to make it sustainable financially? Do you foresee models where Medicaid can look at some of these models? Are you aware of models where the hospital systems are saying, you know what, we should actually join this effort because our other things aren't working and there's going to be a continuum of care in some respects? Or are there people paying themselves or foundations? How do you create sustainability and enough of them around in the state?
That's a great question. As I understand it, and really this is probably a question that should have been posed to Sarah Davidow from AFIA, but as I understand it, Massachusetts gets their funding from their, you know, Department of Mental Health on an annual basis. And again, because of the cost savings involved and because a lot of the population that we're talking about is often on Husky and here in the state of Connecticut Medicaid, I anticipate there's going to be enough of a cost savings that it shouldn't be too heavy of a lift to have annual funding provided to our Department of Mental Health and Addiction Services. I don't think the insurance model, I think that creates more problems, honestly,
It's a
than
failed
it
model.
solves.
Yeah. The issue comes down to is that when we are making our budgets, we never see the savings. We see what's going to be the money up front, and that's part of the difficulty in this process that we deal with.
It's hard to predict what the actual savings will be in real dollars and cents. I will grant you.
Yeah. But that's probably another conversation we should have. One is, of course, making sure that we can do something like this, but then the second part is how do we make it sustainable?
Well, it would be interesting to ask the question of the Department of Social Services Commissioner, how much money goes to Medicaid for inpatient psychiatric hospitalization? I imagine it's a big number.
Yeah.
A really big number.
Yeah. Are there models where the hospitals are, because we had birthing centers when we were looking at, it's a different parallel, but we are exploring the existing healthcare systems. Can we create the birthing centers because the birthing centers needed money? It's almost like the inpatient centers are losing money, but they're not even helping the people. And so if they were able to fund some of this, that would actually reduce the emergency room effort, and they would be a part of population health management that would be more effective. So again, creating some of those models, as long as they continue to have the independence of this model, not to have the CEOs of the institutions trying to control things, which is where things can get confusing. So.
Yeah, unfortunately, I'm not an accountant, so this is not one of my stronger areas.
But you are a super dad. You are.
Well, you know, it's funny, when my son was struggling, I was not his favorite person, but we get along fantastically now. He's doing fantastic, and I appreciate that.
And your effort in the last many years, since 2019, I've seen you and more on computer, on Zoom, but because of the COVID. But you're one person who has shown commitment and has helped this entire legislative body learn so much and do so much. So I feel that the state should be indebted to you. Thank you for that.
Well, I appreciate that. NAMI is an organization. One of our 4 pillars of what we do as an organization is legislative advocacy. So I'll put it out there to anyone on this committee. If you have questions related to mental health and mental health systems, we're here as a resource. Please take advantage of us. We have people at the federal level working on the federal level, and they share what's also happening in the various states. We have monthly Zoom calls, and we talk about what everyone's doing in their respective states. So why recreate the wheel? I mean, certainly the peer-run respites. We didn't come out of this out of a blank sheet of paper. I will say that, and Jordan will probably talk about this later during her testimony, we had a lot of talks with places like AFIA and some other organizations so that we came to this with a model that had been proven. We didn't just kind of come up out of our own heads what we thought might work. This is a proven model.
Thank you. Representative D'Amico.
Thank you, Mr. Chair. Thank you, Tom, for coming and testifying. And I have to say that the testimony from you and your predecessors here this afternoon was very compelling. So I think I think we all share that sentiment. So I'm noticing at the very end of the bill, it requires that the Commissioner of Mental Health and Addiction Services has to give us a report identifying any barriers to implementing the program that we're all talking about. So other than money, and I know that's the big nut, obviously, other than money, do you see any barriers? Do you see any philosophical barriers, any objections that might be raised by anyone?
Well, you touched upon it earlier with the person who was on Zoom, and I'm blanking on his name, but you know, again, they went out of their way to make sure that they were perceived as a strong member of their community. And I know from efforts in the past that when I was working strictly with the local NAMI up in Manchester, and one of the local providers wanted to create some supportive housing, they went out of their way before any ground was broken to talk to their local community and let them know, hey, we're going to bring this in here and we want to make sure you know about it. And if you have any concerns, let's have a discussion about it. They had 2 very public events. And, you know, they didn't win everybody over, but they won most of the people over. And it turns out it's a great addition to the community. It's a beautiful facility, and there's no problems. And I don't anticipate there would be a problem with a peer-run respite. But you always want to do that in full daylight, full disclosure. You don't want to try to sneak it in, because the NIMBY crowd will, if you try to sneak it in, will think you're trying to do something underhanded and everything will blow up. So we just have to be very public about it. But yeah, you know, we'll get a little bit of pushback, I'm sure. Again, it's a lot of it is just the perception of the media. You know, people with mental health conditions are violent psychopaths and the streets are going to run with blood, which isn't true. You know, again, that earlier person said, you know, that there's no data that supports that. Well, there's actually a lot of data that disputes it, quite honestly. It's very clear statistically that people with mental health conditions are much more likely to be victims of violence than perpetrators. But again, that's not necessarily what you see in the popular media. So it's understandable that people who haven't studied this stuff might feel otherwise.
Thank you for that. I'm glad I asked the question, and thank you for your answer. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we want to thank you for being here with us today and your testimony.
My pleasure. I appreciate the committee's support.
Next person in person over here is Cindy Prezio. Welcome. Sure. You can turn the button on to, there you go. Welcome.
Just let me get set up here.
Yes, please go ahead.
All right. I want to say hello, Senator Anwar, and possibly goodbye. and Representative McCarthy Vahey, and all members of this committee. We've gotten to know each other, I think, in the People's Halls during session. I'm here. My name is Cindy Prizio, Executive Director of One Standard of Justice. I'm here in strong support of SB 370. Recently, I have become engaged with a collaborative or cooperative of people where mental health is an intersection. And I want to thank Jordan for with Keep the Promise and Kathy Flaherty, who are getting me more and more involved and educated on this. An act concerning peer-run respite centers for persons experiencing a mental health crisis. I've read the bill. I've even highlighted means voluntary, trauma-informed, short-term services, home-like environment, empowering the people with individual freedom, and what it means, socialization. I mean, your point, Senator Anwar, about loneliness. I mean, I certainly work with a group of people that are, half of them are probably shut-ins, that are engaged with the criminal justice or criminal legal system. And they're lonely. They're so lonely. And let's see where I start. Let me start on my story. I want to thank all the speakers who came before me, because it takes a lot and we're vulnerable. And I learned to be vulnerable. So I want to thank the people who went ahead of me and will come after me. I've experienced chronic depression and several mental health crises over the death of my partner, the sudden death, and the arrest of my loved one, the latter having been when I was newly sober mere months. I would have taken advantage of a peer-run respite center, having experienced multiple programs. I believe if I had been in a setting with caring people who have lived experience, I might have opened up a lot sooner. I spent 10 years in treatment. I had a loving, kind, empathetic, social worker, counselor, actually. But I held back, and I've heard that from others today. She did not know my story for a long time. She didn't know that I was broken in two, doubled over in pain, because she thought I was functioning somewhat. I used to go to her 1 hour twice a week and then go home and be a shut-in. So isolation, when we're in that space, we know how to isolate. You know, we could sleep for days. We could avoid people. So, you know, I've been doing advocacy in this building for 9 years now, and it's a hard road to hoe. Without me thinking deeply about this, there are a handful, actually 2 hands of people I've encountered in criminal justice reform that would have benefited from this respite program. Mothers who are hopeless, mothers who are suicidal over their sons or their children's engagement in the criminal law system. Young men who were convicted in their teens and hopeless about where it brought them. You know, I mean, I think I dealt with the youngest man who was 14 at arrest. He decided to go to high school, and at 18, he went to prison. He was the first young man, where the judge apologized to him because he had to receive a mandatory sentence of 10 years. When I met him, he was hopeless. In fact, we had a couple of experiences where when I wasn't around, he called 911. Somebody convinced him to go to Yale New Haven Hospital, the ambulance, the sirens. He didn't need that. And then I get the call the next day saying, you've got to get me out of here.
Ms. Prizio, but your time is up. Thank you.
Can you summarize in like 30 seconds?
I had a little quote here from North Carolina, I think. And this person was a suicide ideation. I think she was a survivor of an attempt. And she talks about we can and we must do better. There's no conversation that starts with shackles and restraints are healing. And I learned in the rooms, I'm a 12-stepper in many programs. I learned in the rooms how to be a peer support. First, I was broken. And then when I had a person sitting next to me crying her eyes out, I knew how to go to that person because I learned it, pick up her hand. And she wasn't experienced with love, and just work it through as two people. So I'm going to ask you to please pass 370.
Thank you so much. Thank you for your testimony and for being here. Seeing no questions or comments, we will go to the next person.
Thank you
Appreciate
so much.
Of
Good night.
course. And next is Kathy Flaherty. Welcome, Kathy. You've been here since this morning and afternoon and evening. Welcome.
Good evening. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project. We provide legal services to DEMAS clients. I'm here to actually testify very briefly on one bill and focus most of my testimony on the peer respite bill. But the people living with mental health conditions should not be discriminated against, full stop. Senate Bill 275, an act prohibiting nursing homes from rejecting a patient solely on the basis that such patient has received mental health services, is a good bill. It should pass. I did note in our testimony that we've observed instances of nursing homes who refused to take people back when they went to an emergency room because of a crisis, didn't need to be admitted, didn't need inpatient psych level of care, but then the nursing home didn't want to take them back. That's just not acceptable. If they need nursing home level of care, they should have access to nursing home level of care. But I want to spend most of my time adding my voice to the chorus of people who are clamoring for the establishment of peer-run respites here in Connecticut. You've heard from colleagues about the profound healing that happens when people are in a safe space, a physical space where they can go, they can safely share, not be forced, not risk restraint, seclusion, or forced treatment. The way the system, the medical model system works, it views us as people who are broken and people who need to be fixed. And the options they offer us for fixing us don't work. I recently had an inpatient hospitalization in the fall, and I kind of forgot how horrible they are. I voluntarily went to the emergency room, spent 2 days in the ER before getting admitted to the psych floor. They take your phone away from you. They take your clothes away from you. They take your dignity away from you. And they expect that to lead to healing. It doesn't. What did they offer me on the unit? Group therapy, which was a little helpful because it's always good interacting with peers, but medication, and they offered ECT, to which I respectfully declined. Peer-run respites recognize our humanity, our interests, and our strengths, and that we already have everything inside of us that we need to heal. We just might need a little help recognizing it, and we can do that with the support of a peer. And instead of hiding the truth regarding those suicidal feelings, because that's really the reality of what the system teaches us. They teach us we cannot be honest with people because we know that people can deprive us of our freedom. And that in order to keep yourself safe from those interventions, you learn to lie. But instead, let's create the space for honest conversations and realize that suicidal feelings are actually pretty common. They come from somewhere. There's a reason for them. They say insanity is doing the same thing over and over again and expecting different results. I think it's far past time that Connecticut tries something different, and it's really time for peer-run respites in Connecticut. Thank you.
Thank you, Kathy, for your testimony. Thank you for sharing your experience, and I'm sorry it was, again, not a good one. So appreciate your testimony and always being standing for people who need help. Seeing no questions or comments, we'll move to the next person on the list.
Thank you.
Next on our list is Harold Grimes. Welcome.
Thank you to the committee for having me. My name is Harold Grimes.
Mr. Grimes, do you want to turn your camera on? You're welcome to do so if you choose to.
Well, I don't know how to do that right now.
No worries.
Anyways, I was diagnosed with mental health issue in 1988. Where I grew up, how I grew up, my life was over. That day I was giving my first medication. I went home and took the whole bottle. Didn't work. And so for 20 some years, I struggled with my mental health, but nobody knew. I had a very good job. I was making well over $100,000 a year, and inside I was dying. In 2010, I had to stop working. I was on disability. And I was in and out of hospitals, in and out of a couple attempts, a lot of ideations. And then in 2015, my last hospitalization, I realized that I wasn't broken. I was a person. I needed help. And I started, I was at the VA. I'm a veteran. I was at the VA, and I started going to groups. I was going to therapy, but the groups did much more for me because they got me. So I became a NAMI facilitator, and I've been doing that for 10 years. I'm a NAMI trainer, state trainer, and I'm also a state certified peer support specialist and one of 188 national peer support specialists. In the state of Connecticut, we're one of only 11 states that don't allow any Medicaid reimbursement for peer support. Last year, the bill died in committee because some other organizations said it wasn't needed because there was grants available. Grants are very hard to get. Where I'm working at now, it's a SAMHSA grant. In 10 years, there's going to be more peer support specialists than clinicians. Where I work hand in hand with the clinicians. And somebody said earlier today, why do they talk to a peer support specialist about things and not clinicians? Because we've been there and done that. We have lived it. We've walked the walk and walked the talk. When I go with my clients drive the bus, and I'm just a passenger and a navigator. They do their own recovery. It's not my recovery, it's theirs. What I've found since I've been here for 2 years, I've been here, peer support specialist is supposed to have 20 clients. Right now I have 74. And I also work with veterans. When we started, we had 4 veterans. We now have 70 veterans. I've talked to every one of them. Peer support is it's the most important thing for people with mental health issues. It's easier to talk to somebody that's been there. It's and I tell every client I see every day, if we have a good session, that the client learns something and I learn something, because I'm in recovery too. In peer respite, it would help me because as a peer support specialist, because they don't have to go to a hospital. They've got some place and they're with people that understand and care. I don't do this job for the pay. I do it because I'm passionate, and I'm passionate. Go ahead.
I'm sorry, Mr. Grimes, but your time is up. Thank
Okay,
you.
I'm sorry.
That's okay. Thank you.
Yep.
Thank you so much, Mr. Grimes, for your testimony. This is very helpful. Thank you. Seeing no comments or questions, we'll move to the next person on our list. The next person is also online, Tunisia Signore, or Signor. If I mispronounced it, I'm sorry. Welcome.
Hi, everyone. Thank you for having me. Hello, members of the Public Health Committee, and thank you for your for giving me the chance to testify today. My name's Tunisia Signor, Signore if you're in Italy, but yeah, Signor is fine here. And I am the Policy Director for She Leads Justice, formerly known as QUELF. We're a statewide nonprofit that uses a justice and equity lens to advocate for under-resourced and marginalized women and girls in Connecticut. We would like to voice our support today for raised bills SB 370 and HB 5424. A peer-run respite center is a voluntary short-term program which provides 24/7 community-based non-clinical mental health crisis support as an alternative to inpatient hospitalizations. 15 other states are already offering these, and for good reason. In a study focused on responses from over 120 clients from peer-run respite in Massachusetts, over 90% of respondents indicated that they would return again. 92% said that they experienced improvements in their mental health, and over 60% stated improvements in their coping skills. Another huge reason peer-run facilities are effective is because they are voluntary. Forced mental health treatment can be extremely harmful and irrelevant from a cultural standpoint. In one meta-analysis, it was reported that people who are discharged from a hospital after a mental health crisis can be up to 100 times more likely to die by suicide. The lack of treatment options for individuals experiencing a mental health crisis can often make the process of seeking help feel punitive, debilitative, and often hopeless. They are cost effective. The average cost for psychiatric hospitalization is over 10 times more expensive to a similar stay at a peer-run respite center. The cost savings is relevant for individuals, insurers, and the state. I have experience working as a clinical case manager in a crisis mental health residential facility, working with individuals who are in the throes of experiencing crises or being discharged from the hospital. I can tell you from a professional experience that clients being able to share their experience with peers and find support from them is essential on the journey to seeking stabilization and recovery from a mental health crisis. I can also say that in the moments where I carefully and thoughtfully decided to self-disclose my own struggles with clients, those were the times that they later told me made a big difference in their journey with us. We'd also like to express our support for HB 5424. This bill would protect healthcare providers who offer medically accurate information and counseling to their patients and provide needed healthcare in line with accepted standards of care for their patients facing pregnancy complications and more. It would do it would offer a lot of different things. I have many different research things in my written testimony, but I will say that as an organization focused on advocating for marginalized and under-resourced women and girls in Connecticut, we're incredibly supportive of this bill. We believe it's crucial for any woman or girl seeking comprehensive sexual and reproductive health care in our state to have access to information and resources regarding their care that's in line with current guidelines for best practices. In Connecticut, women of color are more than twice as likely as white women to give birth in a Catholic hospital. It is fair to assert from this number that these women would need the same facilities to provide them with sexual and reproductive health care in their times of needs. We need to show marginalized populations who are so often deeply affected and excluded by state policies that we can provide such a minimal level of health service and protections.
Excuse me, Ms. Signori, but your time is up. Thank you.
Okay. In the interest of time, I can stop there. There is a lot more information in my written testimony, though, and everything's referenced, just so you guys know.
We appreciate the written testimony. Thank you so much. And seeing no questions or comments, we'll move to the next person on our list. Thank you.
Thank you.
Tanisha Signor. Sean Mastriani, welcome. You're on. Thank you. Go ahead.
Thank you. Thank you, Senator Anwar and distinguished members of the Public Health Committee. My name is Sean Mastriani, and I am the Administrator and COO at Pierce Memorial Baptist Home in Brooklyn, Connecticut. Pierce is a 72-bed nonprofit nursing home that shares a campus with an affiliated independent and assisted living community. I am here today to speak on behalf of myself and on behalf of Leading Age Connecticut in support of Senate Bill 275, an act prohibiting nursing homes from rejecting a patient solely on the basis that such patient received mental health services. Nursing homes are an essential element of the long-term services and support system serving individuals with serious functional impairments who are unable to live independently in the community. A nursing home is highly regulated, and there are state and federal rules that oversee who may be admitted and how their care must be provided. In line with those rules, a nursing home must assess any person seeking admission to ensure the facility can meet the needs of the applicant. While a nursing home may determine that it cannot meet those needs, the nursing home should not refuse an admission based solely on the fact that a potential resident had received mental health services at any time previously. There may be some confusion in the healthcare field regarding the ability of a nursing home to admit a resident who has been diagnosed with serious mental illness. Federal law addresses the screening and assessment of individuals with mental illness who are seeking or receiving nursing home care and mandates a pre-admission screening and annual resident review, better known as PASSAR screening. To identify nursing home applicants and residents with mental illness, this screening is required because nursing homes are prohibited from admitting any individual with a serious mental illness unless it is determined that the nursing home level care is required. In addition, the state public health code provides that a nursing home may only accept someone with a manageable psychiatric condition as determined based on the evaluation of a board certified psychiatrist. As a result, there are limits on the ability of a nursing home to admit individuals with a prior history of mental health treatment. As I stated earlier, the nursing home should not refuse an admission based solely on the fact that a potential resident had received mental health services at any time previously. Recently, the Center for Medicare and Medicaid Services, CMS, updated their policies and intensified their oversight related to behavioral health in nursing homes with a particular focus on addressing unnecessary use of antipsychotic drugs. There is a strong regulatory focus on ensuring that nursing homes are adhering to these rules, a focus that is potentially causing providers to be skittish about admitting patients on these types of medications or with.
Mr. Mastriani, but your time is up. Thank you.
Okay, thank you.
We do have a question from Senator Summers.
Good evening, and thank you for being here. I can't see you anymore. Are you still on? Okay.
I am.
Okay. I wanted to know, we heard from other nursing home facilities today. Can you tell me, in your experience, have you seen this kind of subliminal discrimination with patients that, they might be an Alzheimer's patient that is on an antipsychotic drug for whatever reason, having them not be accepted into long-term care? Have you seen that or experienced that in your experience? I don't know if you've only worked where you are now.
Thank you, Senator Summers. So I would say I can only speak secondhand at the facility that I oversee in Brooklyn. It's not something, that we see there at that facility, but secondhand, and most recently this August, we heard about it from a family member that had tried to get their loved one in a facility close to them and probably applied at 15 different nursing homes, and they were rejected because it's solely based because of their past history. And, the family had to drive over an hour to actually visit their loved one that was at our facility. So secondhand, we hear about it, but not at my facility. That does not happen.
Great. Now, thank you. I have also had some direct conversations with the Institute of Living, which is one of the largest psychiatric hospitals that we have here in the state of Connecticut, run by Hartford Healthcare. And they're social workers who say when they can, let's say, no longer move somebody along with the care, and that person really needs long-term care, they are having an extraordinarily difficult time placing the patient in long-term care. They're not violent. They're not, maybe they're not eating or something like that, but they are, they're not needing one-on-one kind of care, but they just are rejected immediately as soon as the electronic request goes out. And I'm wondering if you could reiterate what you said previously about how CMS is coming down on or being more stringent on who's taking what kinds of medications in long-term care, because I really think that's impacting the ability for certain people to be discharged from either a psych ward or the Institute of Living into long-term care when they really need it. And I had been contacted by somebody in my district who's actually a priest who came back to Connecticut to take care of his mother and father. His father had cancer, and was also experiencing dementia and was prescribed Haldol. And because of that, he was unable to get him to be transferred to a long-term care facility. The hospital then said to the mother, who was 88, I'm sorry, if your husband stays here, that we're not making progress, so he needs to go somewhere. He was discharged home where she couldn't care for him and back into the ER in this vicious cycle. So have you heard or have you experienced when a patient is on they're considered antipsychotic drugs, that's the classification they're in, but they may be used off-label for other reasons. Is that a reason that long-term care is hesitant to accept some of these patients?
So I would say that there are some facilities that I've heard about out there that are skittish about taking people on certain medications, and they're sort of flags when they get that referral, and it may be an instant no. That's pretty much from secondhand. I know that for our facility, and I can really only speak for our facility, the hospital tells us we take too much time reviewing our referrals because we want to make sure that that person is a fit, and we want to make sure we fully understand their medical history. And we always make a call out to the family to better understand it from their perspective, not just the hospital's perspective. And also we have to look at our staffing levels. We may take somebody that may be a little bit more difficult, but do we have the staff so that they can receive the appropriate care? And it's our duty to look at that as well when admitting somebody. So I think passing, this legislation might make people take a little bit more time looking at those referrals coming in and really seeing, can they accept that person and better understanding that person.
My last question, and I don't mean to put you on the spot. I didn't ask this before, but I probably should have. If what I have shared continues and we're putting or the system, I'll say, is putting families in a situation where if you have a loved one who may be on an antipsychotic medicine or some kind of psychiatric medication, who's older and needs long-term care, but are not accepted into long-term care, what are the options for a family other than taking the patient home in maybe a situation that's not safe? I just see this as sort of a vicious cycle going back into the ER and then back to trying to get discharged to long-term care. Do you have any ideas on what a solution could be other than passing this legislation to have people take another look at if we are really discriminating, even if it's subliminal, against patients?
I think, if, this legislation gets passed, I think that Leading Age Connecticut could help support educating the nursing homes so that we can improve upon the admission of residents that are mentioned in this legislation. I don't really have a good answer for where they go if they don't make it into the nursing home. Nursing homes, actually, we get a referral, we look at a referral. The hospitals don't have that option. They show up on their doorstep. And so I think typically a lot of times these people end up going in and out of the hospital from home, and the hospitals are burdened by them. But most of them, the person that we had that came in August came from the Institute of Living and had no behaviors while they were there at all. So, we really shouldn't be discriminating based upon past history.
Thank you so much for your testimony.
Thank you so much for your testimony. Thank you, Senator Summers. Seeing no other questions, we'll move to the next person on our list, which is Quinn Jennedy. Welcome. Thank you for being here and thank you for waiting for us today. Can you turn, perfect.
Good evening, Senator Anwar and distinguished members of the Public Health Committee. My name is Quinn Genetti, and I'm a certified peer support specialist here in the state of Connecticut who supports young adults across the state. And I'm also the administrative coordinator for the Keep the Promise Coalition, a grassroots of people with lived experience and of mental distress, of trauma, and of psychiatric system involvement. Keep the Promise builds community power as a means of promoting human rights, self-determination, and racial and social justice in Connecticut's mental health system. I'm here to testify in support of SB 370, like so many of my peers today. As a trans non-binary person, I know that my community often avoids seeking mental health care out of the fear of carceral consequences that often follow sharing mental health struggles, including thoughts of suicide. As a facilitator for alternatives to suicide groups that are often attended by trans folks, I know how deeply impactful it is to have a safe and non-judgmental place to share your experiences. I have seen so many folks come to these groups and take what seems like their first full breath all day, all week, all month. Without wider availability of peer support and without peer respites, many of us, as we enter another year of unprecedented anti-trans bills being introduced around the country and at the national level, really struggle. With the constant messaging that we are neither wanted nor accepted, it is not surprising that over 80% of trans adults in the US have thought about suicide and 42% have attempted suicide. In moments of distress, crisis, and life-altering circumstances, where are we supposed to go? To the hospital, where we know we will be misgendered, dead-named, potentially denied access to gender-affirming care, isolated from our chosen families, surrounded by people who may be transphobic as they are strangers to us, stripped of our personal gender-affirming clothing and cell phones. This is not an environment where healing happens for my community. The hospital is not a birthplace of possibility and of hope for many who have experienced a mental health crisis. We need community care and we need peer respites. It took just a single visit with a family member who was hospitalized for mental health to know that I never wanted to become a patient in that environment, but a depressive episode my junior year of undergrad landed me in that situation. I spent 2 days inpatient, after which I was told to follow up with a prescriber and sent on my way with no support in place. My mental health didn't get better after this, it got worse. But I knew that I couldn't go back to that environment. The staff didn't understand what I was experiencing, nor were they curious about the circumstances that had led to my being there. They reacted from a place of fear and immediately moved into exertion of control. My experience is not unique. It has happened to many people, many of them multiple times. In those moments of despair and depression, I deserve the right to consent, to choice, to connection to my community. This is why we need peer respites. Recovering and healing do not happen in a vacuum. They do not happen alone. They don't happen in an empty hospital room. Recovery and healing happen in the context of connection, community, consent and choice, and mutual reciprocal relationships. Your constituents deserve access to peer respites. Please support SB 370 to create 8 peer-run respites here in the state of Connecticut, plus a technical assistance center to support implementation and sustainability. It is time. Thank you for the opportunity to testify today.
Thank you, Quinn, for a very powerful testimony, and thank you for your passion. And you're so sorry about your experience, but you're a very strong individual, and you've shown strength to share your passion and also the experience, which is difficult to do.
Thank you, Senator. I appreciate it.
So we're listening to you, we hear you, and Connecticut is home for everyone. Thank you. Moving on to the next person is Vicky Sigworth. Remotely, I believe. Welcome.
Thank you. I appreciate this opportunity to speak. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. I am here both as a family member and as a recovery support specialist to advocate for the passage of Senate Bill 370 for peer-run respites. which have not only been shown to be more effective in promoting stable health, as you've heard, but are also vastly more cost-effective. My 42-year-old son is a clear example. He was released last July after 7.5 years inpatient hospitalization at Connecticut Mental Health Center in New Haven. It was a mostly horrific time for all of us. This week, he shared with me how he wished he'd been able to go to a peer-run respite to process with other peers the stress happening at the time of his hospitalization. Instead, his stress got so much worse in the hospital, leading to 7.5 years of inpatience. Those 7.5 years were not only repeatedly traumatizing to us all, but they cost taxpayers over $1,400 a day, or around $3.8 million. The cost of his inpatient hospital stay alone is almost enough to fund 4 peer respites, serving many more people. What a waste. While our son was still in the hospital, I was trained as a recovery support specialist and began volunteering in that capacity with NAMI Home City. Soon our home began taking people in as a support space in the absence of any peer respites in Connecticut. One person stayed with us off and on for a few days or weeks at a time as she was going through the stress of tragically losing her partner, followed by several other ongoing crises. She is now doing much better. However, she tells me that without being able to stay with us, where she could get 24/7 support as needed, on most of those occasions, she would have been hospitalized and surely even more traumatized. At one point, she tried calling 988, a disaster. Though she was initially expressing suicidality, 988 simply called the police and 2 clinically trained social workers to come to her house. By that time, she was no longer suicidal, but neither she nor her parents nor I could convince the police she was now safe. They were insisting to take her to the ED, which would have wasted more state funds. Instead, she managed to sneak out the back of her house and drive safely to my place, and we were able to talk through her acute stressors. She was back at work the next day. This is an example of why, for peer-run respites, we are also advocating the safer suicidality protocol found in the Alternative to Suicide groups. When police, as in her case, put their own fears above the patient's expressed needs, unnecessary ED visits occur. Thankfully, she had our family to go to. Otherwise, a hospital visit may have well cost her her job, then her housing, and thus ever-increasing hopelessness. Thank you so much for taking seriously the opportunity peer-run respites offer to provide more effective mental health support at a fraction of the cost of traditional interventions for the many who would benefit from it. We plead with you to lower the cost and the unnecessary suffering which was incurred by our family and friends and countless others for the lack of a peer-run respite center in Connecticut. Thank you.
Thank you so much for your testimony and sharing your experience. It's very profound. Appreciate your, and I'm glad things are better at this point.
Thank you.
Seeing no questions or comments from anyone, we'll move to the next person on our list, which is Sarah Vasogi. Welcome. And you've been here since this morning. You were actually the first person after me who had come in today. So thank you so much for being here and being here all day to make sure that the people in the state of Connecticut get blood. Welcome.
Good evening now, and thank you for the opportunity to offer my testimony in support of SB 368, an act concerning source plasma donation centers. I'm Dr. Sarah Vasogi, the Vice President of Medical Affairs and Medical Director of the Connecticut and Rhode Island Blood Centers. Currently, Rhode Island Blood Center imports more than 62,000 life-saving blood products to the state of Connecticut every year. Before I discuss my thoughts on the proposed amendment, I wish to provide some of my background in this area. My career in healthcare began as a trauma nurse and a captain in the United States Air Force as a medical crew director for a tactical aeromedical evacuation team, evacuating wounded soldiers from combat zones. In addition to having been a nurse for 20 years, I'm also a physician with 8 years of apheresis experience, including as the apheresis medical director at Columbia University teaching apheresis. I worked during the peak of the COVID pandemic as both an RN and an MD, and I saw some of the worst blood shortages of my career. We had to make heartbreaking decisions regarding who received blood versus who had to wait. And these decisions are ones I did not think I would have to make again as a civilian physician outside of wartime. Blood shortages are now a day-to-day issue. I believe it is critical to the health and safety of our population that we consider the impact of any restrictions on the collection of blood that are not evidence-based and deviate from that of most other states in the Union. Specifically, I come in support of the proposed amendment to not require that a physician or physician substitute be on site in volunteer donor collection centers, and agree that a trained technician should be able to collect blood and blood components via apheresis in healthy donors. The pandemic exposed the fragility of our nation's blood supply. The average donor will only travel 10 minutes or 10 miles to donate. Giving blood must be convenient, and blood centers must be in the community. We need to recognize that the care of a healthy volunteer donor is entirely different than that of a sick hospital patient. With properly trained collection staff caring for healthy donors, blood centers across the country safely collect and distribute more than 4 million apheresis products every year. Recognizing the significant difference in apheresis of a healthy person will help Connecticut sustain and replenish our own blood supply. Thank you for your time.
Thank you. I am just so impressed. So you're Air Force nurse. Thank you for your service. And then you went on and became a physician.
Yes.
Where's the book? You're going to write that book, or you're going to learn about your experiences of apheresis and explain. But I'm seeing your testimony, the written testimony. You've been very gracious to actually even mark the bill changes and details. We are seeing a trend for the people who are exploring the third attempt to get this bill right. I think everybody's pretty much saying the same thing. You want the nurse requirement to go away and the physician training to be more something that is much more easily accessible, if you will. Is that the simple version of it?
Yes, what I tell my students when they're in my class for 6 months is that you have to treat the patient, not the monitor. So, you know, I think that we went the other way with this in that, you know, apheresis in a hospital is a procedure performed by a nurse. Absolutely. A sick patient needs the specialty care that only nurses can give them, and they're a precious resource. And so by blanketly applying that to healthy people walking on the street, I could be out of shape shoveling my driveway and be at just as much risk of ending up in the hospital as a healthy person donating blood, but I don't make nurses follow around people with shovels who are out of shape. So I think we need to have practical solutions for making sure that we don't run out of blood, because the supply chains are now disrupted. There are climate catastrophes. It's important to be able to sustain our own hospitals in the event of a disaster and not rely on bringing in so much blood from other states.
And can you just repeat the number for the amount of blood that is coming to the state of Connecticut, but the good people in Rhode Island are giving to us, our citizens?
62,000 units a year just from Rhode Island Blood Center.
So these are 60.
And that's only from the New York Blood Center enterprises. That's not counting what you're getting from Red Cross and other suppliers.
And part of that is because of our laws are reducing the ability to collect blood locally, and then we need to address those issues, and then hopefully we will not be dependent as much from the people through Rhode Island, and I'm sure the people need that over there too.
Absolutely. I spend a lot of time in Connecticut. My sister and my niece are in Connecticut, and I believe the people of Connecticut are very giving and will give us their blood if we let them.
Absolutely, we will, and that's why we're going to change this law. You came from Rhode Island today?
I came from Brooklyn today.
Brooklyn. Okay. We can't thank you enough. You're spending your entire day with us, and I just will, there is okay. And I'll just mention that you probably in Brooklyn area will be the most knowledgeable person on peer respite. So you're going to become an advocate for us on their area.
It was very interesting.
So good. So we have Representative D'Amico.
Thank you, Mr. Chair, and I promise I will be brief. So thank you, Doctor, for coming in and staying here all day long. if you were here earlier, much earlier this morning, and I think that you were, you heard me admit to some confusion about this bill. And I am happy to say that after some private conversations subsequent to our earlier discussion, I am much less confused. So I just wanted to offer that. However, I just wanted to ask you a quick question. I noticed in the testimony offered by the Red Cross that no other state requires nurses to perform apheresis, blood product collection, or be present on site at blood collection facilities. No other state. Would you care to guess why that would be?
I would qualify that, and I would say no other state that does not routinely grant waivers or enforces those requirements. So I believe there was some talk about a couple of other states that had some older laws on the books that they were working on changing, but that they routinely grant waivers, which was not the case here. The reason I would comment medically on why it's not necessary is that when you collect from a healthy person, they don't have the electrolyte imbalances, the blood pressure changes, any of the same risks that a healthy donor who's been screened, who's been vetted, who's had their hemoglobin checked ahead of time, with a little finger prick. It's a whole different situation, a whole different risk level. And our nurses are highly skilled and valuable rare resources, and we need to use them where they're necessary with patients who need their care and who need more of them, rather than having them do things that any well-trained technician could do.
Thank you. And if I can, Mr. Chair, just real quickly.
Please do.
Could you make a distinction so I will understand this a little better between regular blood collection and apheresis blood product collection?
Right. So in the American Society for Apheresis, we refer to it as therapeutic apheresis, is when somebody is sick and requires apheresis to remove something from their blood or replace something. For example, a lot of my patients are sickle cell patients. So we're actually removing their blood, sickle blood, and replacing it with healthy donated blood, versus donor apheresis, where we're collecting blood just from a healthy person so that we can collect more of it. So if you just let blood flow into a bag, you can only collect so much. But if you're returning your own blood to you and we only need the red cells, we can get more without any of the same physiologic changes. So the distinction between the healthy and the sick patient, but also the procedure itself, is very different, in that when you're dealing with a patient, say with sickle cell disease, who is in crisis or has had a stroke, or somebody rejecting an organ transplant, they can become critically ill very quickly. They do need nurses. When you're talking about a healthy person walking off the street who's going to go home, I tell blood donors, you get some free cookies. It's about 500 calories when you donate blood to replace that blood in your body. And that's about the extent of the strain on your body.
I think I understand it better. Thank you very much. Thank you.
Thank you. And Dr. Vasogi, after listening to you, I think we'll put an amendment that the person who's going to oversee this should both be a nurse and a doctor.
I haven't met any others, actually.
I know that's the problem. Senator Summers.
I just have to ask at this hour, did you like being a nurse better than a doctor, or like doctor being a nurse?
It was very different. There are days when I really miss nursing. And sometimes during the pandemic, I was both at the same time. Sometimes I was the only one in the room. I will always love nursing. It was my first love. You never have your first love again, right? But I also love being a physician. I'm very fortunate in that I've had two great loves, plus my husband and my dog in my life.
Thank you so much for being here. You're very impressive. I'd love to talk to you after. I worked with Dr. Edward Shambrom, who actually owned the New York Blood Center at one time. He was he developed the solvent detergent method on how you scrub blood.
Oh,
so that's how I
wow.
spent my career.
That's amazing.
I'll talk to you after. That'd be great.
Yeah.
Thank you so much. Seeing no other comments or conversations, and we'll wait for your book. Thank you for your testimony.
Thank you.
Thank you. All right, moving on. Next is finally, Jordan Fairchild. The power behind a lot of movements. Welcome. Thank you for being with us all day.
Thank you.
And the last many months, Fair. Welcome.
Thank you so much for having us today, and I'm just so grateful that we could get to this point with Peer Respites. Good evening, Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Jordan Fairchild. I am the Executive Director of Keep the Promise Coalition, which is a grassroots coalition of advocates with lived experience of mental distress, life-altering trauma, and psychiatric system involvement. Keep the Promise Coalition builds community power for human rights, self-determination, and racial and social justice in Connecticut's mental health system. I also, not too long ago in November, co-facilitated the probably largest gathering and conference of peer-run respite staff and leadership, I think in history. And I'm here today to testify in support of SB 370, an act concerning peer-run respite centers for persons experiencing a mental health crisis. You have already heard from a lot of my peers about the types of rights removals that can happen when people enter the inpatient system or engage with the more carceral elements of our crisis response system, both in Connecticut and frankly around the country. I have a lot more details about that in my testimony. I'm going to use a little bit of today, at least, to focus on my own lived experience with this, as I think it really lends some necessary perspective to some of the intersectional concerns about how our mental health crisis system treats trans people specifically. And my experience is really that of avoiding services. In my position at Keep the Promise Coalition, I am constantly hearing from our members and our community members who have experienced psychiatric hospitalizations or crisis system responses that were involuntary. Even when people enter the hospital voluntarily, it can be a very distressing experience. There are rights removals that can still happen in that event. And so knowing this, when I came out as a trans woman, in November of 2022, and I lost most of my pillars of social support that I had previously had, I was really at a loss for what to do. There were multiple instances over the past couple of years where I was feeling suicidal. I really felt I had nowhere else to turn to, and I was just lost. And here I am, the executive director of a nonprofit organization that deals specifically with mental health. I would be the person who knows where to turn about this. And, you know, I knew about peer support. I have turned to peer support, and that has been the most important aspect of, you know, my own survival, frankly, over the past couple of years. But in those moments of crisis, I really didn't feel that I could have anywhere to go. Aside from hearing from our community members about, you know, just the regular rights violations and those sorts of experiences that can happen while inpatient, I am constantly hearing from my trans community members about the experiences that they've had while inpatient. Things that are not limited to just experiences of misgendering, dead naming, harassments, not only by staff, but by other patients, having your clothes taken away from you, having your hormone replacement therapy taken away from you. I even heard about one instance where an individual was inpatient and was forced to attend a support group with another patient who had been harassing them on the basis of their gender.
Excuse me, Ms. Fairchild, but your time is over. Thank you.
Thank you.
Actually, I was going to ask you to finish your testimony.
Yeah. This is not an option for me. So knowing all about the way that this system works, I in the moments of crisis that I have found myself in over the past couple of years, I unfortunately turned to a coping strategy that I have learned works for me, which is self-injury. I began cutting myself last summer, and I'm not going to say it's ideal, but I also know that it's the only thing that quiets what's going on in my head in those moments of crisis and moments of wanting to die. I truly, firmly believe that having a peer respite available to me, especially to have a trans peer respite by and for my peers, by other people who have lived my experience, would have made all the difference in those moments. And, you know, I think the other point I wanted to make is that there's been a lot of talk today about trauma-informed care. And I actually think that today is probably the first time in this legislature that I've heard trauma-informed care discussed in a way that I feel is actually trauma-informed. And I'll explain what I mean by that. Trauma-informed, you cannot have trauma-informed care if the care is not informed. We have heard from so many people, Dr. Nathan was talking about it earlier, about the number of people who are simply afraid to communicate what they're going through to their provider out of fear that a more carceral response will happen. They'll be locked up against their will. And this drives a lot of people away from the mental health system. It means people don't want to talk about what they're experiencing. But through peer support groups and through things like the alternative to suicide approach, which is really, I think, a foundational element of peer respite, people have the ability to open up about that. And not only that, the thing that peers really excel at is being curious in those moments, asking people what they're experiencing, what has led to them experiencing, wanting to die. I think that especially for trans people, as with other marginalized communities, as with a lot of people, really anyone who has experienced any sort of trauma, wanting to die is not always an unreasonable thought. When you consider the social determinants that lead to people dying by suicide, self-injuring, sometimes those options actually appear to be extremely reasonable. And so having someone who can sit there with you, understand what that experience is like, and know where you're coming from makes all the difference in order to be able to say, yes, I hear you, I see you, and this is my relationship to thoughts of suicide. I wonder if when you are experiencing this, maybe there's something in your life that needed to die instead of you. So I really strongly urge you to pass SB 370. I urge you to pass it not only with the 5 regular peer respite centers, but with the 3 affinity-based peer respite centers for BIPOC, trans folks, and Spanish speakers, as well as the technical assistance program to make sure that these programs are implemented sustainably and can continue to serve Connecticut residents once they're actually established. Totally open to any questions. Thank you so much for the opportunity to
Jordan,
testify
thank
today.
you so much. I just wanted to also just say, can you repeat the last part about the breakdown that you were talking about? 5 plus 3?
Yes. So as in the bill, basically what it would establish is 5 peer respite centers, which are evenly distributed around the state. The Department of Mental Health and Addiction Services divides the state into 5 mental health regions. So there would be 1 accessible in each of those regions. And then in regions 2 or 4, the affinity-based programs for Black and Indigenous people of color, trans, queer questioning, intersex, or people of other marginalized gender identities, and Spanish speakers would be centrally located in the central regions of the state.
And you're talking also about translation services in each one of them.
I think translation services, having that available is really important. I also think that, you know, part of the reason for the Spanish language respite is because there are so few, you know, peer mental health services, let alone few peer services that are specifically Spanish speaking. And I hear this from members of our community all the time, talking about how they were not able to access services that were not only in their language, but also culturally relevant. You know, I want to point out that not every culture views mental health in terms of illness and incurable brain disease. A lot of cultures view mental health in terms of either the result of trauma or oppression, view it in terms of resilience and struggle. Experiences like voice hearing might also be viewed as a religious experience or some sort of spiritual experience by a lot of cultures. And so having folks who actually share cultural identity can really help to guide us through those types of experiences.
Jordan, I've known you for a few years. You're incredible. And you're a beautiful force of nature. And I think a lot of people who came here today were because of your commitment, your passion, and your true belief that this is going to be what's going to happen. And I think you have infected a lot of us with that same belief. So I want to thank you for that.
Thank you so much, Senator.
And Representative Cook has a question or comment.
Thank you, Mr. Chairman. And Jordan, I have a comment. You know, I've been in this building for a lot of years, and I've sat on this committee for a very long time. And I've had children that have struggled with many things, and still do in some cases. But you said something a few minutes ago that might have been the most powerful thing that I've ever heard in this building. And when you said maybe there's something in your life that needs to die, but you don't need to die. I think that everyone out there that is struggling with something that they hate about their life, and hate's not a word that I use often, but I think that that's what often gets us there. In the world of social media and bullying and all of the other things that happens in this world, that statement there could save so many lives. And so for all of the other great things that you said, I just hope you know that that one is the one that I think that you need to do something with.
Thank you.
Thank you. Thank you for your honesty, your transparency, and the dedication to the cause, and sharing your story, because that's not an easy situation.
Yeah. Thank you so much, Representative Cook. I can't take complete credit for that statement. That was actually wisdom shared with me by, I believe it was Caroline Mazel Carlton, who does a lot of work with the Hearing Voices Network and works for Wildflower Alliance, who you've heard from a few folks today from Wildflower. That was a really life-changing statement when she shared that with me. So just want to send some appreciation to her as well.
Thank you, Mr. Chairman.
Thank you. Seeing no questions.
Thank you all. I also have a fact sheet attached to my written testimony. Thanks.
Thank you, Jordan, so much. We are all grateful for the time that you have given and the care, and as Rep. Cook said, your courage today. I believe next we have Amy Dalheim, who's joining us.
Yes, good evening.
Welcome.
Thank you. So I'm Amy Dalheim, Senior Manager of Regulatory Affairs for BioLife Plasma Services. And BioLife is an industry-leading plasma donation network, and we're part of Takeda Pharmaceuticals. So there is a growing demand for plasma-derived therapies to treat patients with rare, chronic, and complex diseases. And these therapies can only be produced by human plasma from healthy individuals that are donated at plasma donation centers. So on behalf of BioLife, I'm expressing support for Senate Bill 368, an act concerning source plasma donation centers. And we thank you for your work and efforts with this bill. This bill will help plasma collection by aligning the requirements for plasma centers with those in federal law. And through this alignment, a person who's a licensed physician would qualify as the director of a plasma center and would not be required to have a previous 1 year of plasma or blood bank experience. So we currently, as of today, operate 222 plasma centers across 37 states, all while ensuring donor and plasma safety. And we also have a 50-year history in providing relevant training to all of our physicians. This bill would remove the experience requirement and help ensure a sustainable plasma supply as the demand for plasma grows. So again, we thank you for your efforts and thank you for the opportunity to provide this testimony today.
Thank you very much for waiting with us today and for being here, also for the work that you do in the field. And I would just ask, earlier, just a few moments ago, we heard from Dr. Vasugi testifying about the bill and the amendment that we are proposing. I would just like to confirm that you are all aligned with the comments that she made as well. If you were.
Yes, we are as well. Thank you.
Thank you for that. Seeing no other questions, thank you for being here with us. Next is Christopher Manza. Is Christopher here with us? Okay. If not, then Todd Felge. And forgive me, you'll correct me if I got your last name wrong. Welcome.
Thank you. First of all, I'm here to support the peer respite bill. My name is Todd Felge. I'm a facilitator for Alt2Sue. I'm also a grief educator and a facilitate a survivor of suicide loss group. My partner, Larry, died by suicide in 2016. So I've been involved on both sides of prevention and postvention in the suicide world. Peer-to-peer and lived experience is so important and critical in this journey. We say we need to find our tribe of people. This bill is so vital and so important, a place where people can talk and be witnessed in their struggles through this journey. In both groups that I facilitate, we hear stories about the mental health industry and cause more issues than help. There are places for both of these. When we sit with someone who's been in hospitalization and they tell us about their horrible experience and they go back, say they never would, and we understand. They just want to be heard, witnessed from a peer. They are not broken. They don't need to be fixed. They need to be heard without fear of authorities being called. When we're talking with a peer, they see the weight. Sometimes we talk to a peer, we see the weight of the world come off their shoulders. And that's an incredible thing for both of us. There's a time and place for every model, and please make sure this one is passed. Thank you.
Thank you so much for sharing that. And you were efficient with your time after waiting all this time.
I feel like the last person on the baseball team being picked.
Well, I want to say your words were very powerful, and thank you for sharing. I'm so sorry that you lost your partner, and it's amazing that you're here with us and doing the work that you're doing, given the pain that you have faced. So thank you for that very much. And I couldn't agree with you more. We all want to be heard. And as I listen to the stories today, we want to be who we are and met and accepted for who we are, even when those are difficult and dark times. And you're one of the people who does that, as has Jordan and so many others before. So thank you very much for being with us. Next, we have Ribera Sharon.
I'm here. Thank you. I hope you can hear me. Good evening, Senator Anwar, representing McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Rivera. I work at Universal Healthcare Foundation of Connecticut. Our mission is to accelerate the movement for health justice for everybody because health is a human right. Our work is part of the broader struggle for racial, social, and economic justice. I'm here to testify in support of SB 370, Peer and Respite Centers. In traditional mental health services, conversations about suicide and self-injury often result in forced treatment. This causes many people to avoid services altogether. And I'm here to say that we need real and intentional alternatives, and that more people than ever are desperate to find resources geared toward dignity, equity, and reviving some sense of personal power and control. And peer and respite is one proven alternative that can be life-changing and sometimes life-saving. When people call suicide hotline like 988 or tell a provider about their thoughts of suicide or self-injury, they expect human connection and a person to talk to. Instead, they're often met with police at their door, forced hospitalizations, and forced medication. This is extremely traumatic, and people have talked about their experiences during their testimonies, and because many people do not seek help in the first place. People are statistically about 100 times more likely than average to die by suicide following discharge from hospitalization, for mental health crisis. Inpatient services are often not culturally relevant. Many have experienced racism, transphobia, and other forms of discrimination in the mental health system.
We're losing you here a little bit. You're
There
breaking up.
are
Rivera,
few mental health services offered. I'm just going to go off camera and then maybe you can hear me. If I
oh, there you go.
it might be better.
We can hear you.
So I'm going to go off, maybe that's going to help it a little better. Okay, good. Inpatient services are not culturally relevant. May experience racism, transphobia, and other forms of discrimination in the mental health system. These are mental health.
Rivera, unfortunately, you're breaking.
There are very few mental health services offered in Spanish, and each of these has created this.
Rivera, I'm not sure if you can hear us, but you're in and out a bit. I don't know if you are.
I can actually.
Go ahead.
I can hear you, so I don't know. Or I can just like summarize and then I'll put the rest in written testimony. Yes, so I'll just summarize, and the bottom line is I was testifying to support for SB 370 in support of the Peer and Respite Center. So I just will provide written testimony instead, and my apologies that my service is not the greatest today.
Thank you very much. No, we all have had those technical issues, and we understand your support for 370 and talking about the importance of that sense of control and human connection and a number of other items. If you are able to submit written testimony, that would be wonderful. Thank you for being with us today.
Thank you.
Next, we have Rachel Sear. Rachel, if you can unmute yourself.
There we go. Hi, my name is Rachel Sear. I was a head server in a restaurant for 10 years. I have a son, and I was engaged until I was illegally and involuntarily institutionalized by the Hospital of Central Connecticut, after which I was deemed unfit for employment. So I created a model of peer support online, which has been self-sustainable through brand sponsorship, video views, and monetization of healthy coping mechanisms. My mother's pastor had admitted me for a nap, accusing me of sleep deprivation when I went to his church to ask for prayer. I agreed only to prove that I had been sleeping and my request for prayer was valid. When I awoke, I was in isolation. They stole my phone, stole my clothes, and went through my backpack. First they lied, then they stole. Then they expected me to think that this was for my well-being. I watched nurses on their phones mock a patient begging to call her family from behind the glass. They went through my backpack. I was accused of drug addiction and denied my ADHD medication. They criticized how I had stored my medication, even though my blood tests confirmed that I was not addicted. It was very difficult to maintain composure without my medication. But when I saw the doctor, he told me women are misdiagnosed with ADHD. They don't actually have it. They are all bipolar. And believing in God is a symptom of bipolar disorder, which it is in the DSM-9. It can be counted as religious delusion. Sorry, it's been about 2 years since this has happened. It's still a little bit triggering. I was asked questions I couldn't answer. They would wake me up while I was sleeping to ask if I had been sleeping. They would come in while I was eating to ask if I had been eating. They would ask me what time it was when there was no clock in the room. They would ask me what day it was when the only thing I could do in there was sleep. I was not a risk of injury to myself or others. It was noted on paper since day one that I was not a risk of injury to myself or others, yet I was still kept there for almost 7 days. I think it was actually 7 days in total. They would not let me leave because they anticipated manic depression, which would go along with bipolar. It's been 2 years since I got out. I still haven't been depressed. I had to get a lawyer and a judge to be just discharged under the conditions that I would not be employed or work for anyone or leave my house for the next month. This left me with severe anxiety, nightmares about my autonomy, as well as no job, no fiance, and now I'm currently unhoused. I remain optimistic and I still believe in God. What did surprise me is that I had expected a mental health facility to heal and care for patients. There was no therapy, no one-on-one counseling, no background check to even see if I was telling the truth. They didn't call my family. They didn't call my employers. They just believed that my mother's pastor, who I hadn't seen since I was like 13. There was no education of healthy coping mechanisms. Give me 1 second. It's not a good time right now. Give me a second. There was just drugs. They just offered drugs. I was offered antipsychotics that can cause vivid hallucinations and behavioral changes if taken by someone who is not experiencing psychosis. The patients were threatened with 15 more days for non-compliance. This is not a good time. However, coping mechanisms have unlimited earned income potential. I've been volunteering both online and in the community. I built over 12,000 people in my online community by teaching ways to monetize healthy coping mechanisms. I'm funded by brand partnerships that provide supplies that I donate to the community, like art supplies, music supplies. There's somebody who wanted to start a small business with cleaning because she enjoyed cleaning and that was her outlet. So I got her a bunch of mops and buckets and a partnership with Grove collaboration.
Excuse
company.
me, Ms. Spear, but
Yes.
your time is up. Thank you.
Okay. No problem.
Thank you.
I just wanted to say that the funding is sustainable if you're creative.
Thank you. Thank you for sharing your experience and story with us and your support for other options. We appreciate you waiting with us today and thank you. Next we have Bill Spear.
Thank you. Good evening, honorable chairs, ranking members, and distinguished members of the Public Health Committee. I'm Bill Spear with the Plasma Protein Therapeutics Association. PPTA supports Senate Bill 368. We appreciate all the work and attention this committee has given to the issue of source plasma donation centers in the last 3 years. In 2022, there were more than 1,000 source plasma donation centers in the United States, yet none in Connecticut. 3 regulatory barriers accounted for the lack of centers in the state. In 2023, this committee passed a law directing DPH to create a unique regulations for source plasma donation centers. The proposed regulations removed 2 of the 3 barriers. However, the 3rd barrier regarding the center director's qualifications was amended slightly, but still requires a year of blood banking experience. In addition to this barrier, the proposed regulations added 4 more. We hadn't talked about any of these 4 in the 3 years we've been talking about this. So now there are 5 barriers to entry that all exceed federal requirements. We're surprised by this since the direction from Public Act 2258 passed by this committee was to align state regulations with federal requirements for source plasma donation while maintaining a high level of donor safety.
the federal requirements do maintain a high level of donor safety. They govern 1,200 source plasma donation centers. The FDA regularly reviews these regulations to ensure donor safety. No one cares more about donor safety than the FDA. New York recently did a similar review and has aligned their laws completely with federal law. In addition, we provided DPH with evidence of high level of donor safety under the federal regulations. The federal law requires the center director to be a physician, but does not require a year of blood banking experience. It's unnecessary to have a year of blood banking experience for a center director. The only activity taking place at a source plasma donation center is the donation of plasma through plasmapheresis. That plasma is used for further manufacturing of medicines that is used by patients with rare chronic conditions, and also albumin used in emergency rooms every day. The donors who donate at a source plasma donation center are screened to make sure they're healthy that day to donate, similar to what the testimony was earlier for blood donors. Blood banks perform significantly different activities than what we do. So therefore, having us use the blood banking experience for what source plasma donation centers do doesn't make sense and is not required under the federal law. We support Senate Bill 368 because it would remove the 5 barriers found in the current regulatory proposals. Removing these barriers would lead to centers opening in Connecticut to the benefit of patients. I thank you for your time and happy to answer any questions.
Thank you. I have one question. I know Senator Anwar has a question as well, or maybe a couple. So for the 4th grade level, which is what I often suggest here in this building, you just said blood donation it's different than what you are doing. And if you could just give us a few sentences about the differences if you're someone walking in to one versus the other.
Yeah, and I actually have here information that's been provided. Blood banking is highly specialized background, may be necessary in a hospital blood bank setting where blood and blood products are being ordered and administered to patients, where therapeutic apheresis is taking place for patients with serious medical conditions, and where the collection and processing of stem cells for blood and bone marrow transplantation is taking place. We don't do any of that. We don't even do the apheresis that was mentioned earlier for the red blood cells. We do something similar with the plasmapheresis, but it's different activities. There's patient care that could go on at a hospital blood bank. We don't do that. All we have are healthy donors.
Thank you, Senator Anwar.
Thank you so much. Thank you for staying with us the whole day. And between the 3 times you have been here, we've spent about a week together.
Yeah.
I just wanted to ask you, you've looked at the testimony for American Red Cross and the amendments that they have suggested.
Yeah.
Would those amendments work for you?
Certainly. Just, as a point of clarification, their concern is similar to ours, but the ability to have the physician substitute off-site, a little difference in the way that they are regulated at the federal level than we are, is we always have a physician substitute on site. So whomever is the physician substitute would always be on site. But what they're asking for is certainly in line with what we would like.
Okay, because there are many of the companies that are there, and we're trying to make sure that we do right for everyone and find the language that's going to be accurate from everyone's perspective. So you're saying that if we were to look at the amendment that they have recommended, that would be able to address your issues too.
Yeah, I took a look at their amendment. I looked at their testimony earlier.
Okay.
It's fine with us.
Okay, thank you so much. Thank you, Madam Chair.
Squeaky mic? Yes, it's the squeaky mic. Thank you, Senator Anwar, for that. Appreciate it. Representative D'Amico.
Thank you for your indulgence, Madam Chair. So, Mr. Spear, I have to ask this question. I should probably be asking this of the Commissioner of the Department of Public Health, but since you're in the chair, I'm going to ask you. So I don't want to belabor this, but I have to ask. This bill deals with source plasma donation centers. I'm looking at testimony from the Department of Public Health, the commissioner specifically.
Yep.
And she says, when drafting the proposed regulation and policies and procedures for source plasma donation centers, the department started with the federal requirements for this type of facility. As drafted, This bill, SB 368, would require the department to revert our proposed regulations to just the federal requirements, sacrificing key components that would guarantee quality of care for the donors. I can't get beyond that. What could you help me out here? I still can't understand how we can look at that and
Yeah, I mean,
not factor it into our debate here.
right. And I understand that. You know, characterizing the federal regulations as the bare minimum, I think is disrespectful to the people of the FDA. They have responsibility for all 1,200 centers in the US. They ensure the donor safety at all 1,200 centers. But they also understand that any regulation that doesn't enhance donor safety limits the ability to collect source plasma, which, as you've heard from earlier testimony, the clinical need continues to increase. So in 2019, when there was a shortage of a plasma-derived product called immune globulin, you know, putting in these types of regulations don't allow us to collect here in Connecticut. And really, if we were collecting in Connecticut, perhaps some of those patients who couldn't get the product they needed would have received the product, similar to like we're hearing today about the application of these higher regulations to the blood banks. It sounds like you all have a blood shortage here in Connecticut, which it sounds like these regulations, which I suggest to you are unnecessary for donor safety, because what they would like to do is follow the federal regulations that govern blood donation safety, which are the same regulations. They're in the same section of this federal code. It's 21 CFR 630 and 21 640 CFR 640. I'm happy to share all this information with the committee. So I would suggest to you that the DPH is mistaken. One of the things that they suggest, you know, I have here the 5 new barriers. We've talked about the blood banking experience. One is that they would like to limit delegation of duties to the physician substitute. Well, as you heard earlier from the blood banks, and it's similar to source plasma donation centers, some of the duties are delegated to the physician substitute, but some are delegated to qualified, trained individuals, okay? They're unlicensed, but they're qualified and they're trained. If the delegation of duty is only to the physician substitute, you can't operate a source plasma donation center. And I would suggest you couldn't operate a blood bank either. They have a thing where we have to follow regulations governing recovered plasma. We've pointed this out to them over the years that that section of federal regulation doesn't apply to us. Yet when we saw the informal, basically they worked with us and let us see the regulations before they came out as proposal, and we pointed that out to them. They left it in. It doesn't apply to source plasma donation centers. I would suggest then that that kind of shows that their characterization of the federal standards that maintain safety for source plasma donation centers all over this country is mistaken. If you're going to characterize it as the bare minimum, I would characterize it as the gold standard.
And thus my confusion. But okay, I'm going to leave it alone. I'm going to leave it at that. Thank you, sir. Thank you, Madam Chair.
Thank you all.
Thank you, Representative D'Amico. Are there other questions? Yeah. Okay, thank you. And thank you, Mr. Spear, for staying with us. All right, next we have Charlotte Dufay. Or please correct me if I'm wrong.
Duffy, Dufay, whatever you'd like. Good evening, distinguished members of the public health community. My name is Charlotte Duffy. I am a registered voter in the town of Mansfield and also a researcher at Harvard University. My academic training is in history and philosophy, and my work concerns ethical questions in medicine and related empirical research in the social sciences. I thank you for the opportunity to share my thoughts, which are entirely my own, on Bill 5424. I kindly submit to you that the bill under consideration provides a misleading definition of healthcare entities, which obscures the contradictory reasoning in the bill that I think should prevent its passage. On page 1, lines 9 to 11, the bill states that, quote, healthcare entity means an entity that supervises, controls, grants privileges to, directs the practice of, or directly or indirectly restricts the practice of a healthcare provider, end quote. This definition circularly describes an entity as an entity, whereas on line 12, a non-circular description of a healthcare provider as, quote, a person, end quote, is offered. But why this asymmetry? Is it not also persons who comprise the healthcare entity, persons who perform the supervising, controlling, privilege granting, or practice direction and restriction of healthcare providers that make healthcare entities what the bill says they are? Indeed, it is these people who make possible any encounter between patients and the providers in question, and so they are integral to every clinical encounter that cannot exist without them. In light of this fact, one cannot but worry about how the definitional asymmetry functions in the logic of the bill. We are told on lines 56 and 81 that employers, healthcare entities, quote, discriminate, end quote, against the providers they employ by imposing these restrictions on what can be deemed medically appropriate in their institution. But this restriction is precisely what the bill itself performs by seeking to limit how healthcare employers counsel and direct those in their charge regarding the services to which the bill pertains. So I ask you, if the logic of the bill is correct, if these employers ought not restrict the actions of their employees, shouldn't it follow that the state of Connecticut also ought not restrict the actions of healthcare employers? In which case, shouldn't the bill be retracted? Surely it is a graver matter for the state to limit an entire industry than it is for some employers to restrict those who freely consent to work for them under said restrictions. Because the term healthcare entity fails to capture the real people who comprise it, the bill obscures its own failure to meet the very demands it seeks to place on others. And for this reason, I ask those politicians who agree with the principles motivating this bill to consider whether approving it would violate their own principles by restricting as means for freedom, by using restriction as means for freedom from restriction. There is no burden greater than violating one's own integrity, which I believe this bill demands of those who support it and of those who it would affect in healthcare entities. Thank you very much.
Thank you very much, Ms. Duffy, and forgive my mispronunciation of your name. Thank you for your testimony here today and for spending the time and waiting to be with us. We appreciate it. Seeing no questions, we are going to go next to Daniel Fisher. Oh, no, we're not. Actually, we're going to go to Marcella Kurowski.
Members of the committee, I'm Marcella Kurowski. Thank you for the opportunity to speak today. I would like to express my compassion for the people that have testified today. And I do oppose HB 5424 because this bill is legislative creep. I do not believe that it is the role of government to compromise the religious conscience of Catholic hospitals. After this hearing, I hope that it is clear that miscarriage management is different than abortion. And since Planned Parenthood provides a variety of health care, then perhaps the doctors that which provide as such would be better suited for that facility. Thank you, and I hope to see some of you at the March for Life next week.
Thank you, Ms. Kurowski, for your brevity. We are grateful for that, and we're very grateful for you spending the time waiting to testify today at this late hour.
Thank you, Representative.
Seeing and hearing no questions, now we will go to Mr. Daniel Fisher.
Can you hear me?
There you are. Hello, Mr. Fisher. Please proceed.
Okay, thank you very much. I have submitted my written testimony, and I'm going to go off script a little bit because most of these aspects have been covered very well already. Thank you, Senator Anwar, Representative McCarthy Vahey. And I'm here to support, very vigorously support SB 370. It was 50 years ago that I was hospitalized on 3 occasions and given a diagnosis of schizophrenia. I wish there had been peer-run respites at that time, but there were none. And my experience, unfortunately, has been echoed by other people, my inpatient experience. I joke that the only good thing that came out of it was that I became determined during one of my stays while I was locked in seclusion and thought I would be hospitalized for years. I determined to become a psychiatrist and to really create alternatives such as peer-run respites. And that really has been my mission. I founded the National Empowerment Center. I am a board certified psychiatrist and helped start the first Peer Run Respite in Massachusetts. I'm a little choked up still by many of the stories and many of the memories that this still brings up 50 years later. It's hard to really encapsulate how traumatic it is to be locked in a psychiatric hospital with no rights. You lose all rights and no appeal except to a psychiatrist. I thought that by becoming a psychiatrist, I could change the system, but it takes much more than that. It takes many of these testimonies that we've heard. The running of peers is essential. Because when you've been through a similar experience, a lived experience we call it, then you know what it feels like to have no voice. You know what it feels like to be treated very impersonally. And what people need the most is a human heart. Another heart is the most important thing that a person can have to recover and to heal. And in this regard, we've started something called emotional CPR so that anybody can help anybody through a crisis. And it's not only good for people that are going to Peer Run Respite, it's good day to day. It's good for parents. It's good for teachers, because these are human matters. And we need to humanize not only our mental health system, but our society at large. I'll close by just a few pointers about why this makes so much sense and ask you all, why has it taken so long for Connecticut to have a Peer Run Respite? There are 50 across the country, but there are barriers everywhere. When you consider they reduce the load on the emergency rooms, they reduce the trauma of involuntary treatment, they provide a continuity of care because you can still see your psychiatrist or your healthcare worker. They're less expensive, we've heard that. They're 1/10 the expense, and they're very effective. And most important, you get hope. When you go to a Peer Run Respite, you're met by people who've been through a similar experience. They
Excuse
can
me,
give you
Mr.
hope.
Fisher, but your time is over. Thank you.
Okay, I know it's late. Thank you all very much for the time.
Dr.
Any
Fisher,
questions? I'm glad to entertain any questions that you might have.
thank you for your time. Is that the Golden Gate Bridge behind you?
Yes, but I live right next door in Massachusetts.
I only reference that because it's a symbol of hope for many through QPR training. I cannot remember the name of the gentleman who survived.
Oh yes, Kevin Hines. His story is yeah. If one person, he said, if one person had stopped to talk to him as he was climbing the fence at the Golden Gate Bridge, he wouldn't have jumped. Yeah.
Yes, exactly.
Sometimes
So as
one
I listen
person.
to you testifying today and see that image, I think about the hope that you and so many others have given as we talk about this. I don't have an answer to your question as to why we have waited so long, but we're here today and onward and forward we go. Thank you so much for taking the time.
You're very welcome.
today.
And I'm glad to help in any way in the future from my experience on both sides.
Thank you so much. Next,
You're
we
very
have
welcome.
Richard Brannigan. Welcome, Mr. Brannigan.
Good afternoon, Senator Anwar and Representative McCarthy Vahey and the members of the Public Health Committee. Thank you for hanging in there. I'm sorry I couldn't stay there in person this afternoon, but we are here to talk about an amendment to the source plasma bill, which is Raise Bill 368. The need has been well documented, I think, throughout the conversation all afternoon, particularly appreciate the support of our colleagues in the blood collection business. It does take a village to help save lives. I'm proud of our humanitarian organization and the American Red Cross in putting lives first. And so I really want to cut to the chase. You've been with us all afternoon. We appreciate your support and your leadership and that of the Department of Public Health in aligning our regulations here in Connecticut with the national standards and with the American Association of Blood Banks. We collect in the American Red Cross about 95% of the blood in Connecticut, including over 110,000 units of blood a year, 15,000 plus units of platelets. So if you calculate the number of arm sticks that implies it's 30,000 different arms are put into play to help save lives. Those are all being done by professionals. Our donors are heroes to us, as they are to the patients who receive those life-saving donations. That demand for blood is constant. The demand for blood products is constant. Couple of other observations to put forth based on what I've heard today, that waivers do not make good public policy, especially in the regulatory world. We have an overburdened Department of Public Health, as other state agencies are, and good, solid regulations are something worth working towards, and we're well on our way to doing that. We have the support of our AFSCME union partners who are helping deliver those services each and every day. As has been said, no other state enforces the RN and APRN at blood collection facility requirements. There's a significant impact to the health system of the state of Connecticut if for some reason we stop collecting blood or our partners stop collecting blood in any substantial quantities. The irony is that we would be importing blood from other areas of the country that follow the federal standards and not our state standards. And the Red Cross, last but not least, has been collecting blood successfully and safely in the state of Connecticut since the mid-40s, since World War II. Our efforts have impacted millions of lives in the process and saved countless of thousands of lives along the way, including my own. I encourage an amendment to HB 368, which allows us to continue our life-saving work and to allow us to continue to work with the Department of Public Health to achieve the language that we need. Happy to answer any questions you have.
Thank you, Mr. Brannigan. You and Mr. Weber are bookends in many respects today as we have this conversation. We appreciate you staying here with us and allowing us to have this conversation. And I'd like to say to you publicly on the record that we are going to fix this, and we are going to assure that we are not impacting the ability for us to collect blood and have these life-saving means for the people of Connecticut, as you referenced, even in your own situation. Senator Anwar.
Thank you. From the squeaky mic, just wanted to say thank you for being here. You were here this morning and afternoon with us, and I appreciate you being here and continuing the conversation. With respect to the plan, like we have spoken to you before, this needs to be fixed, and we will address this. Both Representative Kristen McCarthy-Vahey, myself, and the ranking members are on board to do the right thing to help you. Thank you.
We appreciate that, Senator. Thank you so much, everyone.
Whoops, thank you very much. Seeing and hearing no other questions, have a wonderful evening. Next, we have Dana Smith.
Hello, good evening, Senator Anwar, Representative McCaffrey, and distinguished members of the Public Health Committee. My name is Pastor Dana Smith, and I'm co-founder, executive director of New Life 2, and a person with lived experience. New Life 2 is Connecticut's first Black faith-based peer-led recovery community organization and recovery center. We provide peer mental health trainings on addiction, harm reduction, systematic oppression, anti-oppression, and we cover to all our neighborhoods. So there's a script here, right? And I don't want to read no script. What I'm here for is to support SB 370 because it's definitely needed. I grew up in New Haven. I grew up in the projects. And right now, what New Life does as a recovery organization, reentry center, we serve neighborhoods. We serve Black and brown neighborhoods. Now, this is not a Black and brown thing I'm talking about, but what I am trying to get across is that a lot of things aren't reaching the neighborhoods, and a peer-run respite will be great because for so long, Black and brown have not been treated fairly in any hospital. It's a known fact. You can look at statistics, whatever. But being around peers being in a house with peers, people with lived experience that's been there, that's been in the darkness and found a way out, or still in the darkness, but learn how to live comfortably, or not comfortably, but learn how to live in that darkness and feel their way around, would be beneficial to our neighborhoods for the simple fact that we are the first ones that everybody want to give medication to, but we're the first ones everybody want to overlook. Being around peers, that's why we open our center in the middle of New Britain, because people come in there and they feel the love, they feel the support. And sometimes it ain't about just giving people something. It's just a place where people could come and settle down. Like, life shakes everybody up and you need to go home and just relax. You want to be with your dog, you want to be with your kids. Well, a peer respite and certain people in certain neighborhoods will be that going home to their dog, cat for that 5 to 7 days. It'll be where I could get rest. It could be where I'm not stigmatized. It could be where people are not looking at me and say, "Oh, you back again." It could be where I could just go to my room and relax if I want to relax, and not say 5 o'clock meds, 3 o'clock meds, 4 o'clock meds. It's a place where I could be treated like a person, because the people that's running that peer run respite, they are people and they are me and I am them, and they understand that. They're not following me around. Do you need anything? You want anything? Are you a danger to yourself or others? I just want to relax. I just want to chill. I just want to get my thoughts together. I just want what everybody else wants. We want to be seen as people. We want to relax in a place, in an atmosphere that's conducive for us to relax in.
Excuse me, Mr. Smith, but your time is up. Thank you.
Thank you.
Pastor Smith, thank you so much for your words, your work, and your wisdom. I appreciate you pointing out those inequities that occur and the importance of being able to meet people where they are. Thank you for taking your time to be here with us today.
Thank you for giving me the opportunity.
Thank you. Next, we have David Reynolds, who's here with us in person. Welcome, Mr. Reynolds.
Evening, Chairwoman and Chairman and ranking members of the committee and members of the Public Health Committee. It's a late hour and we're probably all tired. So what I'm going to do is I submitted a written testimony, and my name is David Reynolds, Deacon David Reynolds. I'm from the Connecticut Catholic Public Affairs Office. Our office represents the Catholic bishops in Connecticut. As I said, I submitted a written testimony, but I'm going to deviate from that. You can all read the written testimony. I want to address some of the things I've heard today during testimony on legislation for 5424. I want to make it very clear to this committee that the Catholic Affairs Conference opposes legislation, Bill 5454, which it views as a blatant attack on Catholic healthcare and religious freedom in our state. The bill appeared as references during the testimony today. It made it look like the bill is a bill of general application. In other words, it's not really aimed at the Catholic hospitals, but the reality is that it is. It's not a bill of general application. What other healthcare entities in the state have official bans on service related to abortion services or even gender identity services? The Catholic hospitals. It's called the ethical and religious directives for Catholic healthcare services. This debate is not unique to Connecticut. This debate is going on across the country, and it's led by abortion advocates. The goal is to break down the barrier that Catholic hospitals have against such services. This bill is a backdoor approach to that. Instead of taking on the church and the Catholic institutions, it goes to give the employees some latitude by saying, you know what, you don't have to listen to what your upper management says. If you are feeling your heart, what you're doing is the correct thing, then just do it. What other employer does that with their employees? This is very unique that if you work for a medical institution or a major corporation, and your corporations or institutions have standards, you're held to those standards. Usually you sign a commitment to those standards. The same thing with employees of Catholic Healthcare. The ERDs direct that they sign a commitment to the policies of with those standards. So it's no different, but this bill kind of ignores it and says, in this situation, these Catholic healthcare institutions, their providers and doctors don't have to listen to them because those doctors know everything. They have a higher standard than their own employers. So we have to watch out for that this bill kind of goes against the whole structure, hierarchical structure of management, policy setting, goal setting for corporations. Yes, people may not like the standard that we have about not providing abortion services. Okay, we have a standard for it. It's been around for decades. It's not new. But there are also, especially in Connecticut, are other places to receive those services. There also, I want to make clarified that the standards of healthcare that Catholic institutions follow just don't have to do with abortions. They dictate, and if you read them, that the top portion has the theological part, the other portion has the directives. They enforce the standard of care for all patients. They do prohibit certain practices, but overall, most of them have to do with the standard of care that the patients will receive in those facilities. I think if all of you read them, you'd say, yeah, I agree with that. That's a good stand. Those are good standards.
Excuse me, Mr. Reynolds, but your time is up. Thank you.
Wrap up, please.
Sure.
I would just like to wrap up, first of all, also by saying that that the ERDs, I want to clarify statements made, the standards do not issue gag orders. If you read the document, there are no gag orders against providers talking about items to their patients. They cannot participate in the services or make referrals, because under Catholic teaching, making a referral for an abortion under its ethical and moral teachings is an illicit cooperation with an evil. That's kind of a churchy statement, but that's what it is. So I want to make sure that the members of this committee understand there is no gag order in the Catholic directives. Doctors can talk, if a pregnant woman comes in, that doctor's free to say, hey, here's your options. You know, you could keep the baby, put it up for adoption, you could have an abortion. They're free to say that. Okay, what they're not free to do is saying, well, I can refer you to, you know, this other facility, or we can do this or that. They can't do that. They would have to say, but we don't provide abortions. You'll have to connect up with another facility. So this whole thing that doctors don't talk to doctors, I think, is very far. It's going to happen, could, but it's not within the Catholic directives. Thank you.
Thank you, Mr. Reynolds. Seeing and hearing no
Yeah.
questions. Oh, Rep. Zupkis.
Thank you, Madam Chair. I'll be quick. Thank you for coming today. I tend to agree with you that I think it is targeted to Catholic hospitals. My question to you is, how many hospitals are in the state?
General or Catholic hospitals?
How many hospitals total are in our state?
I haven't counted them lately. But
Okay.
Groups. So you have Catholics, you have Trinity Healthcare, which is St. Francis, Johnson Memorial, and
I believe it's about 35 or 40, somewhere around there. And how many Catholic hospitals out of all of those?
I'm going to say probably maybe 5. if that
Yeah,
much.
or 4. Yes. Okay. Yeah, that's okay. Thank you. I just wanted to make the point that there are a lot of hospitals, and I believe wherever there is a Catholic hospital, there is also another hospital right there. So thank you for coming and testifying. I appreciate it. Thank you, Madam Chair.
Thank you, Representative Zupkis. Representative Carpino.
Thank you, ma'am. I just was hoping that you could clarify something, because I've heard different things, and I appreciate you clearing up. In the event a woman shows up and is experiencing a medical emergency, will the Catholic hospital permit the termination to take place?
That's a tough question, because what type of medical emergency, there's very rarely, at least in my understanding, very rarely a cause that a baby child has to be aborted to save the life of a mother. So that would be up to the doctors. They would probably have an ethical conference to resolve the issue. It wouldn't be a one doctor decision. I know there's some comments that made that, they don't, they treat ectopic pregnancies as abortions. That's not true. Their ectopic pregnancies are not abortions. So the directives have no restrictions on those. There's 4 procedures for taking care of that situation, and the Catholic hospitals are free to do that.
No, and I appreciate that. So as a Catholic woman, this is important to me. I don't think it's a difficult question. And if you don't have the answer, Deacon, I appreciate that and would love to see something in writing from either the Catholic Church or one of the Catholic hospitals. But I really want to understand if a physician, so not a legislator like
Right.
myself, who's a lawyer and not a doctor or a medical provider, but if a physician determines that a woman is experiencing a medical emergency and it is in her best interest to terminate that pregnancy, I would like to get something in writing so that I am clear and that there is no misinformation so that I can understand what the outcome in that hospital would be.
I'll get you that response, but I could just give a general answer in terms of procedures that should be followed in that situation. Is every emergency is different. Anybody in healthcare knows that. Every person is different. So they would have to evaluate the situation, evaluate, is the baby causing the problem? Is the, unborn child causing a problem? Is the mother going to die if we don't have an abortion? All these issues come up. The general standard is in Catholic healthcare is try to save both.
And I appreciate that, but in a medical emergency, I would hope that the patient is being addressed long before an ethical conference is convened.
Well,
Thank you,
I
sir.
think too, the
I have no more
patient.
questions, ma'am.
Thank you. Thank you,
sorry.
Representative Carpino. Representative Cook.
Thank you, Madam Chairman, and thanks to my good colleague. Now you made me say something. So David, so I want to just kind of continue that conversation just for a minute. So recognizing that you're not a doctor and that you're here on behalf of the organization and not on behalf of a medical professional. So I take that. But you had said that to what Representative Carpino was saying was that if there was a medical emergency, the doctors would have to have a conference. You did originally say
I
that.
did say that, and that was really, they have conferences for, I would say, non-emergency, but it depends on the situation. One doctor may consult with another doctor or go higher up.
So
But
if I entered into fill in the blank Catholic hospital and it was in theory a life or death situation, does the doctors in a Catholic hospital have the right by contract to make that immediate decision without consultation of anybody else?
I'd have to, that question is beyond, I don't want to say beyond pay grade, but that's a question that I think the doctors would have to decide what to do. Again, the standard is to try to save both the unborn child and the mother. And then see if that's possible. It comes into ethics in terms of that an abortion or termination of an unborn child, if it's not the main priority, could actually occur. So there's ethical standards. Okay, we have to talk when a church opposes abortion, it's opposing it because it's the taking of an unborn child who's not in distress. But if the goal of saving the mother's life, the husband says, save my wife's life, or the woman may say, save my baby's life. So there's all kinds of situations that go on and calls that have to be made. As long as the intention is not to you didn't come to the hospital to have your baby terminated. Okay, you didn't do that. So there are all different set of standards applies to that situation.
And I understand.
And I think if I get direction, I could, I will try to get some written documents like Representative Carpino.
I do think that it's extremely important because I think that I think that a doctor, any medical professional, regardless of facility that they are in, takes an oath to ensure the immediate care, especially in an emergency room, trauma centers and the like, that you are taking care of what that immediate crisis is at that time. And we entrust within their training, regardless of facility, that they are making the right decision at the time.
Right.
And so I would be curious to see if there is a directive that they have to pause on that decision to get approval for what could in theory cost both lives.
Right.
And if that's what we're looking at, short of gag orders and all of that other stuff, if that's what we're looking at, I think that we have to have a different conversation about what medical care looks like in the various facilities in the state of Connecticut.
Well, I have to make one last comment on the question is that based on what I have read, is that situation is an extremely rare one. It's not the common one. That it's not a common experience that a woman's life has to be saved and will die if they don't abort the baby. So
And I'm not a doctor,
yeah,
and
and
I
I'm
would
not either.
never want to have to make that decision.
Right.
And so I would hope that it is first and foremost the doctor's choice.
Right.
Because that's what we train them to do.
I could tell you by fact, there's nothing in the ethical EDRs, they call them for short, EDRs, that says, addresses that issue, that says, okay, if the woman shows up, she's pregnant, who goes first? Do we abort the baby? Say it's more of a guidelines that the institutions would apply to the situation.
So I think some further information is.
Yeah,
going to
I will
be needed.
get some too.
Thank you.
Thank you, Representative Cook. Representative Berger Javallo.
Thank you so much, Madam Chair. I just, I feel like I'm a little bit more confused than I was before some of the other questions started to come up. So thank you all. So I would just like to try and understand if, it sounds to me that if you're not clear on this, that I'm very concerned that doctors would not be clear on whether or not they can refer, if we're talking about an emergency situation, and an emergency is an of the moment situation that would require a termination of a pregnancy in order to save the life of a mother. If we're in that position here, but they are bound not to recommend a specific space that she can go or would even have to be moved. I mean, is that what you're telling me? Because from what I understand about all of the hospital access throughout the state, not everybody does just have a choice, nor does every pregnant person understand walking into the space whether or not this emergency situation would prioritize that person's life over the life of the compromised unborn child. So I'm just not really clear that you're that clear, and I mean that with absolutely no offense, even though that sounded horribly offensive. I'm just not sure that you're clear, so I don't know that you're speaking.
Well, I think
authority on
Representative,
this.
the questions are addressing something that is extremely rare in the medical community, that kind of situation would come up. And the hospitals would have procedures in place to deal with that. And the ethical directives that the church follows would leave that up to the doctors in that situation. Obviously, don't run out, try to save both lives. But in some of those situations, the mothers have said, and I know the one happened last year, let me go, save my baby. So on those situations become so personal. I think anybody there's some people here in the medical community that know no situation is the same. And so the patient may want a different level of care. And the hospital has to take that, but it's an emergency situation, a life or death situation. Hospital isn't going to transfer somebody out in that situation. And the directives don't tell them to do that.
I appreciate you answering a very indirect question. I just am concerned because your use of the word obviously, when it seems that maybe none of this is particularly obvious, is what's kind of confusing me. So I appreciate you answering. Thank you, Madam Chair.
Thank you, Representative. Representative Denning to be followed by Senator Summers. Rep Denning, please unmute yourself.
Thank you, Madam Chairman. I'm sorry for the confusion. Sir, I appreciate your time and your testimony, and I'm very sensitive. I was raised Catholic. I understand the teachings of the Catholic Church, and I'm also in the healthcare industry, or was until I retired. And I understand that for the most part, these situations do not occur. But my question that I asked somebody else earlier in the day was, as medicine progresses, we're going to come up with more and more different procedures that the Catholic Church may decide are not in the interest of their faith. And is there a list now currently of procedures that you do not do at Catholic hospitals that employees are asked to sign?
Yes, there is. There are listed in the ERD several procedures that have to do with reproductive health care, sterilization, obviously abortion, and IVF, and several other things that don't occur, but they're not emergency type situations. So the patients have, you know, like especially in Connecticut, have tons of places to make a selection for those services. Also, what's interesting, because it's mentioned in the bill, is gender affirming care. Right now that the DREs are being updated, and I don't know if they'll be finalized in terms of how to treat transgender patients when they show up, or how to give treatment to them. Obviously, the church has strong teachings on that. I'm sure the standards will reflect those teachings. But that does make me think, as we're talking about the care, this bill mentions gender affirming care. Gender affirming care is only one approach to treating gendered people, or people that are having gender dysphoria information. So gender
ask-
affirming care is
Excuse
one
me, Mr.
approach.
Reynolds, if I may, I just asked that people not call out in the room. Thank you. Please proceed.
Because this representative asked me about restrictions, so I'm just clarifying that one of those restrictions is being evaluated. How do we treat this area of concern, this health area? The way the bill's written, if an healthcare institution says, okay, we don't support fully gender affirming care, we support more mental health issues up front. And this is not just a made up comparison. Europe is moving rapidly in this direction away, especially for minors, moving rapidly away from what we call gender affirming care. But so this kind of limits in a way, and I would say visit that language, because do you really want an institution to say, hey, look, we're going to support this type of issue when it comes to gender dysphoria issues or conflicts, but you can only do, you know, this says there's a conflict between what's in the medical reality and what this bill is doing. It's taken a process of curing somebody and say, you have to basically offer this. What if a secular hospital said, hey, look, we no longer enforce, our policies now aren't fully gender affirming care, would be termed gender affirming care. We would rather begin to focus more like Europe and start looking at more mental health care. Then they could be in trouble with it, you know.
So that leads to my next question, sir, which is, does the hospital, Catholic hospitals or any hospital, post the patients and types of procedures that they do not do available for the patients who may come through the emergency room and or electively, so that they have a clear understanding of what cannot be done at that hospital?
I do not believe any hospital does that.
So if you don't expect people to know what you do and do not do, why is there anything wrong with somebody who's actually, they've signed a consent for their care, being able to make them aware of what they may find at another facility, even if they can't do it there?
You mean in terms of like if they sign for care for an abortion at a Catholic hospital?
No, more like they come in, they find out they're pregnant, and the doctor says, you're 15 weeks along. The abdominal pain that you had is not your appendicitis. It's you are pregnant and you are bleeding a little bit. And we are going to have to figure out what we're going to do, whether we take you for obstetric evaluation. And at that point, the patient may say, well, I'm not sure I want to have a baby. What are my other options? Why would you not make it possible for them to say, we don't do abortions here, but you could have that done at another facility?
They're not restricted from saying that, is what I'm saying.
I was told they were, because that's what this bill allows. Is all it does is allow them to say, you can't have it here, but these are the other options that you can have, and refer them to someone else. And as I understand it, that's the document that you are asking all of your employees.
There's a lot of gaslighting going on about what, and I hate to use that term. People repeat things good enough, but that's just not the way it operates. If you're looking at an institution, just take a Catholic institution that hires hundreds of medical providers. Do we believe there's a camera in each room monitoring exactly what that healthcare worker says? No, but they can be held accountable if they're found in violation of the standards. They can't participate physically in a procedure. Okay, they can't do abortions. They can't do sterilizations. They're not allowed to refer for those because in their Catholic moral teaching, it's a cooperation with something that's called an illicit evil. So, but they could surely say, look, you got an option. You know, you're pregnant, you know, keep the baby, put it up for adoption, or, you know, you get an abortion. And that's it. And I think we're kind of downplaying the intelligence of women sometimes when we think all these women come in and they're ignorant and they don't know what their options are when they're pregnant, but they should be reminded of them. So but that's the issue. The thing that someone says, oh, you could only have, if you're pregnant, well, you could keep the baby or, just basically keep the baby or something.
Yeah.
That's not what happens. That's not what
I understand what you're saying. I just
Thank
feel
you.
that this bill doesn't offer anything other than for the opportunity of the healthcare provider to say that to a patient without repercussion of an employer's retribution. And but I appreciate your question and your time. And back to you, Madam Chair. Thank you.
Thank you, Representative. And I thank you for asking questions. And I think we have a couple more people, Senator, to be followed by Representative D'Amico.
And I know
And
it's,
then Representative Reddington.
I know it's late, so I'll try to be quick. There's been a lot of conversation back and forth, so I'm going to try to summarize what I've heard today. And I think it's really important that you do get us in writing what you promised. I'd like to see the directive that you talked about that they sign with the procedures that they are allowed to do or not do. And what I'm hearing, this bill really just, its intention is to maybe dispel what you're saying is happening versus what the perception is. It has been some people's perception that in a Catholic hospital, if you go in and you are pregnant or miscarrying, that the doctor is prevented from even saying that you can have an abortion. Like that is not allowed. But what you're saying is in your Catholic hospitals, if I come in and I'm pregnant, and it's a surprise, so to speak, your doctors can say, Heather, you can have the baby, you can have an abortion. We don't do them here, or you can give your child up for adoption. Is that correct?
That's correct.
What I can't do, and I can do that as a clinician in a Catholic hospital without fear of reprisal from my management. But what I cannot do is say, you can have an abortion and you can go to the Planned Parenthood around the corner and they can help you. Is that correct?
That would correct.
Okay.
Or just make a phone call.
Or
and try
make
to
a
get-
phone call for
yeah.
you. I can't make a referral. So that's a distinction. So this bill, the way it's written, is really trying to protect something that is already available at a Catholic hospital by the fact that you can say you can have an abortion. You just can't make the referral without repercussion. The other thing that was asked was an emergency. So if somebody comes in, it is my understanding that if somebody comes in and they have an ectopic pregnancy, they are miscarrying, the life of the mother is at risk, it is the doctor's duty to care for that patient. Now, the patient may say, put the child ahead of me, but if they don't, it is the doctor's requirement under medical law and oath to take care of that patient. And if a termination, which a Catholic hospitals calls a DNC, they don't call it a termination, would have to be performed. That should be able to be performed without consultation because it is an emergency situation without repercussion from a higher board of a Catholic hospital. Could you confirm that to us in writing
And
when
that's
you
what I'm gonna
respond? But
res-
that's the
respond.
way I understand it in a Catholic hospital. So I think there's been a lot of back and forth. So I think if you can get us that in writing so we can, read it and digest it, that would really be helpful for all of us. And it would maybe help alleviate some of the fears or the concerns that we have.
That's fine, Senator.
Thank you very much.
Thank you, Senator Summers. Representative D'Amico, the squeaky mic.
No, yeah, very good.
That was from Rep Parker I'm calling about.
That was from me,
No,
actually.
we needed a little levity, but we appreciate you, Representative D'Amico. Please
Thank you.
proceed.
Thank you. So just to save us a lot of time, I'm going to not ask any questions. I think that Senator Summers asked basically the questions that I was going to ask. I would like some clarity on this. And Deacon Reynolds, if you could provide that clarity in writing in response to Senator Summers' questions, that would satisfy
I'll get
me.
a copy to all members
So-
of the committee.
All right, thank you very much. Thank you, Madam Chair.
Thank you, Representative D'Amico, and with much love and respect to you, I will say. Thank you, Mr. Reynolds, for your testimony today. I think the lack of clarity in this conversation points to the desire for medical providers to have the clear ability without limits to provide evidence-based care and access to information. I think that, you know, we have to be careful about using words like gaslighting when questions are being asked. I know this is such a difficult topic and a difficult conversation for many people. I don't think that, bless you, bless you. When we talk about distinctions without a difference, the idea of presenting just options versus helping someone in need with a referral and actually what we call in suicide prevention, the warm handoff, is a big difference. And I don't think that anyone here was intending or wanting to insult any woman's intelligence or any pregnant person's intelligence. I think very clearly that the proponents of this legislation are trying to assure that people who are vulnerable and seeking care and support have full access to the full options before them. And there is no intention in this bill to force a Catholic hospital to provide any of those services. I thank you very much for your time and testimony here this evening. Thank you, Mr. Reynolds. Next on our list, we have Vlatsa Hakes. I may have just really missed.
Vlasta Hakes, you're good.
Welcome.
Thank you, Madam Chair and members of the committee. I appreciate all of your efforts today and listening to all the testimonies today. It was quite the day. I believe I'm the second to last one, so I'm going to try to be fairly quick here. But I just want to say thank you for the opportunity to testify in the support of SB 368, which concerns the plasma donor centers. And this bill would align the federal laws governing state source plasma centers with the state laws. We do strongly believe that and know that federal guidelines governing source plasma establish the highest standard of donor safety, and we really do stand behind these federal regulations. Grifols is a global healthcare company that has about 290 centers across the United States. We have about 45,000 donors that visit our centers every single day giving plasma, and we would love to come into Connecticut. We have centers in Massachusetts, Rhode Island, Pennsylvania, Maine. We have been trying to come into Connecticut. We've actually finished a facility. We have a plasma donor center that's built and ready to open in Stamford, Connecticut. But unfortunately, we have not been able to open it because we have not been able to find a physician that meets the Department of Health's regulations. We have been trying for over a year to identify a physician, and we have not found one in Connecticut who meets these regulations. So as a result, we have not been able to open. This center would be about a $5 million annual economic impact to the state, as well as hire anywhere from 35 to 50 people as it continues to grow. We know that there's just not enough physicians in the state. And given this limited number of physicians, we do believe that they are better serving in academic medical centers, community and hospital blood banks than working at a plasma donor center, which is a primarily automated process. And there's no blood banking activities or any direct transfusion that would need somebody with that sort of experience. So we again thank the committee for all your efforts on this, and we encourage the support of aligning with federal laws and being able to provide an environment for where plasma donation centers could open and operate in Connecticut, allowing people in Connecticut to be able to donate plasma and help save lives. Thank you very much for your time.
Thank you very much for staying with us for such a long day and addressing this issue once again, as Senator Anwar has said to some of the other folks who have been here on this issue. So we thank you for having us or for being with us today. Seeing no and hearing no questions, we are on to Mitzi Sky. Welcome.
Well, thank you for having me. I submitted a testimony, but I changed it somewhat during the course of the day. So good evening, Senator Anwar, Representative McCarthy Vehi, and distinguished members of the Public Health Committee. My name is Mitzi Sky. I'm a registered voter in Stamford, a poet, author, and advocate to drop the disorder and the transformation for a humane mental health system. I am here to testify in support of Senate Bill 370, peer-run respite centers. Many others have come before me who have shared their stories courageously, articulately, immaculately, and given statistics that I need not repeat as one of the last persons testifying. I will share a little of my story with you. I feel people have preconceived notions of hospital stays in general and believe that they are going to have a safe space or that their loved ones are going off to a safe place to get the help they need when having a mental health crisis. You've heard today that sometimes it doesn't work like that. It is possible to move through the life-changing upheaval that makes us question our existence without getting labeled and drugged. That is what I hoped for at 23 years old, but without the knowledge of the language of what I needed and the lack of support, I spent about 20 years trying to navigate a system that wasn't created to support a person who looks like me, whose ancestors were enslaved. The act of running away from slavery and seeking freedom was once labeled mental illness, and the name of it was drapetomania. Coming to America at 8 years old and not getting any education on what happened in Black history in America was devastating to my overall well-being, and I suffered dearly for that. We have people who are banning books and creating woke laws because they want to keep people ignorant and perpetuate the system of ignorance and suffering and lack of empathy and compassion for ourselves and each other. I had to learn about redlining, Black Wall Street, Jim Crow laws, white supremacy, caste systems, and racism the hard way before I could overcome the oppression in society that I internalized. I am fortunate that I connected back to my childhood's first memory where I learned about injustice before I knew about the world's injustices. I was able to speak up to the people in leadership who grew up on white supremacy and speak passionately about psychiatric oppression and do not have a clue about racial justice for the BIPOC population. I want to thank Jordan Fairchild at Keep the Promise Coalition for their vision of having infinity peer respites added to SB 370. I remember what my mental health crisis hospital stay looked like. I wasn't working to live. I was experiencing extreme poverty, struggling how to feed my children, going to therapy weekly, complying with psychotropic drugs, and in a very antagonistic relationship with my then husband. Another spell of feeling helpless and hopeless to accomplish my dreams. I needed a different place to be for a short time, and not having connections with family and friends, a mental hospital ward was the only place. The prescription for my pain was drugs and not hugs. I was allowed to be alone for a full day in bed. I was told I could no longer stay in my room on the second day. I was told to go to the community room and engage with people. I needed more time by myself emotionally, and then when I did not comply, I was told that the way out of the psychiatric hospital ward was to get the level system they assigned to me moved up. And to do that, I had to participate by hanging out in the community room and engage in activities. I felt threatened, and that was called treatment. So I complied. The levels moved up and I was released. There was nothing in the form of medical care during my stay that I needed a hospital ward, nothing. I did not understand the soul work I needed, nor did any of the medical staff. Ephraim Akiva said early today in his testimony that he considers his work holy work at the Afia Peer Respite by Wildflower Alliance, and I agree. Looking at my life experience as a soul's journey, I was able to emancipate myself from mental slavery and free my mind from thinking that someone with a degree who does not know themselves knows more about me than I know about myself. I have a lot of respect for those in provider roles who take the time to understand themselves before judging me. My spiritual work is getting to know myself. Sometimes revelations are painful but necessary to move forward. We need people to be seen, heard, and validated, to hold on to the hope and possibilities of living a wholehearted life. I am asking that you please pass Senate Bill 370 and create peer-run respites in Connecticut and support people experiencing a mental health crisis in the most humane and voluntary way possible. I appreciate this opportunity to speak and share with you about what peer-run respites in Connecticut would mean for the people experiencing mental health crisis, especially the Infinity community, the state budgets, and part of our bigger world to move forward with progress. Thank you.
Thank you very much, Ms. Sky, and thank you for taking the time to stay with us today and to share your story and your experience. I was very struck by what you said, that the prescription for your pain was drugs, not hugs. That was a powerful line among many of the powerful words that you just shared. So thank you for your support and for being here with us today.
Thank you for having me.
And hearing no questions, I want to thank everyone for today. Today's hearing was full of many heartfelt stories. And oh, okay, we actually maybe have one more person. All right, hang on, everyone. If you don't mind, I think we have one more person. Am I right? Okay, give us just a second, if you will. Okay, Elizabeth Traster. Are you there with us? Okay, so back to the thanks for everyone being here, and especially to those who took the time to testify before us to share their experiences and stories. Thank you, Senator Anwar, our ranking members, members of the committee, and especially the team behind the scenes who makes this happen. So we are adjourned. I hope you all have a wonderful evening. Safe travels.